So the first topic for today is approaches in endocrinology. And to chair today's first session, I would like to call upon stage Dr. Ajay Agarwal sir from New Delhi and Dr. Devashish Giri sir from Kolkata. And first speaker for today is Dr. P.K. Jabbar sir from Kochi. And the first topic is approach to a case of gynecomastia in an 11-year-old boy. Thank you.
Pointer. Pointer.
Good morning, everyone. I have the privilege to introduce Dr. P.K. Jabbar. He is Professor and Head Department of Endocrinology, Government Medical College, Trivandrum, Director and CEO, Indian Institute of Diabetes, Trivandrum, India. And he had 70 original papers and he has contributed various textbooks and is principal investigator of various trials. Now, off to Dr. Jabbar.
Good morning, everyone. I bring regards from Trivandrum, Kerala. Respected Chair Dr. Agarwal, Dr. Giri, my co-speakers, senior teachers, friends, colleagues, ladies and gentlemen. I'm extremely happy to come to this beautiful place again and to discuss a small but very clinically relevant topic in our endocrine practice. See, my topic is in a case-based approach to 11-year-old boy. And when I looked into the data and literature, definitions are slightly varying, very interesting. There are three definitions which I showed you here for your reference. And if you look into the hormonal regulation in the breast, you can see here there are stimulatory hormones and there are inhibitory hormones also. The inhibitory hormone mainly you can see what is written, there's a testosterone, and there are lot of hormones which includes estrogen, progesterone, IGF, leptins also, and which is responsible for the development of breast. So in short, this is what is happening. If the patient has got a gynecomastia, there is sizable amount of active tissue just opposite behind the areola, and we used to call it as gynecomastia. Such a common problem in our OP also. We have lot of patients with the gynecomastia of varied etiology, but I should admit that the commonest cause of gynecomastia in practice, wherever you practice, that is benign, and in this age group, pubertal gynecomastia. I don't want to say that, you should go investigate this patient thoroughly, which includes imaging, all those things. A good clinical examination will give the definite diagnosis in most of the situation. But one important message I wanted to convey here is, see, once in a blue moon, you can get problems also. So you should know how to approach a case of gynecomastia. Mainly, I'll be concentrating in the pubertal or adolescent type of gynecomastia. We have a patient, recent height spurt, which indicates patient is entering to puberty and started developing other secondary sexual characters also, is not taking any medication, including cosmetics. Now, a crucial question. See, is gynecomastia is pathological always? There are certain phases of our life where gynecomastia is physiological. Number one is neonate, I'm not discussing in detail, and of course, pubertal phase in the not geriatric, senile age group also you can get gynecomastia. So these are the situations where you get physiological. But I have a feeling that, any elderly individual coming with the gynecomastia, please look for any primary cause for gynecomastia. This is one neonatal gynecomastia. That's only because of the hormonal transfer from maternal compartment to fetal compartment. senile gynecomastia. There are many mechanisms postulated, but it's not that uncommon to get this type of gynecomastia in this age group. Probably around 50% of the senile age group, you'll get this type of gynecomastia. Nowadays, what's happening, like we are all using a lot of cosmetic preparation. There are a lot of oils, which is a beautification oil and all. All those situations also you get gynecomastia. Please remember all those things. By and large, these are the causes of gynecomastia. Gynecomastia happens only in 2 or 3 situations. Number one, either you have excess estrogen, or you have reduced levels of testosterone, or there is an alteration of estrogen and testosterone. These are the only 3 or 4 causes for gynecomastia. But mind you, in our clinical practice, most of the situations are mainly due to the disturbance in the ratio between estrogen and physical examination, what I want to tell you that there are 2 things you should examine thoroughly. Number one, good physical examination of breast. Look for proper breast tissue, that is number one. And any concerns like any inturations, very hard in consistency, lymph node, all those things not in, at least not in this patient, in certain individuals always you should look for. And very importantly for this type of patient, just look for your sexual maturity. If the testicular volume is okay, no asymmetry, no nodularity, you can relax. Probably you are dealing with a pubertal gynecomastia alone. Very important to have a good physical examination. This is the method by which you can, because one of the immediate differential diagnosis is fat or pseudogynecomastia. If you are palpating like this and if you are feeling a breast tissue, that is gynecomastia, very soft consistency, more in favor of a fat tissue, or you can call it as pseudogynecomastia. After good physical examination, 3rd point comes your laboratory evaluation. Laboratory evaluation, you should look for evidence of systemic disease, including your liver function, renal chemistry, Hormone investigations, you can start with the testosterone, LH and FSH, estradiol beta HCG, to rule out extreme or probably rare situations like HCG producing tumors. Thyroid function test, because hyperthyroidism is notorious to produce gynecomastia, so you should document thyroid function test. Having done all this investigation, you can categorize the patient with the algorithm. You can reasonably get a final diagnosis of idiopathic or pubertal gynecomastia. All investigations should be normal also. Now, coming to our patient age is 11 years, his thyroid function test is normal, testosterone documented as almost normal, FSH, LH and HCG, nothing contributing or nothing abnormal in this patient. Prolactin is also documented as normal, and estradiol is very minimally elevated, that is accepted. So, by looking into the algorithm again, see, all these investigations are normal. That indicates in this patient, mostly we are dealing with the pubertal or adolescent type of gynecomastia. No concerns at all in this patient. What about the role of imaging? See, now we are all doing imaging to rule out the possibility of pseudo-gynecomastia. But see, mammogram, of course, a very sensitive investigation. People are not doing. I think that's not needed also. But in certain individuals, yes, you can ask for all those things. Now, mammogram, there are 3 types of abnormality. You can see nodular gynecomastia, chronic dendritic type of gynecomastia, and diffuse glandular gynecomastia. You can see here the changes, nodular patterns very clearly seen here, diffuse glandular gynecomastia, and late fibrotic stage. There is the importance also for looking for all those things. If the patient's gynecomastia is a recent onset, defined as less than 6 months or 1 year, the response to medical treatment is good. And if the patient entering to the stage of fibrotic stage, the response is not good, probably you won't get any improvement at all. There are 2 data which they looked into the reduction of gynecomastia to a tune of 2.5 centimeter if the patient has got a recent onset disease and painful gynecomastia. That is more in favor of a good responders to medical treatment. Ultrasonogram, mainly to differentiate, but very interestingly, probably this is misleading. Benign lesions can imitate malignant lesion and is possible, so you have to be very careful in interpreting this ultrasonogram or sonogram picture. Other investigations, now people are doing testicular ultrasound to assess the testicular volume. That's not needed. Other imaging methods like CT and MRI, if you have a suspicion of HCG producing tumors. And the testicular tissue biopsy also, it's not routinely indicated for all these patients. If you have suspicion, yes, you can go for tissue biopsy. Mind you, the yield is also not very good. So we have to be very careful if you are interpreting this tissue biopsy. Now, finally, we came to a conclusion that we are dealing with a pubertal gynecomastia. Usually, the natural course of pubertal gynecomastia regression by the age of definitely before 17 years or before 18 years. And sometimes good percentage of cases you can get persistent gynecomastia. And this is very interesting data published in the European journal, which showed, see, in adult medicine, if you get gynecomastia, that is more in favor of a persistent gynecomastia. Pubertal gynecomastia happens and subsequently the patient will retain in that phase. That is the commonest cause. Now I will discuss, the first case was a pubertal gynecomastia. No need of extensive investigation. Clinical evaluation is more than enough, and you can go for basic investigation to clean the diagnosis, keep under follow-up. Whether to treat or not these type of patients, there are controversies. There is no approved drug for pubertal gynecomastia. People are using various drugs, including your tamoxifen, clomiphene, roloxifene. Lot of drugs have been tried with variable success. Now, coming to my second case, little tricky case. We have a patient born of non-consanguineous marriage, no history of ambiguity here, no hypospadiasis, undescended testis, and gross motor change. There was a delay for walking. We do not know what is the cause of this delay, whatever. Language, all other parameters were normal. Noted breast development from or at the age of 5 years. Please remember, pubertal gynecomastia never occurs. And less than 5 years, probably less than 8 years, we have to be very careful. And genital, as per the history given by the patient and relatives, there is no significant change. Currently, patient is the tallest in the class also. That indicates some sort of acceleration of growth is happening, and no family history of gynecomastia, short stature or macrosomia. There are certain conditions which can present like this. That's the reason I'm just giving the negative history also. And coming to the chronological age of 80, see the patient has got acceleration of bone age also, and the testicular volume is bilateral 4 ml. There is no disparity in the size also. This is the picture, just like a female breast. So this patient is having gross gynecomastia. So what could be the differential diagnosis in this patient? We have to be very careful because patient age is only 5 years. So such situations, our responsibility to look for any primary cause for this gynecomastia. These are the few differential diagnoses. Is it a estrogen secreting tumor? This could be from adrenal or could be from testes. Is it because of exposure to estrogen? Possible, but not to this extent. So we thought probably that also it's unlikely. And there is a rare situation known as aromatase excess syndrome. We were just thinking to entertain this diagnostic possibility. We thought about the looking into the literature. There is another situation, very rare situation, Loeys-Dietz syndrome. That's because of chronic liver disease producing hyperestrogenemia, and which is eventually producing this type of clinical picture. That's also possible, even this very rare situation. When you look into the routine evaluation, it was not very contributing. The hormonal evaluations, mild elevation of estradiol, LH and FSH prepubertal, and DHEAS. We did all this investigation for this patient because we want to clinch the proper diagnosis in this patient. Androstenedione and 70-hydroxy also documented as normal, and karyotype is also normal, XY. Imaging also we did for this patient because I told you we were searching for a primary cause for gynecomastia. Imaging was not contributory for this patient, and eventually we thought about this possibility of aromatase excess syndrome. We know that is a very rare situation, but still we thought about this diagnostic possibility. These are the diagnostic criteria. Diagnostic criteria, on the one side you can see bilateral Tanner stage, more than 2 gynecomastia. Onset of gynecomastia, please remember young age group, excludes syndromic also. Reasonably we did that also. And autosomal dom, we did not get the family history of like this. But still, you have sufficient evidence to entertain a diagnostic possibility of aromatase excess syndrome. And the definite diagnosis can be made only with the genetic analysis. Unfortunately, we lost the follow-up of this patient, so we could not do anything. We sent the patient to plastic surgery department for corrective surgery. And these are the situations always you should consider and rule out these possibilities before making a diagnosis of aromatase excess syndrome. Now, my points are very simple. These cases are very rare. All these cases are very rare. Don't entertain all those diagnostic possibility in gynecomastia, but you should suspect problems or pathological gynecomastia in certain situations. These are the messages I want to convey here. Occurrence of gynecomastia outside normal age group, and prepubertal rapid progression also you should be very careful. Very huge breast, you should consider a pathological type of gynecomastia. And there are certain controversies also centered with gynecomastia. Imaging, people may think that imaging is needed, imaging is not needed, some sort of controversies are going on, and all these biochemical investigation, whether to go for all this investigation or not, and treatment also. So these are the recommendation by Andrology Journal. What is written in whatever we discuss, see if the patient has got a clinical picture suggestive of a pubertal gynecomastia, you stop there. And investigation should be limited. In extensive investigation is needed in case where you are suspecting pathological gynecomastia. And medical treatment you can offer probably for 6 months to 1 year, and after 1 year, it's unlikely to get any good improvement. We have 2 more slides here. All these situations are benign, pubertal gynecomastia, but certain situations also can come up in your practice. Please remember, testicular tumors, androgen or feminizing androgen tumors, all these situations can come up with the gynecomastia, and certain syndromes also. So good clinical examination is also very important to cleanse and not to miss any diagnosis of concern. And what are the treatment modalities? You have the treatment modalities are observation. That's the best treatment modality for pubertal. And medical treatment, we already discussed. Surgical, most of the situations, patients are going for surgery for cosmetic reason. My take-home messages are very simple. Gynecomastia is a very common situation. The commonest cause is pubertal gynecomastia. Investigation should be limited, and medical management can be given for a short time, especially if the patient has got a recent onset with pain. Usually, this patient will respond. That's all. These are the reference for me. And I bring the regards from Medical College Trivandrum, and thank you so much for the kind attention. I'm signing off.
It was a very nice presentation. Can I ask you something?
Please, sir.
Other than cosmetic reason, is there an indication for surgery? Because a lot of patients who come to us 15, 16, they always go, no, do something for me. Even we tell them, yeah, just
No.
one question.
We'll attend to at least one now.
Just one question. And is there any other indication other than cosmetic reasons? Because
No, if it is a very small one, see, mostly what will happen, at least in our hospital, is a government hospital, where people will come from plastic surgery department. Okay, plastic surgery and parents and patients, they are having lot of concerns. Most of the cases we are sending patients for surgeries, cosmetic and social issues. Okay, medical indications are very scanty.
one question from the audience, just because we are short of time. Later on?
Okay, thank you.
Thank you, Dr. Jabbar. And
Thank you, sir.
yeah,
Our next topic is I would like to request Dr. Vijay Sarthi, sir, to come up on the stage. The next topic is approach to a case of ambiguous genitalia with palpable gonads in a child. Thank you.
yeah. Welcome, Dr. Vijay Sarathi, Professor and Head, Department of Endocrinology, Bidoi Institute, Bangalore. And he has many achievements, Best Resident Doctor in KEM Hospital, Mumbai, Young Investigator Award, Vellore 2013, A.V. Gandhi Award 2012, Editor Cape News, 120 publications, and contributed to ICMR and ISP guidelines. Welcome, sir.
Yeah, thank you so much for the kind introduction. At the outset, I would like to thank the organizing committee of ESICON 2025 for this opportunity. So let me discuss briefly on how to approach a case of atypical genitalia and palpable gonads. So here we have a 2-month-old infant who presented with perineoscrotal hypospadias. Phallic length is 3.5 centimeter. Testicular volume is 1 cc, bilateral. Soft in consistency with homogeneous smooth surface. Ultrasound revealed no Mullerian structures. So what is that we are dealing with? So very likely we are dealing with the 46XY DST. That's what we always think. But other results are going to be so straightforward. When the karyotyping is done, it's a 46XX. So what's the diagnosis? Very likely it is a 46XX testicular DST, though rarely could also be a 46XX ovotesticular DST, looking at the location of urethral opening. But it's also true that even 46XX testicular DST can have hypospadias in a few cases. So although we always say that the palpable gonads usually indicate a 46XY DST, it could rarely be a 46XX testicular DST as well. Then how do we proceed with this case? What are the most common cause of 46XX testicular DST? The most common cause is typically an SRY translocation. So first investigation we should order in this scenario is the genetic testing for SRY by FISH. If at all, if the FISH for SRY turns negative, yes, then we need to also order an exome sequencing to look for the variants and genes such as RSPO1 or SOX9, which is typically a duplication. So if you look at probably again one more, the belief we have is that the 46XX DSD is the most common cause of DSD. But if you look at this data, which has summarized all the DSD cohorts, so you can now see that the predominance is actually the 46XY DSD, and 46XX DSD is no more the most common cause of DSD. So why do we need to attain at an accurate diagnosis at 46XY DSD? It's for multiple reasons. The most important is on decision making for sex of rearing, which also in turn decides on the timing and type of surgery and also the type of hormonal therapy. In addition, it's also important to predict the malignancy risk as well as the fertility potential. So then what are the tools to attain an accurate diagnosis in 46XY DSD patients? Of course, as I told earlier, we can always look at the gonads are present or not. We can look at the presence or absence of uterus by an ultrasound. We can look at the AMH, which would also be a marker of Sertoli cell function. We can look at the gonadotropins. We can look at the steroid hormones and ratios, and finally the genetic testing. But all these are perfect, or each of them have issues. Let's move on to another case. Here we have a 24-year-old initially rated as female, because the patient had atypical genitalia, which were mimicking apparent female to start with. But however, by the age of 10, the parents noticed that there is an increasing size of the gonad, which was not noticed earlier, and also the increasing in the size of the phallus, all followed by deepening of the voice. The patient developed erections as well as ejaculation at 13 years of age, and his identity was revealed to be male at the age of 13 years. So the evaluation revealed a P5 with a no gynecomastia, but SPL was short, single perineal opening, testicular volume of 6 on right and 10 on left. So what is the most likely diagnosis? Again, probably we may think it may be a 5-alpha reductase deficiency or a 17-beta HCG3, because the patient is going for a gender role change, and there was a virilization very well at around puberty. But we look at the evaluation, yes, 46XY, ultrasound is not revealing any Mullerian structures. They were expected looking at the testicular size. If you look at the gonadotropins, FSH is on a slightly elevated but LH normal. Testo is quite good, 2.45. DHT is also good. In fact, androstenedione is 3.2, which was slightly pointing towards the possibility of a 17-beta HSD3. But do we think it's 17-beta HSD3? Because when the genetics was done, it was turned out to be an SF1. So, and it was just a falsely elevated ratio. So the whole game changes here. So whatever we thought based on our clinical and hormonal phenotype is not matching with the genetic diagnosis. So what we understand here is that typically when we think that bilateral gonads may be palpable, it rules out a non-dysgenetic DSD. It's no more true. Quite a good number of patients with dysgenesis may also have bilateral palpable gonads, often in the scrotum too. So of course, this patient was managed with a male gender reassignment, underwent masculinizing genitoplasty with staged hypospadias. So as I mentioned in my previous slide, so the palpable gonads usually rule out GD, but as I demonstrated in the previous case, SF1, almost 82% of the patients will have palpable gonads. It's not only SF1, even in patients with other partial gonadal dysgenesis like a WT1, also patients will have palpable gonads. On the other hand, absence of gonads or absence of palpable gonads do not always mean that it is dysgenesis, because majority of the patients with testosterone biocentric defect also will have a bilateral cryptorchidism, often in the intra-abdominal position. In 5% of these patients, even the imaging modalities often fail to localize the gonads. So it's good tool to use, but again going wrong in multiple scenarios. Then talk about the uterus, whether the presence or absence of Mullerian structures makes a difference for reaching out to diagnosis. Yes, the presence of a Mullerian structures usually favors GD, but again, as you can see here in SF1 patients, 80% will have absent Mullerian structures. So it's also true for other partial gonadal dysgenesis. So again, we are going wrong over there. So on the other hand, our hypersensitive sonologists often report a pseudo-uterus in patients with biosynthetic defects as well as AIS or even 5-alpha reductase deficiency. So it's very, very important that we are aware to interpret the sonology reports with caution, especially when it's not matching with the clinical phenotype. A third important marker probably we can think of is an AMH. Yes, it's very well available nowadays, and definitely it's a marker of Sertoli cell function. It usually corroborates with the presence or absence of vitreous, but in patients with partial corneal dysgenesis, a very good point is that it's a better marker than sonologic features. As you can see here in SF1, only 17% of the patients had a normal AMH, whereas all others had a relatively lower AMH, saying that this is a better marker of GD to differentiate it from other 46XY DST. On the other hand, we should also be aware very rarely AMH could be low in non-degenerative GD as well, but it's a very small proportion. Let's move on to gonadotropins. Do they really help us to know what is the exact type of XY DSD I'm dealing with? So if you look at the pre-puberty data, this is data from KEM. As you can see here, FSH may be very helpful in a very small proportion of patients in whom it may be markedly elevated, whereas the LH and testo are all around and they really don't differentiate between the dysgenesis versus other causes, or even among the causes of biosynthetic defects or action defects, there is no differentiation. Another important point probably we need to remember while evaluating an infant with 46XY DST is that, so though we expect the highest levels of testosterone in patients with complete androgen syndrome, that is not the case during mini-puberty because mini-puberty is absent in them. Indeed, they may exhibit much lower levels of testosterone compared to partial androgen insensitivity syndrome. So there's just a word of caution not to miss a case of CIS just because testosterone levels were normal during the infancy. Let's move on to another cohort of patients, those who were pubertal and were rated as males with a karyotype of 46XY. How does gonadotropins perform in this particular group? Again, FSH is slightly helpful, but as the LH and testosterone are off, LH is of not great help. However, testosterone shows some promise here. A value of more than 3 nanogram per ml is more in favor of a androgen insensitivity defect or a phi alpha reductase deficiency. Moving on to pubertal females who have a 46XY karyotype, here probably we have a greater utility of the hormones. So as you can see here, FSH is clearly elevated in all cases of gonadal dysgenesis, even in patients with the proximal biosynthetic defects, and tries to differentiate them from the phi alpha reductase deficiency and androgen insensitivity syndrome. On the other hand, even testo also has a good utility when it's more than 4 nanogram per ml. It's more so in favor of a androgen insensitivity or a phi alpha reductase deficiency. A further differentiation among these two groups can be done with the LH, where LH is typically less than 10 in all phi alpha reductase deficiency patients compared to majority or most of the androgen insensitivity syndrome, androgen insensitivity, where LH was elevated. The LH levels not only differentiate phi alpha from the PAIS, but also differentiates it from most of the gonadal dysgenesis as well as the synthetic defects. Let's now move on to a very interesting part of the discussion, probably which we all believe as one of the most reliable markers of looking at the etiology, that is our ratios. Let's start with the testosterone to androgen ratio. We know that less than 0.8 indicates it's a 17 beta HSC3 deficiency, but we look at the data from KEM. So only 1 of the 5 patients with 17 beta HSC3 had a ratio of less than 0.8. Especially I'm talking about the pre-pubertal children where the values were measured after an HCG stimulation. So whereas, however, the specificity was good, it was not noted in anybody else. But I can't miss like almost 80% of the patients when I'm using a ratio. So that's why we escalated the ratio cutoff to 1.7, where I could detect 80% of the patients without much of compromisation of the specificity. On the other hand, when we look at the T by DHC ratio of more than 20, again, here it has a good sensitivity. Almost 82% got detected with the phi alpha reductase deficiency when I use the ratio, but the specificity is still low even with a ratio of 20, where it's only around 66%. But there are many studies which suggest a sensitive cutoff of 10, but if you use a cutoff of 10, our sensitivity may increase to 95%, but the specificity is going to be even worse, with almost like only around 30%. It's not only in the KEM data, there were several studies way back from 1982, people have shown that the specificity of the T by DHT is significantly lower, especially in patients with androgen insipidase syndrome, because phi alpha reductase activity also requires the androgen action. Even a recent study from AIIMS New Delhi has also demonstrated that the T by DHT ratio, whether you take a cutoff of 10 or a cutoff of 20, has a very low specificity. So that's why don't just go by T by DHT ratio to make a diagnosis of phi alpha reductase deficiency. So always seek a genetic help, because SRD5A2 is a very small gene, and nowadays even if you want to go for a clinical exome also, the costs are becoming relatively affordable. So it's always good to look at genetic diagnosis for all suspected cases of SRD5A2, because even the yield is very high in them. So whenever we talk about these ratios are going wrong, we always blame the immunoassays. So is it always true? Are our LCMS values are going to be perfect? Look at this case. So here, of course, this was the old steroid panel 3 from Dr. Lalpath lab, which is not available nowadays. But when we are using this also, where dihydrotestosterone was performed with a testosterone of 2.32, which is a good testosterone to have a ratio, the ratio was 3.9. We almost excluded the diagnosis of phi alpha reductase deficiency. But to our surprise, when the genetics was done, this actually turned out to be an SRD5A2. So it's not about just the assay types which is actually having an issue. Probably these problems are across all types of assays. Because it's, whether it's a LCMS or it's an immunoassay, the DHT usually exists in picogram per ml concentrations. Any assay will have a problem with the standardization and accurate estimation. With this, probably we make a path for genetics and the role of genetics in the evaluation of 46XY DSD. So if at all, there are several methods of genetic tests, which could be a karyotype, which could be FISH, which could be microarray, or it could be methods of sequencing. Karyotype can detect only the defects which are larger than 5 to 10 megabases, while as FISH can detect so even as low as 50 kilobases difference, whereas microarray is good enough to pick up changes which are larger than 10 kilobase, whereas as low as 1 base pair defects can be identified by sequencing. The sequencing could be Sanger sequencing or an NGS. So Sanger sequencing, we always think that probably may be cheaper, but the problem in India is that hardly any labs are doing a Sanger sequencing. Even if you have to choose a single gene also, but which has 3 or more exons, it's going to be costlier than a clinical exome sequencing. So probably in most of the cases, we are resorting now to clinical exome sequencing, probably because of the wider availability as well as relatively affordability with a large coverage of genes. So what are these NGS we have? So we may have a targeted gene panel where we have a set of genes associated with a typical phenotype, and we analyze those genes. It may be 60 genes or 100 genes known to be associated with the 46XY DSD. Only those genes can be analyzed, and when we are running, we ensure or try to ensure that they are read in a depth, so that I know that I'm not missing any variants. As and when I increase the width of coverage, so I'm losing the depth. For example, I move from NGS to clinical exome, my coverage is less. The number of genes may increase, but the depth of coverage is less. So similarly, from clinical exome to whole exome. So that's why if you have a known phenotype, always choose the gene panel or a clinical exome rather than choosing a whole exome. But you don't have a known phenotype where you are not very sure about one or few of the genes to be coming out from the analysis, then it's a good idea to go for a whole exome sequencing. What are the advantages of whole exome sequencing? Of course, when compared to clinical exome, they may give a 5 to 10% of additional yield. It may also give us detection of new genes, as I've listed here. But as I told earlier, whole exome will detect more incidental findings, and it requires more validation to associate with the phenotype, because you're also identifying some things in the new genes. So for that, it's always required to send a trio sample. Obviously, the cost will go up when I send a trio sample. So as I told earlier also, it may be helping to pick up more, but it's also compromising the depth of analysis, where I may miss few variants in the commonly known genes. So coming back to the genetic results of the KEM cohort, in the 150 patients we had, so almost 52% of the patients had an identifiable genetic abnormality with attaining a molecular diagnosis. Phi alpha reductase deficiency was the most common with 17%, whereas androgen insufficiency syndrome was the second most common, accounting for 10% of the total cases. So again, if you look at the 46XY DSD cohorts analyzed by NGS, so the common causes vary. In some centers, it may be a 46XY gonadal dysgenesis. In some center, it may be phi alpha, and in some centers, so it may be AIS. But if I take a molecular diagnosis in most of the centers from India, nowadays it is actually the phi alpha reductase deficiency. But of course, we go by phenotype because we have a lot of patients who don't get a genetic diagnosis with a PIS phenotype. The most common phenotypic diagnosis will be PIS, but most common genetic diagnosis will be SRD5A2, that is phi alpha reductase deficiency. So another interesting study which I would like to discuss here is from Brazil. In fact, they have showed a very good genetic yield in patients who have a sex differentiation defect. It may be phi alpha reductase deficiency, which may be AIS, but let me tell here that AIS they have defined with a very stringent cutoff of elevated testosterone as well as elevated LH. When we use such stringent cutoff, definitely we are going to get a higher genetic yield. But the typical exclusion of T by A and D by DHT, and then we label everyone as PIS type 2. So in fact, the yield is going to be lower. The second surprising finding we had here is that the genetic yield is very low in patients with dysgenesis, much lower in patients with complete gonadal dysgenesis, where I usually expect a definitive defect. So what do we do then? How are we going to achieve a genetic diagnosis in these patients who have a large proportion of patients with negative genetics? Maybe worth looking at the copy number variation analysis. That typically works out well when we have a syndromic child with a gonadal dysgenesis, as you can see in the study, where 25% of the patients may have a genetic diagnosis. But however, when you're doing a CNV analysis for somebody who does not have a syndromic feature, again the genetic yield is going to be very low. It's also true for our KEM cohort, where probably out of the 45 patients with the GD phenotype, only 15 had a genetic diagnosis, and there was no genetic diagnosis in 30 patients. In fact, including familial cases, where I was expecting a definite genetic diagnosis, we could not identify an underlying genetic cause. So even when we did a SNP microarray to pick up the copy number variations, only 1 out of the 30 had an underlying genetic diagnosis, whereas in 29, we could not do any genetic diagnosis. So again, another group of diseases where probably genetic yield is less is actually where we could not classify them as a specific etiology, where the yield is only around 32. So what are they? Probably they're all a kind of a PAS type 2, or some maybe even a partial variants of gonadal dysgenesis. One clue to PAS type 2 is actually if the patient has an IUGR, so very, very likely that we have a PAS type 2, especially when there is a negative genetic diagnosis. Why do we need to differentiate them from PAS type 1? Because they have a better fertility potential, they have a less risk of gynecomastia, and they also have better potential for a sexual function. So it's very important to differentiate type 2 from type 1. Again, looking at this Brazilian study, what I mentioned earlier, if you have used stringent protocols for classification, there will be no reclassification from defects of androgen secretion or action or from gonadal dysgenesis, but definitely from the group of unclassified diseases. So from there, genetic helps significantly, where almost around 15% will be reclassified as defects in androgen action or synthesis, whereas another 15% will be reclassified as gonadal dysgenesis. So with this, so probably how do we approach a case of DSD at our center? So anybody comes, of course, even if they have a palpable gonads, always do a karyotyping to confirm it's an XX or XY. If it's a chromosomal DSD, then we know probably sometimes even it may come as a chimerism, though rarely to have bilateral O testes, but typically if at all, if I'm getting, I will get an XX or an XY. Then we may go for a genetic diagnosis directly, but even if I get a variant on a genetic diagnosis, I always want the phenotype to correlate with it. And one major feature of phenotype for me is the hormonal phenotype. So if there are syndromic features, I always go with the microarray even without a exome sequencing. But if it is a non-chromosomal, non-sex chromosomal or non-syndromic DSD, go for a genetic diagnosis, so hormonal evaluation thoroughly, both basal and stimulated, and then correlate with the genetic diagnosis, whatever you have got. So thank you so much for the patient hearing.
Thank you, Dr. Sharathi, for your wonderful talk on the most difficult topic in endocrinology. And
Let's go to the next topic. I invite Dr. Nisha Bhavani. She is Professor of Endocrinology, Amrita Institute of Medical Sciences, Kochi. She has 56 publications. She is President, Endocrine Society of India, Kerala branch. And she has various achievements like co-editor of ESI Protocol 2025, Executive Committee member in the past of ESI, PSS, Sandoz. And she has got Best Reviewer Award from IGEM and Best Outgoing Student from GMCS Trivandrum, 1996. So over to Dr. Nisha.
Good morning. A very warm welcome from the Department of Endocrinology, Amrita Institute of Medical Sciences. At the outset, let me thank the organizers of ESICON 2025 for having invited me to talk to you on approach to a one-year-old girl with isolated breast enlargement. This is I have no conflicts of interest. So we'll start with a case with a 9-month-old child who came to us with bilateral breast enlargement. She was referred to us for evaluation. It was noticed around 6 months back. It was not progressive and there was no vaginal bleeding. The child was otherwise normal, active, full-time normal delivery, normal development and growth. The length and the anthropometry were within the centiles for the mid-parental height. The diameter of the breast was 18 mm on the right and 14 mm on the left. The vagina was red and glistening, which indicated that it was not estrogenized. There was no pubic or axillary hair, and there were no neurocutaneous markers or asymmetry to suggest a McCune Albright, or there were no syndromic features. So 2 endos saw this patient. One endocrinologist ordered a bone age, LHFSH, estradiol, thyroid function, and an ultrasound pelvis. The second endocrinologist just reassured and asked the baby to come after 3 months. So who is right here? We'll decide at the end of the talk. So this is what is called premature thelarchy. That is an isolated breast enlargement before 8 years of age, which does not progress during follow-up to central precocious puberty. That's the definition of premature thelarchy or isolated breast enlargement. Now this is a good method of assessing premature thelarchy. You can see, can I have the pointer please? So you see the normal pubertal development starting at around, there is a wide variation in the normal development. This is a normal development where thelarchy, adrenarchy and growth spurt and the menarche will start. Whereas in isolated premature thelarchy, the thelarchy alone starts earlier, the rest of the things will remain in the normal range. Whereas a precocious puberty, everything happens early. So this is from the Australian Journal of General Practitioners guideline for assessing premature thelarchy. Now, all newborns have breasts because of the influence of the maternal estrogen and progesterone. It varies from 4 to 18 mm, but in premature thelarchy, it can go up to 20 mm. The prevalence is reported to be as low as 0.16% to 4.2% in different studies in girls less than 4 years. 60 to 85% of the premature thelarchy occurs less than 2 years, and it regresses over the next 6 months to 6 years. Rarely progresses to CPP, especially if the onset is less than 2 years. So isolated breast enlargement less than 2 years is almost always benign. It is the most common pubertal disorder that we encounter, but it is almost always benign when it is isolated. Regression is less common if the onset is after 2 years, and breasts are typically tanner stage 2 if unilateral, but occasionally stage 3 when it is bilateral. So what is the etiology? The etiology is the hypersensitivity of the breast to the activated HPG axis of mini-puberty. There will be some follicular development of the ovaries, and these follicles will produce estrogen. And FSH also stimulates inhibin B, which has got a paracrine effect on estradiol production. But why some breasts respond to this estrogen, nobody knows. Why some don't respond, nobody knows. There are other organic causes which can present as breast enlargement, but usually in association with other signs of puberty. which can be more sinister causes like an intracranial cause, hypothalamic lesions. Hamartomas are very notorious to present just like premature thelarchy, but usually it is associated with other signs. Gliomas, HIEs, peripheral causes, ovarian cyst, isolated ovarian cyst, or those associated with McCune Albright can present with breast enlargement, and sometimes isolated breast enlargement also. Primary hypothyroidism and all the other causes of central precocious puberty can present with breast enlargement, but usually there will be other causes. The Pallister Hall, Kabuki syndrome, Rubinstein-Thiebaud syndrome, all those syndromic causes, and the genetic syndromes we all know, inactivating mutations of MKRN3, DLK1, which are paternally inherited, and the activating mutation of, opposite KIS1 and KIS1 receptor genes can produce this premature thelarchy. Exogenous causes, of course, estrogen exposure, especially when we have estrogen patches available in India. The estrogen gels are available outside. So if the caretaker is using estrogen gel, that can be a cause, and also all the environmental disruptors. Our phenol is also implicated in production of this premature thelarchy. So all these should be inquired into when a child comes with isolated breast enlargement. So what percentage, our concern when we see a child with premature thelarchy is the risk of progression to CPP or central precocious puberty. Now various studies have quoted various percentages of progression. There is one study of 67 patients where 20 out of the 67 progressed to CPP. But the problem with this study is that it was defined by increase in Tanner stage by 1 and growth velocity by 1 SDS. That was their definition of CPP. That is why the percentage of progression was 29%. Another study, only 9 out of 450 children who were followed up for 6 years went on to develop precocious puberty, that is 2%, and 3 had hypothalamic hamartoma, 3 had peripheral precocious puberty, but all these kids, they had onset more than 1 year. And in another study by Kalpovitz et al., none progressed. Of 1,000 patients they were following up, none progressed to CPP when it is an isolated breast enlargement less than 2 years of age. So all these will reassure us that the percentage of progression to CPP is less, especially when the onset is less than 2 years. Now how do you assess whether it is CPP or premature thelarchy? It is by the progression of pubertal changes and by accelerated growth velocity, advancing bone age, a GNRS stimulation test we are often prompted to do, and a pelvic ultrasound. Are we supposed to do all this in a child who is presenting with premature thelarchy? The GNRS stimulation, we'll deal with this GNRS stimulation test, which has the most robust data that it need not be done in a case of isolated premature thelarchy. It is best avoided. We'll see 2 major studies. So unless there is rapid growth acceleration or rapidly progressive pubertal changes, these GNRS stimulation tests should be avoided in a patient who is presenting with isolated breast enlargement in less than 2 years of age, because it overlaps between normal and abnormal. So this is the previous study which I was referring of 450 patients who was followed up, and 353 were monitored and followed up. No endocrine investigations were done. 97 had endocrine imaging and assessment, of which 9 had central precocious puberty, 3 had peripheral precocious puberty, and this central precocious puberty had hamartomas. But if you see the LH and the LH peak there, the LH peak was more than 5 in 36% of premature thelarchy, whereas it was there in 100% of CPP. So there is a lot of overlap between premature thelarchy and central precocious puberty, and the LH-FSH ratio more than 1 was present only in 66% of the CPP. The only things which used to differentiate, which helped in differentiate the CPP from IPT, isolated premature thelarchy, was uterus more than 34 mm and a basal LH more than 0.2%. It had the best differentiating power for differentiating these two, but again there are many overlaps which occur, which we can see in the next paper. So this is girls with premature thelarchy younger than 3 years may have stimulated LH greater than 10 IU per liter. So that is this is about 30 isolated premature thelarchy patients. You see the basal LH, peak LH, basal FSH, peak FSH, and the LH-FSH ratio. All we cannot differentiate between isolated premature thelarchy and CPP in many of these. You see the peak LH, you see it is more 5 to 10, and some it has gone up to 25. This is all proven premature thelarchy patients alone. The basal FSH is usually high, peak FSH usually high in premature thelarchy, And this most important thing which helped differentiating this was LH-FSH ratio less than 0.43, which is almost always diagnostic of premature thelarchy. So can abdominal imaging differentiate between CPP and premature thelarchy? Again, the answer is usually no. This is a meta-analysis of many studies which was published recently. The conclusion is that the pelvic ultrasound has a limited role in the diagnosis of CPP in early stages, as no properly validated cutoffs exist for all these zonological features. So different studies give different cutoffs for all these things. We can differentiate. If it is very clear, we can suggest this is an infantile uterus where the fundus is smaller than the cervix is larger and the fundus is smaller, as opposed to the adult uterus where the fundus is larger and the cervix is smaller. And this is the ovaries which you cannot differentiate. This is a neonatal ovary, this is a prepubertal ovary, and this is a pubertal ovary. We cannot differentiate between these. Follicles can exist in everywhere because of the mini puberty. But where it helps is that there can be a cyst which is sitting there secreting an autonomous estrogen secretion. So that is where the ultrasound pelvis help. If suppose there's a cyst there and you are going to miss it, then you are going to land up in trouble. And this is a non-invasive investigation. So maybe you can do this ultrasound pelvis. What about endometrium? This is a neonate whose endometrial stripe is seen. So an endometrium, previously endometrium used to be a marker of puberty, but endometrium can be seen even in infants and neonates, but a thick endometrium is usually suggestive of estrogenization. So this is a meta-analysis of 1,977 children with, for which ultrasound was done to differentiate between premature thelarchy and CPP. The uterine length, the cutoff given was 3.2 centimeter, which predicted a positive likelihood ratio of 4.56 and a negative likelihood ratio of 0.26 to differentiate between CPP and BT. All the other factors, the difference was only between 1 to 1.5 units, so it could not differentiate. So it is just complementary in the diagnostic workup, especially when we are seeing a ovarian cyst there producing premature thelarchy. So coming to the clinical assessment, it is always history and physical examination, breast Tanner stage, and the diameter of the breast tissue, because that's an objective way of following up the patient, the diameter of the breast tissue. The length or the height of the baby should be followed up and assessed for additional Tanner pubertal stages. And assess for red flag signs of going into CPP, that is again the additional signs of abnormal pubertal development for chronological age, rapid crossing of sendiles out of keeping with the family pattern, height more than 2 to 2.5 standard deviation above the mean, and strong family history of early or precocious puberty. So this, any of these red flag signs come up, then you can investigate. Otherwise, you can just follow up the child. So no additional hormonal studies and assessments are needed if there is a stable or a regressing breast development over 12 months. Height sendiles are following the expected sendiles. No additional signs of pubertal development for chronological age occurs, and it typically indicates benign isolated premature thelarchy. There are some newer biomarkers for CPP versus premature thelarchy. The GNRS stimulated IGF-1 and IGF-BP3, which seems to be higher in central precocious puberty versus premature thelarchy. AMH, again, it suppresses puberty, so the AMH levels are highest in healthy girls, which is much more, who have higher values than premature thelarchy, again who have higher values than central precocious puberty. And there are a lot of other markers which are coming up to differentiate between CPP and PT, that is leptin, orexin, kisspeptin, neurokinin, irisin and all, but all still in research studies, none as available practically. So emotional well-being of the child, especially if the child is little older, should be taken into account, and the parental anxiety should be allayed. So the objective measures of emotional well-being like the RCAT score and the PETS-QL are abnormal in children with premature thelarchy. So that should be taken into account when you see a patient. Now back to the case, this child was followed up from 9 months till to 3 years of age. The height was following the sendiles. There was no additional pubertal signs. Nothing was done for the baby. The breast gradually subsided by 2.5 years of age, and the baby was discharged from follow-up. They will have usually a normal final adult health and a normal age of puberty. Now, this is in sharp contrast to another case who came to us, a 9-month-old baby, similarly came with breast development, but noticed 3 months back, but then baby had vaginal spotting. Otherwise, the baby was normal, the height was higher, the breast was Tanner stage 3 with a diameter of 18 mm, vagina was estrogenized, there was no pubic or axillary hair, the LHFSH were clearly pubertal, the stimulated LHFSH was also very high, and the uterus was clearly pubertal. So MRI showed a hypothalamic hamartoma there, and this baby was treated with leuprolide from 9 months of age till 12 years of age, and this baby attained a final adult height of 154 centimeter consistent with mid-parental height. So these are two clear-cut cases, but then we have always cases which come in between, which is like an atypical or an exaggerated thelarchy, where usually the onset is between 5 to 7 years, definitely after 3 years. That is stage 2 or 3 breast, cyclical or progressive, may be associated with accelerated growth, adrenarche or advanced bone age, especially when the age of onset of thelarchy is after 3 years. There's a higher chance of progressing to CPP, 21 to 36%. They will have usually normal final adult height, but slightly early menarche. So this is our AIMS data unpublished. We have 43 children with central precocious puberty, of which only 6 presented less than 3 years of age, and all of them had thelarchy plus vaginal bleeding, and all of them were organic causes. 3 had hypothalamic hamartoma, 1 was an HIE, 1 was an astrocytoma, and 1 was an optic glioma. CPP, more than 6 years, 37 patients out of 43 presented with central precocious puberty after 6 years of age. They all presented with progressive thelarchy with some adrenarche, and almost all were idiopathic CPP. We didn't have to intervene anything for that CPP when the age of onset was more. So the conclusion is that the CPP before 3 years, if there is a central precocious puberty, it is almost always organic. So if it is not, everything is normal and you have a CPP, you should be always suspicious whether you are dealing with a CPP or a premature thelarchy. Whereas after 6 years, it is almost always idiopathic. There can be exceptions. So to take home, premature thelarchy is generally a benign condition. Usually no additional testing is needed provided your follow-up is guaranteed. Strict follow-up of height and progression of puberty until there is regression, stability or red flags that suggest progression to CPP. If follow-up is unpredictable though, which is very common in our situation, you are supposed to use your clinical judgment to see how much to investigate a patient, but something which you can almost always avoid is a GNRS stimulation testing. This is the leaflet for premature thelarchy available for the, from the Australian Pediatric Association and the Pediatric Endocrine Society, which tell you in the same lines, for your pediatrics talks you give to the pediatricians, you can always tell them to follow them up and refer to you only when they have a concern. A happy Onam from all of us there in Kerala. Thank you.
Thank you, Dr. Bhavani, for your wonderful lecture. And we'll ask Dr. Jabbar and Dr. Sharathi to join us. Madam, please stay back. We have a 10-minute question and answer session. So, to start with, anyone have
Any from the audience? Any questions from the audience? Not audible.
In a case of gynecomastia.
No, I didn't get the values. Prolactin?
So can we skip, in a case of gynecomastia, the prolactin testing if the testosterone is normal?
Okay, if the testosterone is normal, probably you can. But see, I think it's better to look for prolactin also. If the testosterone is normal, it's a indirect evidence. Okay, that's my view.
So, and one question to Vijay sir. Do you see steroid profiling taking over this whole genome sequencing in any of the DSTs, be it CH, when you're suspecting CH, any form?
Yeah, definitely when you're suspecting a rarer forms of CAH, it's the investigation of choice, because like if you do only 17-OHP, it has a lot of fallacies. It may come high even in 11 beta, sometimes even in 3 beta. It may mislead us. So whereas in the steroid profile, the accuracy of 17-OHP estimation is very good. On the top of that, we also get 11-deoxycortisol, which tell about the 11-beta-hydroxylase diagnosis. Yes, steroid profile has a definitive role for 46XX DST.
So do you think in the future, with pattern recognition and all getting better, and this steroid profiling will be helping in any sorts in today's like 46XY DSDs?
XY DHT, probably it's a limitation is that it does not include the DHT. So if probably DHT could be a part of steroid profile, anybody is offering that kind of a profile, definitely it takes a role. But unfortunately, DHT is not the part of the currently existing steroid panels.
Thank you, sir.
Sir, at what age do you recommend cosmetic surgery for gynecomastia? Is there a specific age after which you say you can go for? Because we have patients at 15, 16, 17, 18 opting that, oh, I am willing for going for surgery. So at what age do you recommend?
That's not the age, Babu. So finally, the issue is whether they will respond to medical treatment or not. Okay. Usually, see, these patients will get regression. Okay, by the age of what is written in the textbook 17, so definitely beyond 18, there is no chance. But see, giving medical treatment also, if the patient has got a chronic disease, there is no much benefit is likely to happen there. So for cosmetic purpose, you can give, but what we are following is after 17, so probably will go for surgery. That's my usual practice.
So after 17, if it's persisting, you ask them to go for surgery.
And if the patient is having troublesome or cosmetic or social issues, you can.
So, Dr. Jabbar, do you have any comparison between tamoxifen or anastrozole?
Yes. There are few studies, Duncan, some author's name, I forget the name. There's a comparison. So practically speaking, a max diameter reduction is around 2.5 centimeters. Okay. But by and large, there is no significant difference between, there is a comparison between danazole also in this area, but there is no significant difference noted with this regimen.
The problem with the anti-estrogen drugs is the response is very slow. So a lot of children who are coming to us with puberty, with gynecomastia, they want a quick fix solution because they're so much depressed. The mother says he doesn't go to the school, he feels very shy. So maybe surgery is a better option for them.
See, social and of course, paternal, maternal side, there are a lot of issues. That's the reason they're consulting plastic surgeons first. So endocrinologists having a conservative thought process, and they will advise, okay, chalega, that is baad mein kar sakte. Now eventually they will go to plastic surgeon, so they will insist for surgery. Okay, but there is no harm in doing that. But see, this is my practice. So see, they will come with a small gout, breast tissue, and painful, okay, and short duration. They will respond well, okay. And if they see, like, so my second case, if the patient has got a breast is that of a female, so definitely they won't respond, okay. Small, yes.
Any other question? If there is no other question, thank you very much for the patient listening.
Now we have a session in Hall A. We will meet back here again at 11:15 for the further sessions here. Oration in Hall A. I would like to call upon the stage the chairpersons of the next session, Dr. Anupam Biswas from Noida and Dr. Shomik Datta from Kolkata.
Thank you. Good morning, everyone. So, on fantastic session planned from practicing point of view, and here we'll focus on how the axis is being influenced by the accessories, that is the drugs. And we are having three learned speakers with us, Dr. Ipshita Misro, Dr. Uma Saike, I think she is absent, and Dr. Bora will be representing her, yes, and Dr. Nilakhi Deka. So may I invite Dr. Ipsita Misro? Please come. Please take the podium. And I am having Dr. Anupam with me. He's from Noida, I think.
Thank you, chairpersons, for the introduction. Wow, ESICON 2025 will be remembered by all of us for a long time. It has set up the benchmarks for endocrine scientific content quite high up. So I congratulate the organizers and thank them for giving me this opportunity. So sir, as sir has told in next couple of minutes, what we are going to talk about are the drug-induced effects which are causing alteration in the TFT. So why are we talking about this? Because if you look into after a plasma glucose, which the test that is advised in our routine practice is a thyroid function test, and the drug-induced alterations are something which needs to be identified because they can be very subtle to having frank overt manifestations. Most of the times you do not need to give any therapy, just have surveillance, and at times maybe you need to consider giving a therapy for this. So we need to understand that, and before delving deeper, first we have to understand how tightly and beautifully the thyroid axis is regulated by factors released from the hypothalamic pituitary level. So the TRH, the TSH that comes out from the thyrotropes goes and sits on the follicular cells present in the thyroid by series of steps causes synthesis of the thyroid hormones, the T4, T3 which are released from the follicular cells. They go and bind with various binding proteins which are there in the circulation. They enter, go to the liver. Most of them are also again they are acted upon by the dehydrogenases, release the free hormones and which go and sit at the TREs. Now why am I talking of all this? Because these are the steps where multiple drugs will come and sit and affect and interfere with how the TFT will appear when you get a report. So now the beautiful relationship that exists between free T3, T4 or total T3, T4 and TSH is the inverse log relationship that they have. So scenarios where you have elevated thyroid hormones, suppressed TSH, or you have got elevated TSH and suppressed thyroid hormones where the relationship is preserved, either you go in evaluation of causes of thyrotoxicosis, hyperthyroidism, or evaluation of causes of hypothyroidism. But life is not very easy. So when you get extremes of report, if you look into this, where you have the other four corners, where you have got normal free thyroid hormones and the TSH is suppressed, to elevated thyroid hormones with TSH being normal, then it can be anything ranging from an assay interference, a NTI, a recovery of an axis, or it could be as something as serious as a resistance to thyroid hormones or TSHomas. The other way around, you make discordance in terms of ranging from subclinical hypothyroidism to secondary hypothyroidism. So you need to suspect drug-induced alterations, especially when there is a discrepancy between the clinical presentation and the TFT. Now at times we see that only a TSH is advocated and the thyroid hormones are not advised, but TSH alone may not give you an answer, especially when you are dealing with assay interferences, when you are suspecting central hypothyroidism, when you are thinking of a RTH, or when you are thinking of a recovery of a toxic phase or TSHomas. So probably you need to understand that we need to advocate along with TSH the involvement of the thyroid hormone evaluations also. So in 2019, NEGM proposed a classification of how the drug-induced alterations in TFT and broadly divided in interference with the endogenous thyroid function, interference with the thyroid hormone therapy per se, and interferences in a euthyroid person in a lab assay. So if you look into the endogenous thyroid person, it can be ranging from disruption at the HPT part, at the changes in the autoimmunity part, changes in the binding globulins, etc. And interesting was how there could be interference in a euthyroid person where you can get a falsely elevated thyroid hormone, low thyroid hormone, suppressed thyrotropin, and also falsely elevated TRAP values. So moving first to the assay interference, broadly you have the biotin interference, the heterophil antibodies, the microthyrotopic and the anti-streptavidin antibodies. Now overall the assays are broadly classified in terms of thyroid assays into a competitive and the sandwich. So competitive is where the signal generated it is inversely proportional and it is used for estimation of the thyroid hormones. The sandwich where the signal generated is directly proportional and it is used for the large molecules, that is TSH. And now the evolution of biotin and avidin complexes to hasten up the process of assay and to amplify the signal, that is also used. Now the problem arises when there are no interfering factors, but when you have the interference, especially what was proposed was biotin, and this was more so in the earlier generation assays. So if it is a sandwich method, the biotin will interfere and it will give you a falsely low TSH values. If it is a competitive assay, again the biotin interferes and gives you a falsely high thyroid hormone values. So this is the classic picture, young females who take biotin as supplements for enhancement of the hair health and the nail health. You get thyroid hormone reports where the thyroid hormones will be elevated and the TSH will be suppressed. So in here the trap can also be falsely elevated. So the picture is, the biochemical picture is that what we discussed, and it just mimics a state of hyperthyroidism. Now the proposed mechanism is to check whether it is due to biotin interference or not. You can have a washout period of 8 to 10 hours, but the earlier generation assays the problem was more, but in the newer generation immunoassays, even the plasma values of biotin, if it is as high as 1000 Ng per ml, they do not interfere. So you can just use a washout and repeat the test. The other antibodies are heterophil antibodies. We all have them. Some other variant of antibodies are there, and more so in the people who are exposed to the mouse or the animal antibodies. HAMA is more common. So they can give you falsely low values or high analyte assays depending upon the interference site and the type of assays. So high analyte values are more reported, and these are more, they affect the sandwich assays. Now it becomes difficult to sometimes differentiate the heterophil antibodies from the macro TSH where the TSH mixes up with its antibody, the anti-TSH antibodies, and form large 150 kilodalton complexes. But most of the assays these days are, they can detect the presence of macro TSH. The other ones are the anti-streptavidin antibody, which is almost similar to biotin, but in biotin assays you can use a washout period, but in anti-streptavidin antibody interference, washout is not helpful too much. Thyroid hormone autoantibodies do also interfere with the assays, and they basically affect the T3 or T4, and it again depends upon various manufacturer platforms. So this is a very interesting thing. In the scenario where you get elevated thyroid hormones, TSH being within the normal part, you must suspect assay, and after ruling out the assay interference, give a thought you may be dealing with other important conditions, especially RTH and TSH OMAs. So there is a series of steps in which further you can evaluate and reach a diagnosis. Now looking into the other part, now we have covered the assay part and the drugs per se. So drugs affecting the pituitary, especially the dopamines, especially the dobutamines, the steroids, retinoids, immune checkpoint inhibitors, they go and interfere at the release of TRH, TSH. Drugs affecting thyroid, most common is, which is proposed, which we know is amiodarone and lithium. And there are other things also which interfere with the TBGs. So especially estrogens and the androgens, one increasing the TBGs, giving a falsely elevated value of total hormones, and the ones which decrease TBGs. Now, if there are drug therapies which are interfering while a person is taking thyroid hormone, most commonly we know it is the PPIs, the iron and the calcium preparations. So all needs to be considered. So another clinical scenario very common for a sick patient, you may just be getting a call where you have aberrant thyroid reports. So classical picture of NTI where the spectrum of TFT variation can be present ranging from a low T3 syndrome or low T4 syndrome. TSH can be normal, can be high, can be also low. So you can have anything. Per se, you do not need to treat them. There is a various school of thoughts regarding consideration of therapy in an NTI. So you may just watch, and there are certain proposed cutoffs. If total T4 is very low, less than 2 Ng per dl, you can use in the interim phase, consider using the therapy. But in a background, if the patient has autoimmune disorders, then there can be persistence of abnormal thyroid reports, and there you need to be cautious. The other patient are the cardiac patients who are taking amiodarone. Now, amiodarone can have both hypothyroidism and AIT1 and 2, because amiodarone has got a huge content of approximately 37% has got iodine is present. So if you get a picture of a subclinical hypothyroidism report in amiodarone-induced hypothyroidism, again multiple mechanisms are proposed, ranging from a persistence of a Wolff-Chakow to inhibition of the deiodinase. You can get a spectrum of reports. So sometimes in the AIH hypothyroidism, you can get elevated total T4 because there is an inhibition of the deiodinase. So you need to consider whether you have what you are going to do. Now sometimes it's not possible to stop the drug therapy and you may need to treat it per se, and you need to monitor the patient. So this is on a rise. Oncology patients these days, with the evolution of the immune checkpoint inhibitors, use of the tyrosine kinase inhibitors, we get a spectrum of TFTs. So this is a patient who is treated with a TKI. Mechanism of TKI-induced hypothyroidism, again multiple mechanisms are proposed. So if somebody who is already on a thyroid hormone replacement, they will need more of requirement because there is increased metabolism. Direct thyroid toxicity is there. There is alteration in the autoimmunity per se, which can lead to immune mediated reconstitution and changes. So again, you can get variation of picture, especially TSH is high and the F3 hormones are usually low. Transient toxicosis can be present. So here again, you need to be careful whether you will like to give treatment or not give treatment. Again, on a background of a pre-existing autoimmunity, you have to be cautious because it's sometimes difficult to remove off the drug therapies. And we know the various CTLA4s, the PDIs, the PDL1s, where again the spectrum of hypothyroidism to hyperthyroidism can be present at various ranges of prevalence, and they also have the effect at the level of the hypothalamic pituitary axis apart from the immune reconstitution changes. Alemtuzumab, a monoclonal antibody which was given in T-cell lymphomas and also MS. So here the prevalence of Graves' disease is quite high, again to as high as up to 60 to 70%, and the pathogenesis, again the breakdown of the self-tolerance due to activation of the autoreactive T cells. So lithium, which is used in management of psychiatric disorders, now can again give you a spectrum of manifestations in the TFTs where the TSHR is high and usually the free thyroid hormones are in the normal. Multiple mechanisms at the level of thyroid hormone synthesis are there. You can get a small goiter. So here in these cases, you can just stop the lithium if it is possible and evaluate the patient if the TSH normalizes. But again, if there is a diseased thyroid per se, especially in background of autoimmune thyroiditis and persistence of the enlarged goiter, you have to again have a judicious judgment whether to consider or not consider. So this is interesting. So earlier what the unfractionated heparin was more commonly used, now you have the higher refined forms. So this is molecule displaces the free thyroid hormones from the TBGs by activating the LPL and releasing the nephas, which cause the indirect displacement of the free thyroid hormones and give you a false impression of elevated FT3, FT4 where the total hormones are normal and TSH is normal. So you do not need to treat them. You can repeat the test, give a washout period of 10 to 24 hours and repeat it. So epileptic patient with low total T4, and we know that major AEDs, they cause alteration of the metabolism by activating the microsomal P450 enzymes and other by affecting the binding proteins. So again, in these scenarios, you need to maybe just re-evaluate again without treating directly. These are the other drugs which are proposed. Warfarin is proposed, GH heart therapies are proposed, and we all are exposed to endocrine disruptors in some other way, which they affect the thyroid autoimmunity and can manifest in various alterations in the TFT if it is done. So what is the clinical implication and management? So importance of a thorough drug history is very important because with the evolution of the AI age, I understand history taking and clinical examination is of course faltering down. So have a thorough history of the prescription drugs, over-the-counter medications which are being used, the herbal preparations, dietary habits, especially in the young females. Try to differentiate them from the primary pre-existing thyroid disorders. Take a proper clinical history. Look into the pattern of TFTs. Need a consideration of thyroid autoantibodies. The thyroid imaging can be done. Consider if the drug can be withdrawal or the dose of the offending drugs can be adjusted, and you may need to monitor and follow up these patients. Now, when to intervene and keep considering therapy, there are no proper guidelines, no consensus per se. So asymptomatic biochemical parameters do not need any treatment. Subclinical hypothyroidism or hyperthyroidism, you have to look into the clinical context of the patients, especially pregnant patients, children, patients who are having heart disease, osteoporosis, there you need to consider giving treatment. Overthyroid dysfunction, of course, you need to do adjustment of the offending drugs if per se they are anything are there. You need to consider giving drug therapies, anti-thyroid drugs, suppose it is AIT type 1, AIT type 2, you can give interims, glucocorticoids and symptomatic management. Multiple challenges are there in the diagnosis and management of this category of patients. First and foremost is polypharmacy. At least every patient who comes to us, at least 2 to 3 drugs will be there, and it is very difficult to identify which particular drug is the offending agent. Comorbidities are very much there. So various underlying illnesses are there that affect the TFT. So sometimes it is difficult. So whether it is the background illness, medical illness that is present causing a kind of NTI or a offending drug the patient is taking. Genetic polymorphisms are underdiagnosed. They are not, we cannot know them also. So that causes a variability in the patient response and influences the susceptibility to the drug effects. Now, various offending drugs are there which have a very long half-life. So even if you remove the drug from the basket, persistence of the effect will be there for a very long duration, and you need to monitor them. Critical medication use which are there, especially in the immunomodulator categories. So it is difficult to completely withdraw those drugs. So here you have to balance it out, how you are going to treat the thyroid related part and also take care of the immunomodulator therapy that they are giving. Future directions are there. We need to consider evolution of pharmacogenomics to identify these genetic predispositions and development of maybe certain biomarkers where we can predict that probably these are the category of patients who may have a drug-induced alterations in the TFT, especially if they are taking immunomodulators, and continuous vigilance of the novel drugs which are coming up related to oncology part, and it has to be done and they should be kept for a prolonged period of surveillance. Long-term outcomes of how the drug-induced alterations in TFT are going to persist beyond for a certain period. So having a prolonged surveillance of those patients need to be kept in mind, and an optimized management algorithm has to be devised, and I believe that it has to be individualized, and you need to take care of the patient per se as a holistic part and educate the patient. Never forget that, because if they will come with you with TFTs with alarming things that okay, my thyroid reports are not in the normal ranges, and now we have labs which highlight the abnormal values in blues, blacks and pinks, and the patients are unnecessarily panicked. So this is just a summary of flow of events. So if you get a discordant TFT, re-evaluate the history. So the normal physiological variants, extremes of age and pregnancy where you can get you do get an alteration in the TFTs, and consider the other therapies. Look into the offending drugs. If the patient is on drug therapy, thyroxine per se, look into the factors which affect the absorption and the metabolism of the thyroid hormone. Reassess the status, whether the patient is biochemically, clinically euthyroid, or persistence of hypothyroidism is present. And then you need to exclude whether there is assay interference, and further you have to evaluate, if needed, a genetic studies in the category of suspicion of TBG disorders or a RTH, there you know. Now, some methods are proposed, especially if it is assay related interference, what can be easily done and which is difficult to be done but still exists. So simple methods, if you are getting an alteration in the TFTs which is not concordant with the clinical scenario, compare the hormone measurements using 2 or more assays. Use PEG precipitation methods if you are suspecting macro TSH. Dilution studies do give benefits, and avoiding the interference blocking agents, so they can be taken care of. These days most of the immunoassays come up as per the manufacturer guidelines, where they use, they are aware about the blocking agents which they are using in the particular assays. And certain difficult methods are there where you are having a strong suspicion that probably the report that you have got is due to an alteration due to some offending agent. There you can use equilibrium dialysis techniques, ultrafiltration methods, radio label studies are proposed, and the genetic testing. So what we need to understand is that when the thyroid function tests do not agree with the clinical scenario of the patient, keep in mind that you could be dealing with a drug-induced alteration in the TFT. Automated immunoassays have evolved in past 20-30 years, but still we cannot say that interferences are absolutely zero. Keep a check on the medications that can involve at the level of the hypothyroid, the thyroid axis, the pituitary and the hypothalamic axis, how they affect the metabolism of the hormones, the circulation, etc. Especially in the patients who are taking the ICPs or the TKIs, we need to be watchful and need to monitor, and probably need to have a vigilant eye on those patients, especially in the thyroid related part. And we, as we discussed, EDCs are everywhere. So how they are affecting the autoimmunity, how they are going to be persistent and going to be staying with us for prolonged duration, along with that the background of the other problems that we have, the offending drugs, the diseases that alter the TFTs, that is something which needs to be kept in mind. And of course, an individualized patient-centric approach is something which nothing goes beyond that. So thank you so much for the patient hearing.
Thank you, ma'am. An excellent talk by Dr. Ipshita. And the panel discussion will be in the end of the session. So for the next talk, I would like to call Dr. Abamani Baro. And this is a very common practice. And during practice also, we see a lot of patients coming with a high prolactin levels. And what are the effect of drugs on high prolactin? Unfortunately, most of the patients in my OPD who are coming with high prolactin, they are already on a cabergoline. So it is very important to take history, and for that I would like to call Dr. Abamani Baro, and she is from Guwahati, practicing at Guwahati. Okay, ma'am.
So at the very outset, I would like to thank the organizing team of SECON for inviting me here. So today's talk was supposed to be given by my HOD and professor, and also my DM teacher, Dr. Professor Uma Kaimal Saikia. But because of some unavoidable circumstances, madam could not come. But she believed in me and then given me the responsibility of speaking on the topic. So madams have made her slides, so I hope I can do justice to the responsibility that has been given. So my topic, today's topic is drug-induced hyperprolactinemia. So the agenda would be a brief introduction, common drugs implicated, clinical presentation, then diagnosis, is it a matter of concern, and the treatment options. So hyperprolactinemia is a commonly encountered clinical condition. Every OPD we get some hyperprolactinemia patients, be it some symptomatic or asymptomatic incidentally found. Now drug-induced hyperprolactinemia emerging as a leading cause of hyperprolactinemia along with other cellular, supracellular lesions. So we have a lot of causes of hyperprolactinemia both in males as well as females, but drug-induced is upcoming and it's been a very common topic now. Now 15 to 45% subjects with hyperprolactinemia is due to medications, and the incidence of antipsychotic per se, particularly induced hyperprolactinemia, is very, very high. It can range between 18 to 72% in men and 42 to 93%, you can say 93%, very high percentage in women. So almost we can say that almost in 100, 93 of them will have hyperprolactinemia if using antipsychotics. Now clinical manifestations vary depending on dose and duration of therapy of offending drug, and a good history and evaluation is needed to rule out other organic causes and arrive at a diagnosis. Now this is the axis of hypothalamus and the prolactin axis. We know that hypothalamus, there are the tubulo-infundibular, tubulo-hypophyseal and periventricular hypophyseal dopaminergic neurons, and they send dopamine and inhibit the pituitary production of prolactin. After production of the prolactin again have some weak impact on this dopaminergic, positive impact on the dopaminergic neurons. Now this is how prolactin remains normal in patients. So what is hyperprolactinemia? So for discussion or for general use, we use 20 as a cutoff for male, nanogram per DL, and for females it is 25. So the drugs causing hyperprolactinemia, the most common is in our private practice is PPIs. So many a times, even pantoprazole, although this is not listed in this, but then even I have seen patients on pantoprazole and rabeprazole on long-term use coming with hyperprolactinemia. So domperidone, then other drugs like domperidone, then metoclopramide, cimetidine, ranitidine, they are notorious for causing hyperprolactinemia. Antipsychotics like chlorpromazine, then the haloperidol, sulpiride, risperidone. Risperidone is commonly used in schizophrenia. So I'm sorry if it is not it's coming very small, but when the PPT was made, it was not that small. So it is like risperidone, then the quetiapine, olanzapine, all this can lead to hyperprolactinemia. Antidepressants like clomipramine, amitriptyline, fluoxetine, paroxetine. So it is commonly used antidepressants can also cause. So sertraline does not cause usually hyperprolactinemia, whereas for fluoxetine, the result says that fluoxetine has conflicting results. Some studies say they do, some studies say they do not. So this is a case scenario where a 25-year-old girl presented with galacturia, noticed for 1 week, extremely worried about it, went to a gynecologist. We do not know, but then all galacturias go to a gynecologist for some reason. I do not know, but then yes, they don't come to endocrinologist, but they do go to a gynecologist, and the gynecologist will definitely prescribe them cabergoline once weekly 0.5. That's a very common practice for 3 months, and then they see the patient after 3 months. But then we should keep them aware that they has to be sent to endocrinologist for evaluation and to see for any underlying major disorders. So extremely worried about it, this lady, then prolactin level was 65 nanogram per ml and was started on cabergoline. So history, no symptoms of hypothyroidism, cycles were regular, no headache, visual defects, or there was no polyuria, polydipsia. Drug history also, she's taking PPI with domperidone combination frequently for vague abdominal symptoms. So examination normal except for galacturia, and other investigations were also normal. She was reassured and she was advised to stop the PPI that she was taking, and she was asked to repeat prolactin after a week, and on follow-up the galacturia reduced and the prolactin was normalized. So this is a very common practice, and we should actually, the treatment shouldn't have been cabergoline, but it should have been to stop the PPI and to repeat the prolactin maybe after 1 or 2 weeks of stopping the prolactin, and we can repeat the prolactin levels after stopping. So this is another case, 20 years old girl referred from psychiatry for amenorrhea for 6 months. Now she was on schizophrenia for risperidone for schizophrenia for last 5 years. She gives history of oligomenorrhea for last 3 years, weight gain, occasional headache, no visual symptoms, no polyuria, no polydipsia. On examination, she was definitely obese with a BMI of 27. Acanthosis or acne was present, normal blood pressure, and no striae, no bruising, no myopathy, no hirsutism, does not suggest Cushing's or does not have other features of PCOS. So investigation-wise, HbA1c she was pre-diabetic with the HbA1c of 5.8%, normal TFT, ONDST was normal, but then prolactin was 150 nanogram per ml, and as you can see, FSH was normal, USG suggestive of PCOS. So this again was a cause of drug-induced hyperprolactinemia with PCOS, because risperidone is very notorious to cause hyperprolactinemia. But then we should also remember that if the patient definitely gives a history of drug, but in patients who come with only PCOD or PCOS, even PCOS itself can have mildly raised prolactin levels. So it has been said that, it has been seen that in simple PCOS cases without any drug history, without any pathology, their prolactin levels may be slightly high, like 35, 50 around, mildly elevated. So in this case, our concerns were we wanted to regularize the cycles, correction of a pre-diabetic state, attainment of normal body weight, normalization of prolactin levels, and withdraw risperidone. Again, it is difficult. We had to take a psychiatry opinion. Many a times it is not possible also. And addition of a adjunctive therapy. So the symptoms, if you consider the etiology of hyperprolactinemia and the symptoms, it's been seen that almost 20% in females and 30% in males, they will have no symptoms. Almost 30% will have mental disorders. Galacturia is present in only 20% of the drug-induced. Hypogonadric symptoms like menstrual disorders and along with galacturia may be in 30%. So around 30-20% with drug-induced may come with symptoms. So can prolactin levels predict etiology? Again, if it is visible, then you can see in drug-induced, in a meta-analysis, it was seen that the prolactin levels range between 37 to 720 in drug-induced. So we cannot imply that a prolactin level more than 200 or more than 250 is equivalent to a macroprolactinoma or microprolactinoma. So even in drug-induced, they can go above 200 or 250. So there is many overlap in drug-induced and microprolactinemia in the prolactin levels. Macroprolactinemia, huge macroprolactinemia, we get prolactin in thousands and more than 500. But again, prolactin levels can be an overlap in microprolactinemia and drug-induced cases. So distribution of prolactin levels as per etiology, again you can see in drug-induced, almost 50% will have prolactin levels between 50 to 100. But then we can get even above 500 as well. 5% of them may be in the 250 to 500 range, and like on 10% maybe in the 200 to 250 range. So if it is between 50 to 100, a definitive history of drug, then maybe it is a drug induced. We may not do a MRI brain in all cases, but then yes, if the levels are high, more than 200 or 250, there are associated symptoms of headache, visual disturbances, then we may, and if there are features of central hypothyroidism or any other cases, then maybe we may think about doing an MRI. So the main problems comes as in all the patients we cannot do MRI with every patient of hyperprolactinemia. Again, it is our clinical judgment that should guide us whether we should tell the patient to do an MRI or not. Because in the, I do not know, but in Guwahati, like MRI would be almost 6,000, 8,000 rupees. So all patient may not be affording for that. So drug-induced history intake, drug intake history is very, very important. Again, symptoms of mass lesions has to be taken, and usually prolactin levels will be less than 100, between 50 to 100, and overlap with microadenoma or stalk compression. It is another thing that stalk compression can also cause mild elevation of prolactin levels. We should exclude pregnancy, renal, hepatic dysfunction, and hypothyroidism, and estimate other anti-pituitary hormones if clinically indicated. Drug withdrawal if possible, followed by repeat testing. Imaging may sometimes be needed in case of diagnostic confusion. So are there long-term consequences of hyperprolactinemia? So what if we leave the patient like that, somebody having a prolactin level of 100, and we just leave that? But it has been seen that hyperprolactinemia has many effects on the cardiovascular system as well as the bone health. So prolactin levels and severe risk factors. So hypertension, higher the prolactin levels, and higher the blood pressure, or it correlates with the hypertension. And this is because of dysregulation of dopamine-dependent mechanisms. It can also lead to dyslipidemia, and it can increase cholesterol, LDL, triglycerides. And also because prolactin ultimately leads to suppression of hypothalamic GnRH secretion, and this hypogonadism can reduce lipoprotein lipase activity, weight gain, and obesity, leading to various metabolic syndrome and increase the risk of metabolic syndrome. Atherosclerosis and endothelial dysfunction can also occur because prolactin stimulates vascular smooth muscle proliferation, angiogenesis, and reduces N production, nitrous oxide production. Now prolactin and glucose metabolism, if we see that adipose tissue, in the adipose tissue, basically it will increase lipolysis and decrease good adiponectin and increase leptin. Basically, it leads to insulin resistance. In skeletal muscles also, it increases insulin resistance and decrease lipoprotein lipase. In liver, it increases hepatic gluconeogenesis and also increase insulin resistance. But a good thing about hyperprolactinemia is its effect on the pancreas. It has effect on beta cell survival and proliferation, especially in fetus. During pregnancy, why is hyperprolactinemia important? So we know that prolactin levels increase during pregnancy, and we have always known that prolactin will help her to lactate during her breastfeeding period. But it has been seen it has a beneficial effect on the fetal pancreas also, because it improves the beta cell survival, proliferation, decrease beta cell apoptosis, and increase insulin biosynthesis, and increase glucose-dependent insulin secretion. So body weight again in hyperprolactinemia, otherwise in a person, adult, leads to a mesocortical limbic system. It increases like ingestion behavior, it decreases satiety. So there is increased hunger. In adipose tissue, I have already said that insulin resistance, and in HPG gonad, it leads to hypogonadism by suppressing the secretion of GnRH. Now severe risk, yes, it has effect on the adipose tissue. As we know, the adipose tissue is the largest endocrine organ, and it leads to lipolysis, ultimately increased free fatty acid. There is ectopic fat deposition in the liver, skeletal muscles, heart. Ultimately, there is insulin resistance. Pro-inflammatory markers increasing, there is increased risk of diabetes, prediabetes, and dyslipidemia. So definitely hyperprolactinemia is a cardiometabolic risk and has to be treated. And is hyperprolactinemia associated with mortality risk? Yes, a study and meta-analysis, it has been seen that each unit of prolactin, each unit is 10 nanogram per ml, is associated with a prolactin increase of 10 nanogram per ml or each unit of prolactin increase is independently associated with increased risk of all-cause and severe mortality. So even in this, paves a new thought, and studies can be done when in ICU patients we can just see the prolactin levels and correlate with the mortality. If this is how can it positively correlate, and what is the strength of correlation? Now, prolactin and bone. Again, a lot of studies has been done, and it has been seen that prolactin has an effect on the bone osteoblast as well as osteoclast. It not only causes osteoporosis by causing hypogonadism, but it can also lead to osteoblast inhibition and osteoclast activation. So spinal BMC it is almost 25% lower in women with hyperprolactinemia when compared to healthy women, and high rates of vertebral fractures are reported in patients with prolactinomas. Trabecular bone is affected more than cortical bone, but both bones are affected, both cortical and trabecular. Bone formation markers reduce with increase in resorption markers and depends on the degree and duration of hyperprolactinemia. Again, hypogonadism is another reason for the impact on the bone. So as you can see, prolactin, the prolactin have an inhibitory effect on the osteoblast and an activating effect on the rank ligand. Ultimately, there is osteoclastogenesis. Even osteoclast promoters like interferon, interleukin-1, TNF-alpha, COX-2. So all these are promoters for osteoclast. Even hyperprolactinemia leads to increase in the promoters of osteoclast, leading to osteoclastogenesis. But then the hyperprolactinemia has a dual effect. Like less than 100, it may reduce osteoclastogenesis, but more than 100, the effect is increases osteoclastogenesis. The higher the level, the higher the chances of osteoclastogenesis and osteoporosis. Now, treatment of drug-induced HPL. So we have to definitely remove offending drug. If it is a PPI, there is no other option. We have to remove the PPI. And again, reducing the dose of the antipsychotic or switching to another antipsychotic drug, and adjuvant therapy. Like there are newer drugs like aripiprazole, adding metformin, and also we can add a dopamine agonist. So dopamine agonist in antipsychotic drugs. So concerning regards worsening of most of the time, antipsychotic we are not able to withdraw, especially in patients who have bipolar disorders, schizophrenia, autism, depression. So again, a meta-analysis have shown that psychological sometimes may be worsening if we are using some dopaminergic agonist also, along with antipsychotics. It is more common with bromocriptine, and none cases has been reported from cabergoline in the dose of 0.25 to 1 milligram per week. And even if we are using dopamine agonists like cabergoline, it needs close monitoring. Now, another drug is aripiprazole, a typical antipsychotic, a dopamine receptor stabilizer. So it is most extensively studied in antipsychotic-induced HPL. So it can be used as an adjunct to antipsychotic drugs, but it cannot be used with PPI-induced or other things. Because aripiprazole, otherwise, when used as an adjunct to antipsychotic, so it competes with the antipsychotic and inhibits the D2 receptors. But if it is used alone, it may cause a paradoxical increase in prolactin levels. So a patient on aripiprazole should be monitored for prolactin levels, and also the physician should be aware that there could be paradoxical increase also. So again, monitoring is important. So most studies have validated efficacy, safety, and no conclusive evidence for optimal doses, but most studies suggest low doses to be advantageous. Now, a partial agonist of D2 and D3 receptor inhibits dopaminergic activity when dopamine levels are high and stimulates dopamine activity when dopamine levels are low. All again, aripiprazole action depends on the dopamine. So if the dopamine levels are low, it will not, if prolactin levels are low, it will not further reduce the prolactin levels, but if they are high, it will reduce. The dose is 5 to 10 milligrams per day, and the side effects are sedation, insomnia, and headache. Now, adjunctive metformin, if we give metformin at a high dose of 1500 to 2500 milligram, then yes, it can also reduce prolactin levels, improve dopaminergic tone, and reduces prolactin levels. And there has been seen that there is resumption of menses in 70% of women. And meta-analysis also said that drug-induced hyperprolactinemia given adjunct metformin, there is some improvement in the hyperprolactinemia. So higher doses, longer illness duration, BMI more than 25, this can be considered in these conditions. So like a patient who has prediabetes, a high BMI, we may consider metformin giving in case of hyperprolactinemia. So this is a comparative efficacy to compare. This is a study comparing the efficacy of aripiprazole versus metformin in hyperprolactinemia, and has shown that aripiprazole is much better effective than metformin in causing remission of hyperprolactinemia. So aripiprazole is a much better choice than metformin. So the key points are: determination of etiology of hyperprolactinemia is fundamental for selecting the most appropriate treatment strategy. Mild to moderate elevation of prolactin levels usually seen in drug-induced hyperprolactinemia, however, overlap may occur leading to diagnostic confusion. Adding aripiprazole, dopamine agonist, or metformin may be considered, and long-term concerns regarding metabolic and skeletal health need to be addressed with larger prospective studies in drug-induced hyperprolactinemia. So from this, we know that yes, hyperprolactinemia, drug-induced, is a significant risk factor for cardiovascular disease as well as osteopenia and for the bone health of the person, as well as yes, for PPI we can stop the drug, but it is not always possible for us to stop the drug like in bipolar disorder, schizophrenia. So we may have to add adjuncts to the therapy. So thank you so much.
Thank you, Dr. Abhamani. Please stay with us. So after prolactin and thyroid, it's time for adrenal. And Dr. Nilakhi is with us. She will tell us how this threatening situation can be avoided. Nilakhi, please.
So a very good afternoon, everyone. I think it's still good morning. A very good morning to everyone. It's a wonderful experience to be on this yearly endocrinology pilgrimage hosted by Kolkata this year, ESICON 2025. We have had very relevant discussion about drug-induced endocrine disorders. We know endocrine disorders are a rare set, but drug-induced adrenal disorders, drug-induced hyperprolactinemia, or drug-induced thyroid function disorders, as have been discussed, are very, very common. And I believe all of us in this room have had such instances of dealing with drug-induced endocrine disorders. The third part of this discussion today is on drug-induced adrenal insufficiency. To begin with, a small quiz. Okay, you'll have to show a raise of hands, or maybe you can just stand and volunteer and say. This is a 36-year-old woman with a history of seizures, which was controlled on phenytoin. She has been undergoing chemotherapy, which included immune checkpoint inhibitors for the treatment of metastatic breast cancer. She is admitted to ICU with fungal pneumonia, and she was intubated with etomidate and rocuronium. She was started on ketoconazole for the fungal pneumonia and given 30 ml per kg of normal saline. However, in spite of beginning all these treatment as per the guideline recommended way, 36 hours later, she becomes increasingly hypotensive despite escalating vasopressor support. And she was subsequently treated with hydrocortisone, and a very good response was seen. Now, which of these following medications in this patient do you think contributed to the decompensation? Was it phenytoin? Was it etomidate? Was it ketoconazole? Was it the immune checkpoint inhibitors, or all of the above? Oh, very good. So my job is made easy. The next question. Which of the following patients, these are a few examples, are at the lowest risk of adrenal insufficiency? A 32-year-old female who is on intranasal steroid sprays for allergic sinonasal disease for the past 3 months. Another 62-year-old obese lady with knee osteoarthritis who was on intra-articular steroids given monthly for the past 6 months by our orthopedic surgeon. Third is 70-year-old gentleman with COPD who was on regular fluticasone propionate inhalers, and that was interspersed with oral and IV steroids to take care of the acute exacerbations. The fourth example is that of a 25-year-old female with severe RA who was on oral prednisolone 5 mg per day along with methotrexate and tofacitinib for the past 3 years. And 75 years old gentleman with generalized prurigo involving the entire body using multiple topical steroids for the past 1 year. Now, which of these following patients is at the least likelihood of having an adrenal insufficiency? Okay, so I think I can even go without the presentation because the audience is very well informed. So we know there has been an epidemiological change in drug-induced adrenal insufficiency, and the world literature suggests that there's been a changing epidemiology of adrenal insufficiency. So it is no longer the autoimmune diseases like Addison's disease. It is no longer the infections like tuberculosis, histoplasmosis, or HIV-related infections, which we would earlier have as a cause of adrenal insufficiency. Rather, in modern times, it is the drug-induced adrenal insufficiency which has a preponderance over the other infective or even the autoimmune causes. Now, drug-induced adrenal insufficiency occurs with certain medications which disrupt the normal functioning of the adrenal glands, leading to inadequate production of cortisol. In this discussion, we'll discuss about adrenal gland basics, the drug connection between drugs and adrenal glands, and how we manage. Now, there are two primary mechanisms by which drugs cause adrenal insufficiency. One is suppression of the hypothalamo-pituitary-adrenal axis, and other is direct inhibition of the cortisol synthesis in the adrenal glands. So this is the adrenal gland at a glance with adrenal cortex comprising of zona glomerulosa, fasciculata, and reticularis. And we have the glucocorticoids, the heroes in our discussion today, which is secreted by the zona fasciculata. Now, drug-induced adrenal insufficiency could be primary adrenal insufficiency as a result of adrenal cortex destruction with cortisol as well as aldosterone deficiency. It could be secondary adrenal insufficiency because the drugs act on the pituitary and lead to decreased secretion of ACTH. Or it could be tertiary adrenal insufficiency, where the drugs, they suppress the hypothalamic stimulus to pituitary, that is the CRH, and there's a suppression of the hypothalamic pituitary adrenal axis. Now, the features of tertiary and secondary are almost similar. So both of them cause low cortisol, low ACTH, and so these two terms are used interchangeably. Glucocorticoids are supposed to cause tertiary adrenal insufficiency, and that is the most common cause. So in this chart, we can see that there are different, in the diagram, there are different levels, the hypothalamus, pituitary, adrenal glands, and from there we have glucocorticoids and the mineralocorticoids. So there are various drugs, apart from the most commonly known glucocorticoids, which can affect the hypothalamus. The most common offending drug in this category would be immune checkpoint inhibitors, which Ipshita had just mentioned. So immune checkpoint inhibitors are new drugs used for the treatment of cancer, and they are notorious to cause endocrine dysfunction like thyroid dysfunction and adrenal insufficiency. So immune checkpoint inhibitors, they act on two levels. They can either cause hypophysitis and lead to secondary adrenal insufficiency, so they affect the pituitary. They lead to lymphocytic infiltration of the hypophysis and lead to deficient ACTH secretion. So that can be picked up when you do a PET CT scan in these cancer patients who are on immune checkpoint inhibitors, and that shows the affection of the hypophysis with immune checkpoint inhibitors. Immune checkpoint inhibitors, again, can lead to adrenal inflammation and destruction and lead to primary adrenal insufficiency. So when you have immune checkpoint inhibitors in a patient who is on cancer chemotherapy, you can suspect two types. So it could be primary or it could be secondary adrenal insufficiency. The other not very good point about immune ICIs, immune checkpoint inhibitors causing adrenal insufficiency, is the fact that most of these patients are irreversible, and so you have to supplement them for life with glucocorticoids to take care of this. Now, we have other drugs like glucocorticoids, opioids which are used for analgesia in cancer patients. We have megestrol acetate, which is progestin, medroxyprogesterone acetate, cyproterone acetate, which act on the hypothalamic pituitary axis. We have medications like glucocorticoids, imipramine, chlorpromazine, antifungals, triazole antifungals like ketoconazole, itraconazole, fluconazole, which affect the adrenal glands. Etomidate, which is a anesthesia-inducing agent. So etomidate is also used for transient sedation in short procedures, short surgical procedures. That can lead to adrenal gland affection because it inhibits the enzymes, and thereby it causes adrenal insufficiency. We have drugs which can cause adrenal hemorrhage, bilateral adrenal hemorrhage, as in use of heparin or warfarin in patients, which could lead to primary adrenal insufficiency. Now, once glucocorticoids and mineralocorticoids come to the circulation, there are again certain drugs which can either increase the clearance of glucocorticoids, like the CYP450 inducers, or suppose the patient is on certain glucocorticoid for a disease, and you use CYP450 inhibitors. So what happens is that the cortisol clearance is decreased. As a result, the patient is exposed to higher doses of cortisol, which could lead to adrenal insufficiency in the patient. So you have drug interactions which can lead to glucocorticoid excess or insufficiency in patients. So in this game of drug-induced adrenal insufficiency, we know by far the most important habitual offender is glucocorticoids. But as we saw from the previous slide, that there are other players too, which are making their presence felt in this scenario. Yeah. A small technical glitch. So we see that drugs can cause primary adrenal insufficiency, it can cause secondary adrenal insufficiency, it can cause tertiary adrenal insufficiency. Now, when we speak about glucocorticoid-related adrenal insufficiency, various factors increase the risk of the glucocorticoid leading to adrenal insufficiency. So it is the route of administration of glucocorticoids, it is the glucocorticoid dose, the glucocorticoid half-life and potency, drug interaction, and the inter-individual variability. So the inter-individual variability includes the body weight of the individual, the age of the individual, and also certain genetic susceptibility factors which predisposes one individual to more adrenal insufficiency or less. Now, the HPA suppression by glucocorticoids can be via any mode. Like we saw from the quiz question, it could be oral, it could be intra-articular, it could be inhalational, it could be topical, all modes, it could be intra-articular. All of these glucocorticoids, which are administered by various routes, get absorbed into the systemic circulation, and thereby they lead to HPA suppression. Now, there is something called glucocorticoid potency. And as you can see in this chart, the short-acting glucocorticoids with the least potency are agents like hydrocortisone. So they should be used more frequently. Then we have intermediate-acting glucocorticoids like prednisolone and methylprednisolone with a potency which is intermediate. So hydrocortisone has a potency of 1, and methylprednisolone or prednisolone has a potency of 5 and 4 respectively. Now you look at the last row. So that shows dexamethasone and betamethasone, which has a potency of around 30 to 60 when you compare it to hydrocortisone or methylprednisolone or prednisolone. And so these are very potent steroids and long-acting. So the risk of having adrenal insufficiency with the prolonged use of these long-acting, highly potent steroids is very high. So we need to know this chart, because then we know which kind of steroid to use in which patients, so that the risk of adrenal insufficiency would be least with our choice of glucocorticoids. Now, there is something which is called physiological dose of glucocorticoid and something which is known as supraphysiological dose of glucocorticoid. So the normal cortisol secretion in the body is close to 10 mg per day of body surface area in an individual. And depending upon the bioavailability of various steroids that we take, be it hydrocortisone, prednisolone, methylprednisolone, or dexamethasone, the physiological doses of these steroids resembling or mimicking the endogenous cortisol secretion would be around 15 to 25 mg of hydrocortisone or 0.25 to 0.5 mg of dexamethasone. Prednisolone is another commonly used steroid. So around 5 mg of prednisolone refers to the physiological replacement dose of cortisol in an individual, resembling the normal cortisol production in the body. So a person who has taken a supraphysiological dose of steroid for longer than 3 to 4 weeks is at a high risk of HPA suppression. In addition to the dose of glucocorticoid, the type of glucocorticoid we use, based upon the circadian rhythm of cortisol secretion, any glucocorticoids given in the evening or late night is more likely to cause adrenal insufficiency compared to the similar dose given in the morning. So that is another very important point that we need to keep in mind when we are talking about drug-induced adrenal insufficiency. Again, the duration of use, the body mass index, obese individuals are at higher risk of adrenal insufficiency compared to lean individuals. Elderly gentlemen or elderly individuals are at a higher risk of adrenal insufficiency compared to the young ones. So we have, when it comes to glucocorticoid metabolism or drug interaction, we have CIP inhibitors like ketoconazole, fluconazole, which are frequently used, diltiazem, verapamil, cimetidine, which can lead to increase in the level of cortisol in the blood and thereby lead to more cortisol-induced suppression of the HPA axis. And then we have CYP 450 inducers. So a person with adrenal insufficiency on glucocorticoid who are given these agents like phenytoin, phenobarbital, carbamazepine, the metabolism or the clearance of cortisol may be increased, and hence the patient may suffer from an adrenal crisis like the first case which we saw, the quiz question. Now, recognizing the signs and symptoms. So it could be general like weight loss, fatigue, nausea, vomiting, abdominal pain. It could be particular like postural giddiness, hypotension. It could be headache, confusion, loss of concentration, depression, sleep disturbance is very common. Or it could be certain specific symptoms like Cushingoid appearance is seen in glucocorticoid-induced AI, which is very specific. There is a lack of hyperpigmentation in drug-induced adrenal insufficiency, which is another distinguishing feature when we distinguish adrenal insufficiency, drug-induced vis-a-vis primary adrenal insufficiency because of autoimmune or other infection. That is another distinguishing point. You will have Cushingoid features, and there's a distinct lack of hyperpigmentation. Now, the looming danger, the sword of Damocles that hangs on patients of adrenal insufficiency is, however, acute adrenal crisis. And in any patient of adrenal insufficiency, we have to have a very high vigilance in avoiding an episode of adrenal insufficiency. So how do we diagnose drug-induced adrenal insufficiency? We discussed the causes of the offending drugs. We discussed the symptoms of drug-induced adrenal insufficiency. Now, how do we pick up drug-induced adrenal insufficiency? So the most important point in picking up drug-induced adrenal insufficiency is, I believe, the clinical history, the physical examination, and a thorough history of the drugs and medications used, be it any route. So did you have an intra-articular injection in the past? So many months, if you have symptoms of adrenal insufficiency, so we should ask about history of intra-articular steroid, oral steroid, intranasal steroid, topical steroid because of some skin condition. So all of these are to be kept in mind. The initial treatment testing would involve a morning 8 a.m. cortisol and ACTH. And certain confirmatory testing are there, like the cosentropin test. So a morning 8 a.m. cortisol less than 100 suggests a very high risk of tertiary adrenal insufficiency. And indeterminate cortisol, so between 100 to 300, requires the use of a diagnostic short synectin test. A morning 8 a.m. baseline cortisol of more than 300 to 400 excludes the diagnosis of adrenal insufficiency, and the patient does not require further testing. This, however, is not true of mifepristone-related adrenal insufficiency, which is mifepristone, which is it is an abortifacient drug, RU486, which many people use, and it is also used for the treatment of Cushing's disease. So in this patient, so it is a glucocorticoid receptor antagonist. So it prevents the glucocorticoid from acting at the tissue level, but the levels of cortisol will be high. So that is where you can miss adrenal insufficiency because of mifepristone. So that is another point that we need to keep in mind. ACTH would be low or it would be low normal, and except dexamethasone, all other exogenous steroids interfere with the standard cortisol assay, and hence we need to withhold the cortisol for a period of, the glucocorticoid for a period of 24 to 36 hours in order to have a correct information regarding the cortisol levels. So dynamic testing is there. There are other testing, but what is the management? So management is glucocorticoid replacement. In this, we have to, like any standard tenet in endocrinology, it says that whatever we are giving has to mimic the natural physiological cortisol secretion. And so the natural physiological cortisol secretion in healthy individuals, there's a regular circadian pattern with the peak cortisol levels between 2 a.m. to 4 a.m. in the morning, and the nadir, the lowest levels, approximately 6 p.m. thereafter until 2 p.m. again next morning. So when we are giving corticosteroids, glucocorticoid replacement, the highest dose should be in the morning. The next smaller dose could be around 6 hours later. But we should keep in mind that if you are giving a third dose, that third dose has to be 6 hours prior to sleep. So 6 hours prior to sleep, it in some way mimics the endogenous cortisol secretion that occurs in the body. So highest dose morning, then a small dose in the afternoon, and the last dose not later than 6 hours before bedtime. So sometimes there could be glucocorticoid withdrawal syndrome, and in this, we need to increase the doses of the glucocorticoid and then again watch and observe until the patient gets accustomed. Why do we need to taper glucocorticoids? To reduce the side effects related to long-term exposure, prevent reactivation, and prevent the risk associated with HPA axis. So we have to start with the initial rapid taper of glucocorticoid, then a slow subsequent taper. We should keep in mind that longer the use of steroids, slower the taper we should do. So these are very key important points. What do the guidelines say? That we should not or we need not taper glucocorticoids in an individual who is on less than 3 to 4 weeks of short-term glucocorticoid therapy. All patients on long-term steroids tapering should be done only if the underlying disease no longer requires glucocorticoid therapy. And it has been suggested that if we want to test for the HPA recovery, we can do a morning serum cortisol again. If the cortisol is more than 10, we can stop or we can gradually taper and stop the steroid. If it is less than 5, then we need to continue the steroids and attempt stopping the steroids at a later date. So there are sick day rules, wearing a medical bracelet or card, and during times of moderate or major stress, we need to increase the dose of glucocorticoid in patients whom we are treating for adrenal insufficiency. Adrenal crisis can be precipitated by physical, mental stress, infections, surgeries, pregnancy, and so on and so forth. Treatment involves immediate IV hydrocortisone at a dose of 200 milligram stat and then 100 milligram stat followed by 200 milligram over the next 24 hours. So around 50 mg IV 6 hourly. IV fluids and identifying and treating the precipitating illness. So to summarize, what the guidelines says that in order to prevent drug-induced adrenal insufficiency, we need to use the lowest effective glucocorticoid dose for the shortest treatment period possible. We need to taper glucocorticoids very judiciously, individualizing the pace depending upon the clinical response. Biochemical testing aids in timing of the steroid discontinuation. We need to educate the patient on the sick day rules, which is very, very extremely important to prevent an adrenal crisis. We need to keep in vigilance for adrenal crisis during acute stress. And there are certain newer cortisol replacement techniques, glucocorticoids, like Plenedrin, F-MODI, which are modified release hydrocortisone. So sometimes the patient may not be taking those 3 doses of hydrocortisone given because of non-compliance, poor adherence. In these, we have modified release hydrocortisone, which have been tried, which are being researched, so that the outer covering will have an immediate release followed by the inner core with a very slower release. So those are areas where research is going on. So in order to prevent adrenal crisis, we need to limit the use of steroids, use other steroid-sparing drugs.
Please sum up.
And monitoring is important, and dosing schedule. So with that note, I thank you for the patient hearing.
Thank you, Nilaki. So nicely explained. So I think we are having 9 minutes in hand, and house is full, so I think we can take 2 to 3 questions.
Yes, sir. You can go ahead with the question, sir.
They end up with hypotension because we had faced similar situation many a times. And second thing is, I know that cortisol and serum cortisol and suppression of ACTS stimulation test. What about the role of DHES in the diagnosis, especially to differentiate between drug-induced and primary additions?
I think it's very important, and another important thing is the electrolytes. So that is one point that I did not highlight, but when you have, so first thing is when you have a herbal medicine induced adrenal insufficiency, you will see telltale evidence of corticosteroid excess. Like the patient will have facial plethora, there'll be supraclavicular fullness, there'll be buffalo hump, there'll be easy bruising, and the patient will have abdominal striae. So those will be telltale evidence that the patient has been exposed to corticosteroids, though he was not on these pharmacy formulations, that those were herbal supplements. Because many patients take herbal supplements to gain weight. Sometimes they take herbal supplements to get rid of the pain in the joints and all. The second point that you elucidated, DHEAS, yes, that is decreased in drug-induced adrenal insufficiency, and so symptoms of hypogonadism, symptoms of infertility, subfertility is seen in drug-induced adrenal insufficiency. In drug-induced adrenal insufficiency, we usually do not find electrolyte imbalance. Like we know, low sodium hyponatremia and hyperkalemia are important signs, important biochemical parameters which point towards adrenal insufficiency in cases of primary adrenal insufficiency. But that is because aldosterone, if the gland is destroyed, then you have that aldosterone deficiency. But in cases of secondary adrenal insufficiency, where there is a defect in the pituitary or hypothalamus that leads to adrenal insufficiency or drug-induced adrenal insufficiency, you do not have these florid or characteristic sodium-potassium imbalance because of the fact that the sodium-potassium balance is also maintained by the renin-angiotensin-aldosterone axis, which is not, so sodium-potassium is not just regulated by glucocorticoids. You have another axis which maintains this balance. So that could be another point, having a normal sodium-potassium, yet features of fatigue, asthenia, poor appetite, and all these, that could point towards drug-induced adrenal insufficiency.
Thank you, Neil.
Rather than primary.
Thank you. Dr. Shukla, please.
I just wanted to elaborate the quiz that you asked. The nasal, inhale, topical, oral. Oral I could understand, 3 I could not. So I think I would appreciate if you explain that.
So which 3?
The nasal steroid, the inhaled steroid, and the topical steroid. Which is worse, which is safer?
So that the question was which is the least. So usually topical and intranasal, they have the least potential to cause adrenal insufficiency. But again, it is said in literature that if you are using topical steroids over a large surface area, especially when the skin is thin, where the chances of systemic absorption of the topical steroid is very high, and that too for a very prolonged duration. Like in that patient, he was using for prurigo or generalized prurigo for the past 1 year. So that could lead to adrenal suppression. But inhaled, I mean the intranasal.
A small quick point I'll make here, because I'm not aware of, but inhaled steroid is seen that without hampering the hypothalamic adrenal axis, they cause osteoporosis. Those who are on long-term inhaled steroids, if you look at the bones, many times the bones are significantly osteoporotic.
Thank you, sir.
Dr. Ipshita, yeah. I wanted to know whether there are guidelines when we should check TFT in patients on immune checkpoint inhibitors.
There are no consensus guidelines at what point of interval you should check. What has been seen is as early as 2 to 3 weeks, as late as 60 to 70 days, both hypothyroidism and hyperthyroidism can occur. So once you have started the drug therapy, we routinely do not do we do not identify the risk factors where they would have a thyroid dysfunction, especially we do not screen for the antibody positivity autoimmune status per se whenever we start the ICPs or the TKIs. But yes, if you can do a background TFD and if there is subclinical hypothyroidism right from the beginning, so those are the patients where you need to monitor. Maybe after 6 to 8 weeks, you can repeat and see how they are doing. Thank you.
Thank you. Sir, Professor Chaudhary is with us. Sir, do you have any comment on that topic?
Not on that. Maybe a couple of quick comments about the steroids. With high-dose pulse methylprednisolone that we've been using, endocrinologists, the degree of adrenal suppression is very little, despite using 500,000 milligrams every week or whatever. So that's one observation. The other is the recovery. I mean, yesterday only Dr. Gary Hammer did suggest that within 1 to 2 years you have recovery. But there are so many individuals who probably never recover their adrenal function. That's what something we need to remember. About the prolactin, quick ones. One is about PPI-induced hyperprolactinemia. If the prolactin is really high, more often I think it's a prokinetic added with the PPI, the DSRs that we see, those are more implicated than the PPI itself. PPI can, of course, cause. The second is when we talk of drug-induced hyperprolactinemia, of course, the guidelines will suggest you stop the drug and then recheck in 72 hours. Let us remember that human body differs from one to the other, and so if at 72 hours, if the prolactin is still not normal, but has come down, please do repeat again, maybe after 2 weeks, even after a month. I've seen patients recovering their prolactin levels only after a month. And what was that? The third point is about mild prolactin elevations, which may not cause menstrual disturbance, may still cause luteal phase dysfunction. So we may say the gynecologist started on prolactin just because it's 35 or whatever, and maybe we deride them. I think why they started, we do not know exactly, but that mild prolactin elevation may still cause subfertility, infertility. So that may be an indication for starting cabergoline even with mild elevation, if that is the underlying cause. Sorry for taking so much time.
No, sir.
Thank you, sir. So it is a time for last question. I think Dr. Umakanto, please.
So my question to Dr. Nilakide, madam. So how will diagnose mifepristone-induced AI?
So it's the context, the history that the patient is taking mifepristone, and that cortisol estimation would not really help. So how we treat drug-induced adrenal insufficiency with mifepristone is by using a still higher dose of glucocorticoid. So that overcomes the glucocorticoid receptor block, which is there with mifepristone. So it's the same.
Ma'am, is there any clear-cut guideline in patients who are using long-term PPIs and domperidone, after how much period we should retest the prolactin level? First one and second one, I'm a physician, not an endocrinologist actually. When should we suspect a male patient with hyperprolactinemia, ma'am?
Nowhere it is written that this much duration of PPI intake or domperidone intake or metoclopramide intake would lead to hyperprolactinemia. There is no indication, and there is no recommended time period as of, because some patients develop hyperprolactinemia after 2-3 months of use, and some may not develop after years of use. So again, on clinical judgment, and if there is any clinical evidence or any disturbance like infertility, subfertility, as sir has already mentioned. So many patients, for like female patients, will be referred from IVF centers for hyperprolactinemia, my hyperprolactinemia. So in those cases, we take a history, and retrogradely we come to know that yes, this was the history. So in history taking, but per se, if sir can put some light on this, but no definitive time period of, because I have seen patients, I have been seen diabetic patients who are on years of PPI intake, but then still their prolactin levels are not very high. So difficult to say.
Ma'am, when should we suspect male hyperprolactinemia?
See, any subfertility, erectile dysfunction, hypogonadic symptoms, then we should do a prolactin levels, even in
So I think that question was already answered. More than 20, madam, I said already in the beginning. It was. Said.
Yeah, even
I
some-
think
Mhm.
we've had
Thank
a
you, ma'am.
fantastic session, and something which is very commonly seen in our OPD practice. So on to the next sessions now.
Thank you. Thank you. Kaushik, please.
Moving on to the next session, Byzantine bone. And to chair the next session, I would like to call upon stage Dr. Umakanta Mohapatra sir and Dr. Vimal V sir on stage, please.
Good afternoon, everybody. Welcome to the session on Byzantine bone. So in this session, we have three speakers. The first speaker is Dr. Amiya Joshi. He is Director and Diabetes and Endocrine Clinic, Mumbai, recipient of IDF and European Society of Endocrinology Young Scholar Award. He is the past Secretary of Moha Endocrine Society and Scientific Secretary of ASICON 2015-19. So with these few words, I would request Dr. Amiya Joshi to speak on your topic, sir.
Headquarters of the hospital is actually in Bengal, in a town called as Mayapur, 3 hours from here. There are certain topics that are beautiful. There are certain topics that are thoughtful. But occasional topics can actually be painful. And that's the specialty of my topic. I mean, the physician is glucocentric, the nephrologist is creatinine-centric, and the patient actually comes to voice his problems or her problems when the pain comes to the fore. Another painful aspect is the gold standard for the diagnosis is a bone biopsy, which is almost not available except in select centers and not done in most of the patients. So there always remains a gap which doesn't affect the treatment on ground, but always leaves this little pain in mind that we are kind of lacking something. However, what is interesting is a change in the perspective that has happened. And I always feel as an endocrinologist, it's a privilege to manage diabetes because it just gives you a 360-degree view of what is going on beyond glucose. A problem which was actually identified as osteodystrophy has now manifest as a syndrome of 3 characters. One which is actually in the blood. So that is about the bone mineral changes. The second is which is in the bones, that is the changes in the bone morphology. And the third, which is actually a change in the heart or the circulation. And that's about vascular calcification. The thing doesn't end here. It's not only about vascular calcification, it's about another form of insult that is going on in the cardiovascular system, which is again beyond the bone and the mineral, and we'll come to that. But tune your minds that whenever you are looking at a CKD, MBD, your job is to not only heal the bone, but also make sure that the heart doesn't go for a toss. And I must tell you one thing, that we are tuned to look at renal and cardiovascular outcome trials, and very few of our renal patients actually die of renal death. Most of them actually die a cardiac death. And so it's always important that we look at cardiovigilance. Now before we proceed to what we do actually, let us tune our mind to what is going on. What we have been looking at is calcium and phosphorus levels, which we must look. What we have been looking at is PTH and alkaline phosphatase or BSAP, which also we must look. But we should also be aware, if not in a position to measure always easily, is that other cornerstone which drives the systemic effects is a rise in FGF23 and a resistance to FGF23, because there is a reduction in the levels of FGF23 receptor, that's clotho, and there is formation of calprotectin particles, which finally result in vascular calcification. So this is what was the hypothesis, a classic trade-off being replaced by another trade-off where your hyperphosphatemia, hypocalcemia pathway also gives a branch called as FGF23 pathway, which further reduces the activity of 1-alpha hydroxylase, further complicating the picture and adding the systemic angle. Now this FGF23 results in ventricular hypertrophy. So if you get a 2D echo of a person who is getting CKD MBD on a long standing basis, you will actually find that the heart is little bulky, valvular and vascular calcifications are visible, and a myriad of systemic features including the inflammation that drive the whole thing. So always remember that when you are dealing with CKD MBD, we have to look at three things: the bone morphology, the bone minerals and the vascular status. And never forget to look at the vascular status, because most of the times that will be the defining factor that determines the patient's lifespan. So obviously what we have been looking at or what we have been doing, let us start and begin with that. And that's about the calcium and phosphate. We know that as the nephron number starts reducing, the first change that happens is rise in phosphorus, or the ability of the kidney to excrete phosphorus is reduced. So the phosphorus level starts going up. The ability to activate vitamin D goes down. So as a result of that, the calcium level starts going down, the PTH level starts rising, and there is a resistance to the PTH. The rising PTH and the rising FGF23 are one of the important determinants of progression of the CKD as a whole. So in a nutshell, we are looking at a pathology which has mainly biochemical abnormalities which we see: calcium, phosphorus, alkaline phosphatase, PTH, but also vitamin D to an extent. A bone, look at three things in the bone: turnover, mineralization and volume, and the patient will have bone pain and fragility fractures. And the third is actually a heart and circulation, that's extraskeletal manifestations which we see by vascular calcification. Now we looked at three things in CKD, we looked at the three parameters that we will be looking at. We looked at three things in the bone, that is turnover, mineralization and volume. But let us now look at three other important things which actually can suddenly derail the way where you are looking at the bone. And that's a dynamic bone which is caused by the disease, that is diabetes or an inflammatory disease that is contributing to the CKD, the inflammation at the tissue level and the therapeutics that are going on. And it's a very delicate balance, because at times it is not unusual to see that a lot of calcium supplementation has happened, the PTH has gone low, and suddenly the cause of fracture is not your classic pathway, but this adynamic bone that has happened. To put this in numbers, a decade ago, less than 10% had adynamic bone, but the newer literature pegs that as much as 20 to 40% could actually be having a dynamic bone. And then this is about the vascular calcification, which depends upon the calcium and phosphorus product, resulting in amorphous to crystalline transformation of the calcium crystals and finally vascular calcification. Now what we will monitor hands-on is calcium phosphorus. It's economical. Do it 6 to 12 monthly in the beginning, but as you progress by stage 5, it's almost done on a monthly basis. PTH, which used to be done at baseline and then 6 to 12 monthly as we go to stage 4 is now advised to be done 3 monthly. And at least some couple of studies done in recent literature contradict the 2011 view of 3 monthly PTH giving way to monthly PTH, giving to better survival and renal outcomes. Bone specific alkaline phosphatase again is a strong marker of turnover and needs to be done similar frequency as PTH. FGF23 in a research setting can be done, but again our therapeutic armamentarium is less. And finally, we have to look at so many things in the patient, so we have to prioritize what we do. These are different guidelines which have put up different perspectives, but the core practice remains the same which we discussed in a nutshell. Now let us look at what happens in the bone. We first looked at minerals, second we looked at the bones, and there we will look at turnover, mineralization and volume. The classic disorder is osteitis fibrosa. The second is an adynamic bone, and then you can have osteomalacia and then a mild form pertaining to both, that is uremic osteodystrophy. Now this is what you will typically see, and that is what a biopsy will tell you. And as I said, that biopsy is something that is done in select settings and lacks access to most. Now let us, before we move on to the treatment part, summarize the 3 things that we will look at. We will at the end of evaluation classify the person having a high turnover or a low turnover bone. A high turnover bone will be seen in majority, where you will typically have a low normal to normal calcium, a phosphorus which usually is little high, a PTH and a elevated BSAP are your main enemies that will define the high turnover bone. Your treatment will be guided by these, where players like calcimimetics as well as calcium based phosphorus binders will be your key armamentarium. And again, if the patient is on dialysis, you have to keep the calcium concentration balanced. Whereas if you look at a low turnover bone or an adynamic bone, you will actually see that the calcium levels may be little higher or normal, and your choice of phosphate binder that you use will be a non-calcium based phosphate binder. If you decide to treat the bone in this group of patients, your PTH level will typically be below 2 times the upper limit of normal, and teriparatide becomes a option that can be used, though in a guarded manner, monitoring, but it becomes an option in this group. Whereas in your high turnover group, denosumab remains the mainstay of therapy once the eGFR falls below 30. So this is what you should be completing at the end of your evaluation, that whether the bone is high turnover or low turnover, determined mainly by your PTH and the bone specific alkaline phosphatase. And then you will decide what you will decide: how to correct calcium, how to correct phosphorus, and what to do to the bone to improve the quality. But it will be determined by the mineral and the turnover status. To give you a brief glimpse of this is how the bone looks, and we have, this particular audience is accustomed to it. What I would like to tune your mind is that as you look at the bone, also look at the calcification that could be seen in the soft tissues and the vessels around, and that again is a good marker for you to know the vascular health. So this is what about the treatment is. What you will see is a state of low calcium, high phosphorus, high PTH. What you have to do is balance calcium, balance phosphorus, balance PTH, avoid over treatment at all costs, and finally keep the alkaline phosphatase normal, and PTH 2 to 9 times the upper limit of normal. Now this is probably first thing in the armamentarium, because first change is rise in phosphorus. First thing you should look at is normalizing the phosphorus, because that's good for the vessels. Again, recall, high turnover bone, you will probably prefer a calcium based binder, and calcium carbonate and acetate are used. If your calcium level is normal to high, you can actually prefer acetate. Remember not to use citrate, because citrate increases risk of aluminum toxicity. 2 candidates which can be used in a dynamic bone or the state where calcium is normal to little higher is sevelamer and lanthanum. vascular outcomes are better with sevelamer. It also helps reduce your cholesterol levels and is anti-inflammatory. In a patient with concurrent anemia, you can actually go for iron-based binder, which is actually quite costly, sucraferric oxyhydroxide. And aluminium-based binders we don't really use, but they can be used in a desperate situation. What is interesting is the emergence of magnesium as a tool, both for reducing the phosphorus and reducing the vascular calcification. Your hidden friend here is actually a calcimimetic, which also helps to reduce your phosphorus to an extent. Vitamin D analogs also we have to use in a careful manner. They help you bring up the calcium. Remember, if your calcium is high, normal or high, do not go by vitamin D analogs, simply correct the vitamin D. But if your calcium is low, you should use calcitriol, or in a select setting paracalcitriol, again not widely available. But then calcitriol also can be used in a guarded manner. If you are using it IV, alternate day is an option. If you are giving it daily, 0.25 to 1 microgram is the dose. We have to adjust it, but monitor. I prefer to monitor after starting the person on calcitriol till the patient is on a stable dose, at least monthly. Later on, you can reduce the frequency of monitoring. Now, cinacalcet had a lot of use, at times a hype also, but it remains a useful medication to actually get your PTH in your desired range, that is 2 to 9 times the upper limit of normal in stage 5 CKD. The EVOLVE trial did not give mortality benefit, but did give benefit in terms of reducing the calcification and reducing the PTH by these calcimimetics actually even helps you lower the phosphorus a bit, because the renal aspect of phosphorus reabsorption is also affected here. Etacalcetide is actually one thing that is on the horizon, and evocalcet, mainly Japanese literature for better GI tolerance. Etacalcetide is IV given, again I mean used in select setting, not widely available. This is about the PTH, I discussed that, but the main driving factor for treating hyperdynamic bone is actually correction of PTH. Remember one thing, before going on to an anti-resorptive, in a hyperdynamic bone disease, it is very important that you address the PTH first and then go on to the anti-resorptive pathway. Bone density is now more and more accepted even by the Nephrology Society guidelines as a useful tool, which they were not keen to use on, because it actually gave you an idea about fracture risk also, and so all deserved should go for BMD. But beyond that, anyone who is keen on transplant, anyone on immunosuppressive therapy, anyone with a pathological fracture, you should remain open to do a DEXA even at an earlier age. What DEXA tells you is mineralization. What DEXA doesn't tell you is the turnover. And so DEXA has a limitation, but still remains a useful tool. FRAX holds good up to stage 3, but this particular study by Whitlock also endorsed its use in stage 3 to 5 and is recommended. It's like something better than nothing. It again doesn't take into account the duration of the disease and the turnover of the bone, but still gives you a reasonably better idea about the fracture risk. About bone biopsy, as I said, it ideally should be done before you give any anti-resorptive. It ideally should be done when there is unexplained pain and fractures, and it remains the gold standard, but our experience remains limited. Now, this is a consensus statement by Indian Society of Nephrology about management of CKD and MBD, recently released 2025. So, anybody with a T-score poorer than -2.5, look at the turnover and decide the therapy. High turnover bone, anti-resorptive; low turnover bone, consider anabolic agents like teriparatide. Remember that bisphosphonates cannot be used or should be used with dose adjustment and extreme caution when the eGFR falls below 30. So what remains with us is denosumab. 1 in 4 of your patients whom you give denosumab will have a reasonably bad hypocalcemia. So keep that in mind at 7th day post treatment, without fail ask them to do a calcium level, and denosumab is not like a, we have that we give it and forget it. It's not like that. It is probably a drug that needs to be used with utmost caution. And then teriparatide, we discuss the role. I will just share an anecdote that my surgeon friend once called, that I have a patient who actually have been referred for parathyroidectomy, and the patient is actually due for transplant. So I think the MBD will itself correct. I told him actually the patient whom most of the times I have been telling you not to operate and send the patient to me first, here I am telling you to operate because the health of the transplanted graft will actually depend on the status of the PTH and other bone mineral axis. So actually transplant with a hyperdynamic bone is an indication for parathyroidectomy. Beyond that, remember that PTH more than 900 to 1000 with best medical management under close supervision and intractable bone pain or mineral abnormalities is a reasonable indication for parathyroidectomy. At least my endocrine surgeon and I have zeroed down on the fact that we operate 3 glands and leave 1 gland with a marker in situ, because that whole idea of removing the 4th gland and transplanting it in the forearm, we didn't find it very comfortable and useful. Vascular calcification, I will suggest do a CT and if possible tell them to screen from carotids to the abdominal aorta in one go, minimum radiation exposure, you get a very good idea. And we try to correlate it with NT-proBNP because you will see broad calcification. Whether it is an obstructive calcification and is affecting the cardiac hemodynamics, NT-proBNP can help you interpret it better. And then there are investigational agents for preventing the vascular calcification and emerging strategies like FGF23 antagonists, clotho restoration strategies and calprotectin particle inhibitors. And obviously we need a multidisciplinary management. So in a nutshell, CKD MBD is a silent disease. By the time it starts being discussed, the pain has already started. We have to interpret it in terms of 3 things: minerals, the bone and the vessels. We always have to assess the bone turnover other than other parameters, and frax and DEXA, though not be as helpful as in general population, still remain useful tools. Hyperdynamic bone, correction of the mineralization of the mineral parameters and anti-resorptive, a dynamic bone, anabolic. Remember that we have to lower phosphorus, maintain calcium and keep the PTH in a normal range. Thank you one and all for your patient listening, and it was great being here.
Thank you, Mayor, for the excellent talk, making a very complex talk looks very simple. We can have the discussion at the end of the talk and you can sit here. So now it's my proud privilege to invite my dear friend, Dr. Pradosh Gangadhar, who is the senior consultant and pediatric endocrinologist at Aston MIMS Hospital at ICRA Hospital, Kozhikode, Kerala. And he has done his DM in endocrinology from PGI, and he has got vast experience of around 15 years in managing metabolic bone disease and other endocrine diseases. He has authored so many chapters and 15 index publications is there. And he is the organizing secretary of Mendo's Update, our organization of 2025 and 2024 and 25. He is currently the secretary of Malabar Endocrine Society, and he is the scientific committee chairman of Kendocon 2024. And he has got areas of interest is hypernatremia and metabolic bone diseases, and he's an expert in the field of metabolic bone diseases. Over to you, Dr. Pradosh.
Thank you, Dr. Vimal. At the outset, I'd like to thank ESICON 2025 organizing team for inviting me for this prestigious conference to the City of Joy, back again. So I'll be speaking on TMP-GFR, and I will be dealing with the critical appraisal of this measurement, and let us see. So I start with the clinical presentation. The font has been changed a bit. I don't know what happened to the slides. So we have got a 23-year-old lady with history of seizure disorder. She was on levetiracetam, 500 milligram twice daily, and she came with generalized bone pain, backache, and difficulty in walking for 2 years, and she was born out of non-continuous marriage. And her initial evaluation, as you can see here, showed vitamin D deficiency with secondary hyperparathyroidism. And you can see that her calcium is 8.93, phosphate is 2.3, and ALP is suggestive of osteomalacia. And she received cholecalciferol and replacement, and her osteomalacia-related symptoms and hypophosphatemia persisted. You can see her repeat phosphate was 1.25, and she underwent further evaluation. You can see that I ordered urine phosphate, urine creatinine, plasma phosphate, and plasma creatinine. So the purpose of evaluation is to calculate TMP-GFR and TRP. We will come to what is we are going to see with this measurement. So this is the classical Walton-Bijovit nomogram, which published in Lancet in the landmark article in 1975, which is a graphical tool to estimate TMP-GFR, where the maximum rate of renal tubular resorption you can see that we are measuring it with the unit of glomerular filtrate. So this is basically a measure where you can estimate the maximal rate of tubular resorption from the proximal tubule. I will come to the basics of this. So you can easily calculate from this graphical tool. Once you have patient's actual phosphate concentration and you know the TRP of the patient, you can just draw a ruler and you can see that what is the basic TMP GFR of this patient. You can see that if the patient's plasma phosphorus is 1.2, and you can see if the TRP is 0.8, and if you draw the diagram, you can see that TMP GFR comes around 1 milligram per deciliter. So this is a way you can easily do with a graphical tool, but you can do it with a calculation method for which you need to calculate TRP first. TRP is the fractional tubular resorption of phosphate, and then we have to apply the Walton-Bijovit correction. If there is increased phosphate resorption, you can see that if the phosphate excretion is minimal, you need to apply a curvilinear correction. I will come to that in the coming slide. So they thought it was due to a splay effect in tubular resorption of phosphate. Actually, there is a splay effect that is explained for tubular resorption of glucose, where glucose is absorbed nearly completely from the kidneys. So here they thought that they just applied that tubular resorption equation for the glucose correction to phosphate. But we have to really see whether there is a real splay happening with the tubular resorption of phosphorus or not. I will come to that. So here you can see that this is the formula, and first we calculate TRP. TRP means 1 minus that fraction excretion of phosphate through urine. So you will get the TRP, and if you make it into the percentage, you will get the normal percentage more than 85%. That means that more of the phosphorus is getting reabsorbed into the proximal tubules. And then we apply the formula and we can calculate the TMP GFR. If, say, patient's TRP is more than 0.86, you need to do the corrective applications as we explained here. Now, just go through the phosphate homeostasis a bit. You can see that in intestine, we take food 20 milligram per kg per day, around 7 milligram per kg excreted through the feces, and you can see that intestinal absorption happens here with the contribution of digestive juice. And in phosphorus pool is predominantly contributed by bone and kidneys. And you can see that there is a redistribution happening in the tune of 3 milligram per kg per day. So that urine, you can see that 30 milligram per kg per day is getting excreted. So in kidney, 3 major hormones contribute to excretion of phosphorus. So this is not actually the tubular resorption as we thought in glucose. This is the regulation by this hormone lead to that splay effect. This is not the classical splay. This is a splay-like effect due to hormonal regulation and other physiological factors. I will come to that. So if there is diseases that leads to or affect this hormonal regulation, that can lead to phosphaturia and hypophosphatemia. If there is poor intake or decreased absorption, you can get hypophosphatemia. So TMP-GFR actually helps you to differentiate these two disorders. And if there is hungry bone also, you will get hypophosphatemia. So redistribution can lead to hypophosphatemia. So the different mechanism can happen. I'll briefly go through the hormonal regulation. You can see that there is a differential effect. Though FGF23 and PTH acts to the proximal tubule, there is some difference in mechanism. They actually act on the sodium phosphate co-transporters, and they leads to inhibition of this receptor. That lead to excretion of phosphate through kidney and reduce phosphate reabsorption. You can see that the FGF23 actually inhibit active vitamin D, while PTH stimulate active vitamin D. This is the differential effect you need to know regarding this hormones action. So these 3 hormones are essential, but predominant action is through PTH and FGF23. Again, going through the further physiology, you can see that this is important point. PTH, you have got direct receptor on the proximal tubule, but this is a catch here. The clotho expression is more on the distal tubule. So whatever effect of FGF23 happening in the distal tubule, but once the FGF23 clotho acts on the distal tubule, there is some paracrine signaling that we still don't know how it acts on the proximal tubule. So it indirectly, through the paracrine signaling, increases the phosphate excretion through the proximal tubule. So this is the differential effect in the tubules. So that's one key point probably we need to look into. So these two important points we remember, and phosphate reabsorption usually happens 80 to 85% in the proximal tubule. There is no phosphate reabsorption happening anywhere else in the tubule. So 15% probably is getting excreted through the kidney. So this is a mechanism you need to remember in the physiology regulation. So in physiology, phosphate homeostasis regulation by diet, kidney, bone, and hormones I discussed. Key hormones are PTH and FGF23, vitamin D minimal role, and these are the co-transporters that is important in the proximal tubule, and GFR influence of filtered out. If there is advanced CKD, it can affect the phosphate kinetics. Now, important point, how will you collect sample for this TMP GFR? This is an important point in practice. Fasting is needed. The patient should fast overnight, no food, only water. And second morning void urine sample is important. So you discard the first morning void, collect the second urine sample at 1 to 2 hours later in a clean preservative-free container. 4 to 25 ml of urine is required. Then serum sample generally drawn 0.5 ml of blood at exact time. But in the current 2025 recommendation for XLH, X-linked hypophosphatemic rickets, they states that you can collect blood sample within 2 hours for phosphate and creatinine estimation. It's not mandatory, exact time is needed. You can bit adjust because it's practically sometimes difficult for the labs to collect the exact time. So label both samples with the patient details then at the time of collection. Now, in the past, people are recommended 24-hour collection and 2-hour morning collection. That whether it is needed or not. Exact 22-hour collection is not needed because ratio-based method. So TMP GFR actually corrects this based on GFR. So we don't need the timed collection here. And a fasting second void is important, and it minimizes the dietary and diurnal effect. Actually, phosphorus serum value will come down after taking food. So that is why we need to take it in the fasting. Then accuracy, paired urine serum samples under proper condition will give reliable results. Now, in the past, there are timed collection, 24-hour and 2-hour. Now it's obsolete. We need only spot collection. This is the latest recommendation in JZM 2025 on XLH. They recommend calculating TMP GFR per glomerular filtration rate using a spot fasting urine sample and paired serum sample. And 24 collection is not mandatory, but in some situation you might do it. Now coming to the online calculators. Previously I used to calculate this with the calculators. It always lead to a lot of errors. So what are the online calculator options? So there are 3 important calculators if you go through the literature. This is the most validated one, ASTB, ANZ, BMS. You can see that this is the Australasian Association of Clinical Biochemists and BMS, Australian, New Zealand, Bone Mineral Society calculator, all use Walton-Bijovet calculation method. But you can see that for pediatric adult endocrinologists, this is the best one because it can do both calculation. And this is more validated with the IDMS aligned creatinine. While ESPN is a European calculator, again it's pediatric focused, and GPN is again a pediatric focus and common in pediatric use in Europe. I will come to that. And this is the most validated because I already mentioned it uses IDMS aligned creatinine, and it provides automated interpretive comment across both pediatric and adult reference ranges. You will get both reference ranges in different age groups. It flags results against harmonized age-specific cutoffs, greatly aiding clinicians, and is applicable to pediatric and adult cases. So these are the important benefits of this calculator. I recently came to know regarding this calculator because thanks to the invitation for presenting this is a very important tool. So I will just apply this to the online calculator in our patient data. You can see that these are the 3 important calculators I mentioned. If you Google it, you can find that and just apply the data. You can see that I applied my patient data here. You get the results here. TRP is 72% and TMP GFR is 0.7 millimole. It gives value in millimole, but you need to correct it by 3.1 is the correction factor. It will come as 1.15 milligram per deciliter. That indicates that for her age, it is a low TMP GFR. So this is millimole. So you need to correct it into 3. So this will give you a lot of things. So it's very easy. You don't have to do a calculation and you need not go wrong with the calculation. That's one way of going wrong with the TMP-GFR calculation. This is the GPN, German calculator. Again, there is no age, simple calculator. You will get both values, TMP-GFR in milligram as well as if you want milligram per deciliter directly, you can use this calculator, but it's a pediatric focused calculator. And another one is the ESPN, the European Society of Pediatric Nephrology calculator. There are other points you can see, but there is some limitation here. Age cutoff is 18. My patient age is 23. I cannot increase to 23. So you will get a probably lower value TMP-GFR. So that's an issue, but you will get a lot of additional things, calcium creatine ratio and pediatric reference range based cutoff. So if you want to look into that aspect, you can use this calculator. So there are a lot of benefits with that. Now, coming to the controversies in phosphate evaluation, I will ask the one question, do we really need TMP-GFR here? What current algorithm in hypophosphatemia recommends and relevance of TMP-GFR and emerging alternatives, because there are some algorithm now comes with fraction excretion of phosphate and TP-GFR. I will come to that, what is TP-GFR. So if you go to the Williams recommendation latest edition, you can see that still Williams recommends in hypophosphatemia, TMP-GFR is the ideal one to look for. You can measure TMP-GFR as we mentioned currently. Even recent XLH guidelines, TMP-GFR and TRP is the most important things to assess hypophosphatemia. But if you look at up-to-date, which is a good platform here, and there are some other algorithms put forward by these authors, you can look into that. You can see that in hypophosphatemia, they actually ask for fraction excretion of phosphate, not TMP-GFR, along with 24-hour urine phosphate excretion. If it is less than 100 and less than 5%, that indicates that there is appropriately low kidney phosphate excretion. And if fraction excretion is more than 5 and 24-hour urine phosphate level is more than 100, either of these, you think you have to consider renal phosphate wasting. So you may not need TMP-GFR. This is a simple calculator you can do. There are a lot of calculators for fraction excretion of phosphate. In our patient, you can see that her fraction excretion of phosphate comes to 28. But interestingly, the reference range for increased excretion in both these calculators is more than 20%. But the algorithm says more than 5% you can consider. So there are still need to be some standardization to be done here. But our patients definitely has significant phosphate excretion with this calculation. Now, what is TP-GFR? TP-GFR is tubular phosphate reabsorption per GFR. It is not the maximal tubular maximum phosphate reextraction. Is a usual physiological tubular resorption per unit of GFR. So this has got a simple formula in comparison to TMP-GFR. You just need serum phosphate, urine creatinine multiplied by serum creatinine. You can easily calculate that. And I made actually a calculator. If someone needs that, you can contact me. It's a TP-GFR calculator. For our patient, I just entered the data. You can see that this is giving a value of 1.14. That means that TP-GFR is again low, consistent with increased phosphate excretion. So in the kidneys, and this patient has phosphate loss through kidneys from the proximal tubule. So what are the important caveats of TP-GFR versus TMP-GFR? TP-GFR actually captures the real-time phosphate reabsorbed relative to filtration, reflecting the current hormonal and physiological influences rather than assuming a fixed maximum. It's more reliable and effective for tracking true phosphate reabsorption and loss, simpler and more accurate in assessment for phosphate handling in practical setting. I already mentioned TMP-GFR use mathematical correction to correct that basically the splay effect that is not there for phosphate reabsorption. So it initially modeled after glucose transport splay. So that was not correct actually. But there may be some physiologically meaningful changes due to hormonal variability, obligatory excretion of phosphate, and individual set point differences in phosphate excretion. So this is probably lead to splay-like effect. That is why TMP-GFR got still a relevance in practice. Now, why this is important? Because if you measure TMP-GFR, it will overestimate the real maximal reabsorption, especially if the phosphate X clearance is very low. So recent literature supports that TP-GFR may be equally or more accurate in pediatric setting, and this aligns with the current recognition that phosphate transport mechanisms are less dependent on splay. So splay probably effect by the Walton-Bijovit correction was not ideally needed. So this is important take-homes. Why not TP-GFR now? Because it's an easier calculation, but it's not been universally adopted into calculator. Probably I first time hearing this for the preparation for this presentation. Nobody knows about this. And the Walter-Mijot method is historically entrenched, widely validated across population. So TPGFR is less widely known for fewer standardized references exist across age group. So that is why TPGFR is not done nowadays. Probably it will be the future thing we will be looking to. Coming back to our patient, you can see that her values come low TRP 71.9 and TMP-GFR is low 1.4. That indicates she has a phosphate leak through the kidneys. And you can see that her FGF23 is high. And she was evaluated for genetic causes considering her age, and she underwent a genetic evaluation. You can see her images. She had some interesting finding here in the spine. She has insufficiency fractures in the pubic rami and fibula. And you can see that she underwent even a gallium scan from some other center. It was negative. And this was her diagnosis from the genetic screening. She had clinical exome sequencing revealed heterozygous ENPP1 mutation, that is autosomal recessive hypostemic rickets type 2. Probably not not much reports from India. You can see that it encodes a particular enzyme that generates pyrophosphate by degrading adenosine ATP. So it leads to increased calcification in many areas. So you can see that there is a posterior longitudinal calcification here. That's a clue for this rare condition. And it can happen in adult XLH. And these are the clinical clues for this condition, rare condition in practice. You can see progressive calcification in the arteries, posterior spinal ligament, periarticular calcification, normocalcemic multiglandular primary hyperpara, hearing loss, pseudoxanthoma elasticum, and enthesopathy. If it is anything is present, it can happen in adult XLH as well. So what are the clinical utility of TMP-GFR? We can look at tumor-induced osteomalacia, X-linked hypocytic rickets and ADHR and ARHR and Fanconi syndrome all needed. There are some emerging indications like heart failure, it's a prognostic marker, and renal donation, actually donor TMP-GFR predicts recipient outcome. So these are the new things for the TMP-GFR. Now, in pediatrics, especially for genetic hypocytic disorders, it's an important thing. But in my practice, now finding some relevance in prematurity related BMD, MBD of prematurity, which occur in very low birth weight, early preterm babies like less than 28 weeks, and very low birth weight means less than 1.5 kg birth weight. So if there is some dilemma with the ALP and phosphate level, you can see that TMP-GFR less than 3.5 and TRP more than 95, which indicates that probably this patient will have probably severe phosphate depletion, and that will help you to diagnose this condition. So these TMP-GFR can be implemented in neonatal ICU for these rare conditions. Now, final slide, I did a SWOT analysis. That means strengths, weaknesses, opportunities, and threats. You can see that there are a lot of strengths. This is a gold standard measurement, and it effective across pediatric and adult population, but weaknesses are depend on timing and fasting. The collection may not be practical in some patients and unreliable in advanced CKD. And threats are there is limited awareness, misuse of outdated calculators and errors due to calculation, and declining use in tertiary care. And genetics sometimes might replace, and TP-GFR may replace this TMP-GFR in future. And opportunities, there are a lot of opportunities with transplant, heart failure, and newer indication coming up, and MBD of prematurity. So I summarize and conclude this session with the strength, physiological, practical, gold standard measurement for renal wasting. But weakness, it's a protocol sensitive, CKD limitation, opportunity, digital calculators useful, and AI integration can be a good tool. Threats are declining awareness, misuse, and reliance on genetic tests. Thank you. Thank you all for patiently listening. Thank you.
Thank you, Dr. Gangadhar, for beautiful presentation of a difficult topic. Sir, please join us. So it's a time to introduce Dr. S. Ramkumar. He's the consultant endocrinologist of Sabita Medical College, Apollo Hospital, and Dr. Ram's Diabetes and Endocrine Clinic. He had 10 publications in different national and international journals. He received the award of Dr. Balagopal Raju Award for Best Paper, Dr. A.B. Gandhi Award, Best Doctor Award of Tamil Nadu Government, ISPAD International Fellowship Award, and he is the founder of Turner Society, Turner Syndrome Society. With these few words, I would request to start on sclerotic bone disorder, the role of imaging to reach the etiology. Sir, start.
So good afternoon, everybody. Sincerely thank the organizing committee of ESICON 2025 for inviting me to talk on this one of the rare but interesting areas in endocrine practice, that is the sclerotic bone disorders. So I'll first discuss some of the basics on bone formation because that is useful for the classifying this sclerotic bone disorders. And about skeletal dysplasias, especially the sclerosing type of skeletal dysplasias, some of which are hereditary and some are non-hereditary, and also about the acquired disorders which can be metabolic malignancy, and how by looking at the typical X-rays we can identify these different forms of sclerotic bone lesions. So we read from our MBBS days the two types of bone formation, that is the endochondral ossification, that is basically for the long bones, and the intramembranous ossification for the flat bones of skull. And the main difference is the whether the cartilage is formed which is later converted into the bone or without the use of cartilage. So whenever there is an osteoblastic activity, there is a release of rank ligand and macrophage colony stimulating factor, which stimulates the osteoclast into the pre-osteoclast and then the multinucleated osteoclast and then into the activated osteoclast. And in the resorption pit, there is two things happen. One, the release of hydrogen ions causes the dissolution of the minerals, and the release of cathepsin proteases causes the degradation of proteins. So whenever there is a defect in the resorption, it causes osteosclerosis. So bone sclerosis by definition, it's any abnormal increase in the bone density on plain X-rays or CT. Sometimes you may also pick up in DEXA scan or in the MRI. So the simplest clinically useful way to classify sclerotic bone disorders is by identifying them whether they are focal or they are multifocal or diffuse. For example, you can look at this X-ray. So you can see a single lesion. The lighting one is actually the tumor. This is surrounded by the periosteal reaction. So this is a case of osteoid osteoma. This is another lesion. This is also in a different area. This is in the tibia and this is in the humerus. You can see the destruction of the cortex, and you can also see the tumor is elevating the periosteum. We can appreciate in the second, the left side one, elevation of the periosteum we can see. That forms the Codman's triangle and also radiating bone lesions. So what is common between these two lesions are, both the lesions are bone tumors. They present as involvement of a single bone, single area. So that is focal. So if you compare with this X-ray, here multiple bones are involved, multiple areas of involvement in each bone. So most typical example is a metastasis. Here we have the topic of interest is sclerotic, so we have the osteoblastic metastasis coming from two main organs. One is prostate and breast. There are also other reasons for multifocal sclerotic lesions, which I will come later. The third one is the diffuse type. So in the diffuse type, either the entire all the bones are involved, or in one bone the bone is completely involved. So how do you, the other way of classifying is based on the etiology. So this I said about the sclerosing skeletal dysplasias, that is can be subdivided as hereditary, non-hereditary, and the acquired can be subdivided as metabolic malignancies and systemic disorders. So the sclerosing skeletal dysplasias can be further subclassified. This is just to understand how they are classified. One is by whether they are disorders of endochondral ossification or disorders of intramembranous ossification, or whether it is mixed. In the endochondral ossification, there is a development of primary spongiosa which has to undergo resorption, and then the development of secondary spongiosa which has to undergo resorption. Failure in the resorption of primary spongiosa causes osteopetrosis and pycnodysostrosis. Failure in the resorption of secondary spongiosa causes osteopoikilosis or osteopatha striata. If there is a defect in the intramembranous ossification, it causes progressive diaphyseal dysplasia, hereditary multiple diaphyseal sclerosis, and hyperostosis corticalis generalizata. This is other way of classifying them, whether they are hereditary or non-hereditary. The hereditary ones, we know osteopetrosis and pycnodysostenosis, etc. The non-hereditary ones are intramedullary osteosclerosis and meloriostosis. So now we'll come one by one on the classical radiological findings seen with each disorder. I will not go into the theoretical aspects, we will just discuss the X-ray findings. The osteopetrosis, also called the marble bone disease. Here, this can be because of the mutations in the carbonic anhydrase or in the rank ligand or in the chloride channel. If there is a mutation in the cathepsin, it causes pycnodysostenosis. So in both the conditions, overall bone mass is increased, but here there is also the involvement of the medullary portion of the bone, so it causes pancytopenia. The osteopetrosis, we get the pancytopenia. The autosomal recessive type is very severe, is lethal. What we commonly see, what we see in osteopetrosis is the autosomal dominant form in childhood or adolescence. So if you can see in this first image, there is a uniform sclerosis of all the bones, the ribs. We describe it as marbled appearance. In this second image, we can see there is a sclerosis of the upper and lower end plates. So this description is called the sandwich vertebra. Another important thing is that it is a well-defined sclerotic sclerotic lesion in the upper and the lower portions of the vertebra. This is the typical description called Erlenmeyer flask deformity. We can also see multiple areas of transverse sclerotic as well as sclerotic areas. This is bone within bone appearance. In the skull, we can also see the sclerosis of the skull base. This is the Erlenmeyer flask used in the chemical labs. This is one of the typical description for osteopetrosis. So comparing with osteopetrosis, in pycnodysostenosis, there is no involvement of the medulla. So there is no pancytopenia, but they have a very severe short stature. This is you can see the preservation of the medullary cavity, which is involved in osteopetrosis. And here you can also see the transverse process is not affected in pycnodysostenosis. The most characteristic finding, this was during my postgraduate days, one of the typical X-rays that we are shown is the absence, the osteolysis of the terminal phalanges. This is one important or commonly told the differentiating feature between osteopetrosis and pycnodysostenosis. There is also sclerosis of the calvarial skull bones, obtuse mandibular angle, and lack of this paranasal sinuses. So three features differentiate osteopetrosis from pycnodysostenosis. One is the acro-osteolysis, second is the obtuse mandibular angle, third is the absence of paranasal sinuses. In addition, pycnodysostenosis, we have the normally functioning bone marrow. Then coming to the disorders of secondary spongiosa, here we can see linear striations. This is the pelvis, we can see the fan-shaped striations, and in the long bones also we can see that striations, these are like lines that run parallel to the long bones. This is described as a celery stalk appearance. So there is another condition which is also because of the disorder of secondary spongiosa. Instead of linear striations, here this is well-defined small spots. This is osteopoikilosis, spotted bone disease. You can see here in the humerus as well as in the iliac bones, multiple round, small, well-defined sclerotic foci, and this density will be similar to the bony cortex. Then coming to the second classification, the disorders of intramembranous ossification. I think we have seen some very rarely progressive diaphyseal dysplasia, Camurati Engelmann disease. Here you can see there is bilateral symmetrical hyperostosis of the lower limbs. The metaphyses and epiphyses are not involved, and there is sharp demarcation between the normal and the abnormal bones. So this is actually a disorder of intramembranous ossification, but the question is, why does it affect the long bones? Because the reason is the outer part of the cortex still develops from the intramembranous ossification. That is the reason. Here there is a involvement of the long bones. The other conditions are hyperostosis corticalis generalizata or endoosteal. The endoosteal means that is the inside portion of the cortical bone. This is because of the involvement of beta-catenin pathway involved in bone formation. The sclerostin, the SOS, the sclerostin and the Dickoff actually inhibit the WNT-catenin pathway. So when there is a mutation in sclerostin, it causes uncontrolled bone formation. So you can see here in this condition, there is abnormal bone thickening on the inner aspects of the inner aspect of the bone. Meliostosis, this is one of the, it has one characteristic description called the candlewax appearance. Here we can see the sclerosis on one side of the cortical bone, and it is typically described as the dripping candlewax appearance. I think this is shown in the metatarsal. The best way, X-ray would be the long bones. This is of the ulna. You can see the candlewax dripping appearance, and the typical thing is that can happen either on the inside or in the outer aspects. This is on the outer aspects. And there is one more condition called intramedullary osteosclerosis, where there is involvement of the medulla, but here there is no cortical thickening. So coming to the acquired osteosclerotic bone disorders, so there are multiple reasons: renal osteodystrophy, fluorosis, LRP5/6 activation, hepatitis C, hypervitaminosis A and D, milk alkali syndrome, hypopara, and heavy metal poisoning. I'll just describe one of the classical findings in the X-rays. So you just had some of the findings discussed by Dr. Ameya, osteitis fibrosis cystica, adamnic bone disease, and osteomalacia. But it is a paradox that in CKD and renal osteodystrophy, we can also have a osteosclerosis. This is one of the X-ray to show both osteosclerosis and the absence of excretion of the left side kidney. Maybe if it is observed even much in a closer look. So this is similar to the osteopetrosis. In osteopetrosis, we said the upper and the lower end plates will be having sclerosis. Here also it is very similar, but the typical description given is Rugger-Jersey spine. But unlike osteopetrosis, where it is well defined, here it is not that much well defined one. In addition, we can also see some periarticular calcifications in CKD. This is the Rugger-Jersey spine, the rugby player jersey spine. That is classically described in CKD. And coming to skeletal fluorosis, so I think we had, I think Prathosh sir was telling about the ossification of the posterior longitudinal ligament. So in fluorosis, we can have the ossification of both the anterior as well as the posterior longitudinal ligament. All the bones will be seen as osteosclerotic. We can see the intraosseous membrane calcification. I think you can see the arrow is not pointing. It's okay. And here we have at the insertions of muscle. There also we can get the calcification. And we can also see the calcification in the ligaments of the pelvis, that is the sacrotuberous as well as the sacrospinous ligament as well as the obturator membrane. Hyperparathyroidism usually have a lytic lesions, but there are some case reports of patchy osteosclerosis. And in hyperparathyroidism, overall the bone density is said to be increased, but we don't have any one particular area of sclerosis. And X-linked hypophosphatemic rickets, this is mainly described as enthesopathy. At the insertion of the tendons, we can have calcifications. And these are other reasons: heavy metals, hepatitis C, hypervitaminosis D, and also a whole list of conditions where we can have a patchy sclerosis. And I'll describe some of the important ones. The Paget's disease. We have the lytic phase, mixed phase and blast phase. In the lytic phase, you have the characteristic, the blade of grass appearance, well-defined lytic sharp border of the lesion. And in the mixed phase, we can have the prominence of the bone itself is thickened, there is cortical thickening, and there is the coarsening of the trabecula. Here, the one typical description seen in vertebrae is picture frame. So, unlike in CKD or in osteopetrosis, where the upper and the lower end plates are involved, here all the borders are involved, like a picture. So, this is called as the picture frame vertebra, and thickening of inner calvareal table and focal areas of cotton wool osteosclerosis is also described. So, you can see the entire bone is involved here. Compared to the left side, the right side, the entire bone is involved, and we can also see the cortical thickening and the prominence of the trabecula. This is also one of the case our radiologist wanted to post. You can see the prominence, to show the prominence of the trabecula. Here they also have the fracture here because of the Achilles tendon, because of the pull of the Achilles tendon. This is also to show, compared with the left side, the entire bone is involved. This is another condition, Erdheim-Chester disease. This is non-Langerhans cell histiocytosis of unknown cause. Here also we can see the cortical thickening with the narrowing of the medullary cavity, and also some areas of infarcts you can see. In sickle cell disease, they have a characteristic description of sclerosis called serpiginous or semilunar sclerosis. This is bone infarct. Again, we can see the serpiginous infarcts in the diaphyses. So metaphyses we already discussed. It's not that always it should be multifocal. It can always be a unifocal also, like this, or it can be multifocal as described earlier. So most common reason for osteoblastic metastasis is breast and prostate. So whenever the age is more than 40 in any sclerotic lesions, you have to think in terms of malignancy. So other disorders are systemic mastocytosis, myelofibrosis, and fibrous dysplasia. We know that they have a predominantly lytic type. Sometimes they can have mixed, and here the bone is replaced by proliferation of fibrous tissue. You can see the ground glass appearance here, and we can have the thickening of the cortex also. Tuberous sclerosis is also described where there is multifocal areas of osteosclerosis. So whenever there is multifocal osteosclerosis, not only metastasis, but also consider all these disorders like osteopoikilosis, sarcoidosis, Poem syndrome, mastocytosis, and tuberous sclerosis. So when you see diffuse sclerosis in clinical practice, usually associated with the non-tumorous conditions, hyperparathyroidism, renal osteodystrophy, fluorosis, myelofibrosis, mastocytosis, and Paget's disease. Also sometimes malignancies. In Paget's, the osteosclerosis in the blastic phase is involving all the four margins, unlike in renal osteodystrophy, in which only the superior and inferior end plates are involved. So these sclerotic bone lesions, the approach is actually not only based on the X-ray, but you should also consider the other parameters from the history, the examination, the lab parameters, as well as the imaging. So, summarizing, the first thing is which is the bone involved. Whether in the bone, whether the entire bone is involved or only one area is involved. So it's a focal, whether it is multifocal or whether it is diffuse. Second, whether it is intramedullary or cortical or juxtacortical, and whether it involves only lytic lesions or both lytic as well as blastic lesions. Then supportive evidence for any tumor or non-tumorous lesion. This is one of the review article for us, the approach to all the sclerotic bone lesions. So increased bone density, that is sclerotic bone lesions, can be because of both impairments in the bone resorption as well as increased bone formation. The simplest clinical classification will be focal, multifocal, or diffuse, and the etiology are mainly the sclerosing bone dysplasias and metabolic and endocrine and as well as metastasis. And any patient more than 40 with a sclerotic lesions consider a bone metastasis, and treatment is based on the etiology.
Thank you, Dr. Ramkumar, for the nice talk. Now we have 10 minutes left for the discussion. So to keep the ball rolling, I think I will start asking one question to Dr. Ameya. Dr. Ameya, in resource poor settings like India, So would you consider giving alpha calcidol instead of calcitriol for patients with metabolic wounds, and how do you approach, and in that sense, what will you do for patients who are not that much affording? What is your take on that?
I think, sir, very, very pertinent question actually, because alpha calcidol is actually something that also helpful in our resource limited setting. Beyond that, I would like to make 2 points over here. Alpha calcidol, if you give, it's not that you are going inferior, you are actually doing a good job, because alpha calcidol has more longer and stable action than calcitriol. You just have to be sure that the hepatic function has not gone for a toss, because otherwise alpha calcidol needs a good hepatocyte function. The second thing is calcitriol actually is also available as a generic version, and at least some of them work reasonably well. So I agree, alpha calcitriol is a good option. It has advantages over calcitriol and can be used as long as the liver function is good. Thank you.
Dr. Ame, I think the cost of alpha calcitriol is around 8 rupees, but calcitriol is 16 rupees, and it is one drug of calcitriol is equivalent to 2.
Point well taken. That's what I agreed with, sir. I also said that it can be given, less frequently than calcitriol, works economical. The only point that I wanted to make is that we also have generic calcitriol also available, which works well actually.
So, any question, comment, or query from the audience?
Then Dr. Viral Shah is also there in the audience.
Yeah, yes, sir.
Good morning, sir. My question is to Amaya, sir. Osteomalacia, it is classified as a low bone turnover disease, despite we see a very high ALP and PTH. Why is that so?
So osteomalacia is where the bone volume is low and the mineralization is affected. The turnover is high based on high alkaline phosphatase, so the turnover is high.
But it is classified as a low bone turnover when we
Low
see
bone mass disease, or basically the mineralization is low, but it's because of the less raw material that you are supplying.
Any other questions from the audience?
Sir, my question is to Amaya, sir. Sir, in asymptomatic refractory hyperpara, is there any PTH cutoff that you take before subjecting them to parathyroidectomy? You mentioned about refractory hyperpara as 800, 900 and 800 with symptoms, with signs and symptoms, but in asymptomatic, because even these patients are at a high risk of cardiovascular events. So is there any PTH cutoff that you look
So the rough thing that was said was you have to confirm 2 things. One is the bone specific alkaline phosphatase should be high, and the PTH level should be, they have said 800 to 1000, but in one of the ESAP modules I have the protocol that said was more than 900 with best medical management. Here it is very important that many of these where the symptoms are less actually respond well to the medical management. I mean, if you just improve the calcium levels, use the calcium mimetics wisely, up titrate them to the best of the capacity, use proper phosphate binders, and you will actually be able to medically take care also. So these, most of them will respond. In occasional case, you can take it on a case-to-case basis or parathyroidectomy, but these incidences are rare. Usually they will be symptomatic who will be having this.
Thank you. A question to Dr. Pradosh. Do you see an expanding role of genetics in children and adolescents, especially in hypophosphatemia kids, and which type of test will you order? Is it clinical exome sequencing or whole exome sequencing or whole genome sequencing? Or
regarding the importance of genetics, obviously we have to follow the classical algorithms first to determine the renal leak, and then FGF23 dependent or not, that's the step. Then following which we need to go for genetics most often. In practice nowadays, because clinical exome is a bit cheaper and it can cover most of the mutation, non-mutations, I go for clinical exome first. But definitely the expanding role of whole genome is coming, and people are telling it could be the last test resort for all the your queries and answers. So we don't know, in the future we might be going for that, but clinical exome is pretty cheap now. If you
even whole exome is also
okay,
coming very cheap.
But
Yeah.
clinical exome you can do it even for the rate of FGF23 you can do a clinical exome. Even
So that's
lesser
why we
than
can
that.
bypass some other tests.
Yeah, definitely. And you could see newer things with genetics. That's
Dr.
Subodip.
Yeah. So question to Dr. Gangadhar again. You mentioned about the fractional excretion of phosphate, which is relatively easy test to be done. Just you need a urine and serum phosphate and creatine. So how do you see that the role of TMP-GFR, whether it can, the FE4 can replace calculation of TMP-GFR or not?
I think so. It can replace. Only problem with this is probably it's not well standardized. If you look at the algorithms, they put the cutoff as more than 5% and more than 100 milligram in the setting of hypophosphatemia. But if you look at the calculators, it gives us cutoffs be more than 20 years. The increased excretion. So our patient definitely had answer with that, but we don't know the borderline scenarios where you could miss or you could include. We are not very sure. So that's the only concern. Probably we need to look into, because these are emerging areas. Probably we may see easier calculate TPGFR or fraction excretion phosphorus replacing TMPGFR in the future. And TMPGFR, basically I discussed that point. It is based on a false belief that there is a splay effect for phosphate excretion. But that is not there. It's a physiological regulatory phenomenon that leads to that splay-like effect. So probably even there is a miscalculation in the TMPGFR calculation algorithm as well.
Correct.
Any
So, yes, sir, to Pratosh sir. Sir, in severe and long-standing cases of hypophosphatemia because of secondary tubular defect, there can be phosphate wasting.
Yeah.
So whenever we get a low TMPGFR, how sure can we be that it is actually because of renal phosphate wasting, or it's secondary due to other etiology which is causing tubular dysfunction? Like,
okay, you are telling there is
basically like
severe hypophosphatemia that lead to secondary tubular dysfunction.
Yes, sir. Like basically.
So that's a scenario I discussed, the MBD of prematurity scenario, where children have a low bone reserve and basically their phosphate replacement is very low. This is very common phenomenon in newborn ICU. So there is a paradoxical relationship with TRP and TMPGFR. You will get a high TMPGFR that indicates the kidneys are trying to absorb whatever that is possible. But because the phosphate is very low, when you calculate TMPGFR, you will get a very low. So usually you will see that TMPGFR relation is towards the same direction. But here you will get a high TRP with a very low TMPGFR. That relation happens, that indicates that there is a severe phosphate depletion and severe phosphate depletion related secondary tubular dysfunction. That's one way to look into. But I recently encountered one baby in NICU. He had secondary hyperpara. So if there is secondary hyperpara, it can lead to some tubular issues, and this patient can have a TMPGFR and low TRP related to increased PTH. So it's a tricky scenario, but if there is severe phosphate depletion, then you will get that paradoxical relationship.
Thanks. Also, like recently, all these pediatric nephrology journals, they're not really recommending use of the current formulas for calculation of TMPGFR because the nomograms have been established from adult population.
Yeah.
So they're telling to use alternatives like Brodel et al., few other.
But most of the algorithms I mentioned, the Pediatric Society algorithms from the Europe, German and European ESPN calculators, they actually follow the Walton-Bijovet nomogram-based algorithm because it's a time-tested one. Currently, it's well-tested, even with stages of CKD 3, 4, agreeable results are there. So probably still we can use TMPGFR. It can give you the answer, but probably in the future we might be changing that.
Thanks.
Any other questions or comments? Dr. Biral Shah want to comment on TMP upon GFR or something?
So 1 minute 38 seconds is left. So if there is no question, I will ask one question to Dr. Joshi. So regarding FGF23, so during monitoring, will you recommend FGF23, and what is about anti-FGF23 in management?
Yeah, so FGF23 actually can be done to know at an early stages. Even in stage 3, it can guide you about whether the person is going into a MBD thing. It can be an early indicator, like we have microalbumin. However, the FGF23 assay availability has been little difficult. Now, earlier we had 2 labs in Mumbai doing it. Now, Hinduja Hospital stopped doing, Metropolis is still doing. The onus is actually, I feel, on us. If we start prescribing FGF23 more, the lab that does it will find the measurement sustainable, and then we will have more labs kind of doing it. Now, anti-FGF23 is in an experimental stage for this particular CKD MBD. It's more used for X-linked hypophosphatemic rickets, or it's better approved. But over a period of time, I think we always have a retrospective evaluation. We learned heart failure after SGLT2 inhibitors came, we learned obesity after GLP-1s came. So I think after anti-FGF23 comes, we will also learn a different perspective, like we are learning Micral with. Yeah. Thank you for
Thank you so much for the excellent talks.
Can I put a final comment?
Yeah,
on
yeah,
that?
definitely. Dr.
Because
Prakash.
there is, because of we are seeing a lot of patients. We have a huge population of hemodialysis because there's a big department of nephrology in our hospital. And what we are seeing is that nutritional osteomalacia and vitamin D deficiency related aggravation of renal hyperpara is a big issue. And if you correct vitamin D deficiency and sufficient calcium replacement has been given, many of these patients can have complete resolution of their symptoms and they can go with supportive measures. And we are doing a lot of parathyroid surgery, but generally many patients, if you avoid, you can actually avoid the post-operative complications of Hungry bone syndrome if you well correct these complications. That's a very common issue, probably neglected in the nephrology community. So now they are actively replacing vitamin D and calcium to improve this.
Yeah.
Thank you.
On behalf of the entire panel, we thank the organizers of PhysiCon 2025 for giving us this opportunity. Thank you so much. Thank you.
Over to organizers.
Moving on to the next session, updates in metabolic bone diseases. To chair the next session, I would like to call upon stage Dr. Abhishek Pandey sir and Dr. Shubhadeep Pramanik sir. Thank you.
So good afternoon. I know it's time for lunch, so let us be introducing a very interesting topic for discussion. It's something new which I also didn't know day before the topic was given to me to chair. So to discuss a new thing, role of osteomorphs. So all of us have heard the name of osteocytes, osteoclast, osteoblast for bone remodeling and bone formation. But what is osteomorph? So to discuss that, we have Dr. Shyamsiddha Mangaraj, who is a professor in the Department of Endocrinology at IMS and some hospital, Bhubaneswar. Over to you, Dr. Mangaraj.
Good afternoon, everyone, respected seniors and dear colleagues. At the outset, I would like to thank the organizing team for having me over here. So the attendance is a bit lean because of the ongoing lunch. But I will talk something of a new breed of cell, that is osteomorphs. Okay. So what does that mean? So I think the day the topic was given to me, I also had to Google it because I was also not aware of its existence before the topic was given to me. And in the next 20 minutes, I will be speaking regarding how the cell came or regained its identity and what is the translational scope of the current cell that has been only identified in as late as 2021. So this would be my broad agenda of our presentation. We'll have an overview of bone remodeling with special emphasis on osteoclast biology because this is the cell which is the target of many therapeutics for managing osteoporosis. And we'll discuss something how the fundamental understanding of osteoclast fate has changed and evolved over the years. And we'll discuss in detail of whatever is known of this new breed of cell, that is osteomorph. And lastly, we'll have some translational discussion regarding how osteomorph utilizing in clinical settings, because basically we are all clinicians, so I will just summarize some evidences that we have from recent studies. So to go through the overview of having an bone remodeling. So our skeleton is not merely a unit which gives us structural integrity. It goes way beyond that. There is a continuous dynamic change that happens over a period of time, and it is stringently controlled by many endocrine and local factors. Remember, this orchestration of factors is under a critical control of various inputs. The two predominant cell phenotypes which determine, one is osteoblast and osteoclasts, oversimplification, but the cellular interaction between these two cell types determine whether the bone is going to form or is going to get resorbed. So if you talk about osteoclasts, so osteoclasts, if you look at the ontogeny, they have distinct origin from the bone marrow cells. One is the mesenchymal origin, which gives rise to osteoblasts and adipocyte, myoblast, and the second line is from the macrophage monocyte system from which your osteoclasts come. These have distinct ontogeny and this also have distinct phylogeny. Their function is also distinctly different in the bone microenvironment. So today's talk focus would be on osteoclast, how these function and how critically their fate is determined. So this is an overview of bone remodeling. So your bone lining cells, they orchestrate or they attract the osteoclast from the circulation to the areas of bone which requires remodeling. So this remodeling can start from activation, then formation of the resorption pit by the activated multinucleated giant cells or the osteoclast. Then after that job is finished, probably they end up with apoptosis. So this was what we conventionally know by classical in vitro and in vivo studies for the last couple of decades. But does that hold true? We are going to see in next couple of slides. So we are all aware of, we have anti-resorptives, we have anabolic agents to treat osteoporosis, and remember, if you talk about the interaction between osteoblasts and osteoclasts, rank ligand receptor, osteoprotogerine, these three perhaps determine the rate and fate of bone formation and bone destruction. So now what osteoclast is going to do in the bone microenvironment? Now as we move on, the exact elucidation of the pathology of how it functions, the subcellular mechanisms, the transcription and transduction pathways have been well validated in at least in vitro and in vivo studies. So once you have expression of rank, so the rank ligand, soluble rank ligand, once it is available, it is going to bound with the rank receptor and it is going to induce conformational changes to the system of osteoclast. Now it becomes something known as committed osteoclast. Further signaling, down signaling transduction will lead into a maturation and formation of a classical multinucleated activated osteoclast with its classic ruffled border, which will induce resorption at the appropriate site. Now, till now we understood that your osteoclast is coming, getting attached to a particular site, doing this function of bone resorption and getting exhausted and ultimately dies by apoptosis. But is it true? So what has fundamentally changed in the last couple of years in our understanding? So we believed earlier that for the last 5 decades, the osteoclasts are short-lived cells. They live up to, let's say, 2 to 3 weeks before eventually their death happens by cellular apoptosis. They do their work and they die in the bone microenvironment, nothing more. But 3 pivotal studies in the last decade has perhaps changed the way we now understand osteoclast fate. The first landmark study was published in 2012. Jansen et al. Demonstrated for the very first time that after the function is over, they do not die as apoptotic cells, but they can undergo a process of cellular fission to give rise to something known as daughter cells. These are multinucleated giant cells, but these are derived from the mature osteoclast and they do not die like apoptosis. So if you look at the figure down, you look at the panel C. Panel C, there is OC2 and OC3. These are the daughter cells that has been, this is live in vivo imaging technique through which they demonstrated that actively osteoclasts can divide or into fission giving rise to two distinct subtypes of cells or daughter cells. But here also, before that, nobody had demonstrated this phenomenon happening in vivo. But here also there was no question of osteomorph. The next big leap came in 2019, which was published in Nature by Galraza et al. So what they have shown in their elegant parabiosis study using murine models, they showed that your osteoclast is not going to die by end of 2 to 3 weeks as is conventionally thought of. But they showed that these cells can live up to 6 months. Remember, 6 months, a figure which was unheard of before the discovery of this kind of study. So they can remain in the circulating blood pool even at a site which is distant from the primary site of bone resorption. So this was not demonstrated earlier. Now came the big break. So the big bang was in 2021, McDonald et al. Published a seminal paper in Cell. So what happened in this first of a kind study, they showed that the osteoclasts suffer an alternate fate, not only as an apoptotic body, but they used a very sophisticated tool of intravital imaging to picture the live streaming what happens in the micro environment. And they showed that osteoclast had fission and it produced daughter cells as was shown 1 decade earlier by the previous authors. For the first time they coined the term osteomorphs. So osteomorphs are basically fissile daughter cells derived from osteoclasts. So if you search literature before 2021, there is no mention of the word osteomorph. So for the very first time, this terminology came into picture. So with the discovery of osteomorphs is a complete newer frontier and newer horizon to look at from a different perspective to osteoclast biology. So what has happened? They gave a concept of fission and fusion cycle. So just look at the figure. Under a steady state, your macrophage under the influence of soluble rank ligand and GCSF gives rise to a steady state osteoclast. This is there in the bone marrow microenvironment. If the need arises for osteoclastogenesis, then through the stimulation of soluble rank ligand, it undergoes activation to form a mature osteoclast, multinucleated mature osteoclast, which is ready to do its job of bone resorption. This we know. Then came fission. They showed that it divides into daughter cells which are osteomorphs. And remember, these osteomorphs are not inert cells. They do have their very function. In the subsequent demonstration in the same experiment, what they showed, osteomorphs can again go back, fuse together to form again a mature osteoclast. That means it is not end of the story. They can again go back, fuse together to form osteoclast. Now what is the significance? I will tell you later. Again, they demonstrated that when you give osteoprotogerin, a decoy receptor for rank ligand, this process can be inhibited. So there are two evidences. There is a biological evidence of refusion to form mature osteoclast. It can be again blocked by giving an osteoprotogerin. So this was beautifully elucidated in their study design. So now we'll know everything what is known of osteomorph as of 2025. So this cycle of osteomorph and osteoclast recycling. There is a osteoclast, it can undergo fission, give rise to osteomorph. When the need arises, these osteomorph can again refuse to form mature osteoclast at two sites, maybe the same site or at a distinct site away from the primary site to give rise to bone resorption. And this cycle can continue depending upon your hormonal milieu and local factors. So this perhaps may contribute to enhanced osteoclastogenesis in certain scenarios. So the next question was whether it are merely daughter cells or their distinct architecture is different with regards to genetic heterogeneity. So using the sophisticated techniques of single cell RNA technique, the same McDonald et al. Provided the first evidence that it is not mere replica as a daughter cell, but the distinct genetic architecture is something which is different from conventional osteoclast. There are 151 genes which are upregulated not in osteoclast but in osteomorphs, and if you compare the human genomic data set or library these have been known to result in skeletal diseases in human and mice model if there is a defect in the particular genes. Hence, it is very, very critical. The second boost came, a separate author group, Huang et al. In 2023 published data confirming the presence of in vivo evidence of osteomorphs, and they show with similar techniques that there is formation of osteomorphs, fission, fusion, and again refission. So they advanced it further. Now what determines whether your osteoclast will remain as a motile cell, it will undergo fission, or it will die as apoptosis. So that is determined by a step known as mitophagy, a cellular technique through which the cell will determine whether it will divide into osteomorph, whether it will remain dormant, or it will go on to become a activated nucleoclast, osteoclast. So this was demonstrated beautifully as late as 2023. So our historical view is that osteoclast remains for 4 to 6 weeks, performs its function as resorption and dies by apoptosis, but it is not that simple. The current view tells you that osteoclast undergoes a cycle of osteomorph, osteoclast refusion, fission, which continues, and remember, they can travel to blood vessels and migrate to a different site and induce osteoclastogenesis if the need arises. Next is how it is going to affect us as clinicians. That is the million-dollar question. So one particular clinical problem, that is, if you are giving denosumab, very potent agent, good increment in BMD, good reduction in fractures, but if you stop or miss a dose, what happens? We all know that there is a rapid reversal of bone remodeling, and the thresholds of markers shoot up by the end of 6 months if your dose is missed. This may result in elevated risk of fractures, vertebral fractures. It is a well documented phenomenon, and for that very reason you have to follow an anti-resorptive, let's say with Jolendronet, after you contemplate stopping, withdrawing denosumab. So this is a clinical problem, but how it is caused, what are the mechanistic insights why this particular phenomenon is seen in clinical practice. So earlier it was reported that when you give denosumab for a long period of time, it is going to block the differentiation and there will be accumulation of pre-osteoclast or osteoclast precursors. Nobody had identified what kind of precursors these are. With the advent of osteomorphs, perhaps these are the spools of cells that remain in the blood when denosumab is continued. Once it is withdrawn, as I told you, osteomorphs again refuse to form activated osteoclast, which may continue again osteoclastogenesis, which may result in enhanced BT bone turnover markers, resorptive markers, and result in clinical fractures. So this is the area where osteomorphs may play a very handy role. So now we have this temporal window. This is obviously from murine models, where they have shown that currently if you give an osteoprogesterone or let's say denosumab, your bone resorption is going to reduce, BMD is going to improve. But once you stop that, the threshold, look at the right hand panel, serum CTX. This is the current clinical intervention window. When the bone turnover marker shoots up, you are going to introduce a newer anti-resorptive. But even before that, there is an early intervention window where soluble rank ligand and the 5B isoform of TRAP are elevated much before the eventual elevation of CTX. Because these markers are not conventionally used in clinical settings, we are perhaps missing this intervention window, which could be targeted before the effect wears off of an potent agent, let's say of denosumab. So this may come off very helpful if you are going to advocate using these markers when the data is available with us. Now when you are giving denosumab, so once you are giving denosumab, look at the right hand panel, it blocks osteoclast, well known effect. But look at the left down hand panel, rank ligand inhibition also retards the fusion of osteomorphs to osteoclasts. So it blocks two things, osteoclast function, again reformation of osteoclast from the osteomorph. Let's say this is the story for 3 years in which you have continued giving denosumab. But suddenly due to the patient misses a dose, does not turn up or something because of unaffordability, you are stopping denosumab. Now what happens after that? If you stop denosumab, look at the green arrow, osteoclastogenesis is going to again shoot up when the dose effect wears off. Now look at the fusion. Again, because that blockade is gone, osteomorphs, the pool of osteomorphs which are again pulled back during the entire therapy. These precursor cells again are going to fuse, giving more rise to more mature osteoclasts, which can enhance osteoclastogenesis. That will translate into more bone resorption. If you do a serum CTX, that is going to rise and perhaps may culminate in increased number of vertebral fractures that has been well reported with missing of doses of denosumab. Something, because not all antiresorptives, this is not the story. There are few questions which are still left unanswered, like we use other antiresorptives, let's say bisphosphonates, oral or even the zoledronate, but this kind of fracture enhancement or shooting off of markers is not seen with them, despite having a similar kind of action. The answer is not yet clear to us, because why that happens, because osteomorphs do form in every other scenario, but why that rebound phenomenon is not happening with use of bisphosphonates is yet to be elucidated. Now coming to, we have talked of osteoporosis alone. Remember, rank ligand and osteoporosis signaling is involved in many metabolic diseases, inflammatory diseases and diseases of malignancy. Let's say malignancy related bone loss, especially myeloma, Paget's, glucocorticoid-induced osteoporosis, or even your Charcot's neuroarthropathy, in which everybody is aware that rank ligand signaling is involved. So whether osteomorphs may be playing a role in the genesis or propagation of the diseases is yet to be elucidated, because now studies, especially murine studies, are ongoing to address these issues. So osteomorphs may have a potential role in understanding the defects beyond osteoclast in these particular subset of disorders. So I'll just conclude with the whatever findings I have discussed with you over the previous 20 minutes. So the discovery of osteomorphs perhaps has resulted in a paradigm shift in our current understanding of osteoclast biology, particularly what happens to osteoclasts. Its fate, it never dies alone with apoptosis, it remains in the blood as form of osteomorphs, which can again be recruited. It challenges the long held notion that osteoclasts are short-lived as 4 to 6 weeks. We have data to suggest that they can live up to 6 months. So it is kind of fundamentally challenging the central dogma in the osteoclast biology. There is strong in vivo evidence. I have shown you multiple authors confirming the presence of osteomorphs in osteoclast recycling and osteomorph generation. The only thing is there is a strong data from murine models. Replication in humans is yet to be done. This has a translational scope because it might help us to understand the clinical problem of denosumab withdrawal and rapid increase in the turnover leading into enhanced fracture risk. So targeting this could be a strategy, and in the end, because osteomorphs are a separate cell entity altogether, it has a distinct genetic architecture. So targeted strategies, because the receptor also might be different, so target strategy to evoke response from these could one day see us develop new medications which can be used to treat metabolic diseases, especially osteoporosis and malignancy related bone loss. Thank you for your kind attention.
Thank you, Professor Swamsid, for your excellent presentation and sharing knowledge with us. I request you to be seated on the dais. So moving to the next presentation, it is about the hungry bone syndrome, prevention and management. The next speaker is Dr. Soham Mukherjee. He is an associate professor in Department of Endocrinology at PGI Chandigarh, and his areas of interest are youth onset diabetic mellitus and metabolic bone disorders. He has several indexed publications in national and international journals and recipients of multiple awards. So I welcome Dr. Soham. Please proceed.
Thank you for the kind introduction. So you all know that after parathyroidectomy, following hyperparathyroidism, be it PHPT or secondary hyperparathyroidism, SHPT or renal hyperparathyroidism, there is a transient decrease in the serum calcium level. Usually this is mild and should not last for more than 3-4 days, and because of transient hypoparathyroidism. However, it is problematic if there is a severe drop in serum calcium more than less than 8.4 milligram per dl, and there is prolonged severe hypocalcemia for more than 4 days, and it is classically defined as hungry bone syndrome post-parathyroidectomy. So, first described in 1980s, following post-curative parathyroidectomy in PHPT cases. Sudden drop in sustained elevated PTH level to less than normal or resulting in this condition. However, it is being now more commonly reported in end-stage renal disease in secondary hyperparathyroidism. But rarely it has been also reported after initiation of cinacalcet therapy for secondary hyperparathyroidism. It usually developed after 2 weeks, within 2 weeks of cinacalcet therapy. And after total thyroidectomy in thyrotoxic cases, grave disease cases, and even seen in bone metastasis with osteoblastic metastasis, including prostatic cancer after initiation of estrogen therapy. Prevalence in PHPT varies widely. It ranges from 4 to 87%, more common in Indian population and Eastern population as compared to Western counterpart. In Western population, the prevalence is only 10 to 15%. So we'll discuss this later. For the secondary hyperparathyroidism, from a study, the incidence was reported to be around 28%. And in that study, they observed that 1/4 of patients with secondary hyperpara with parathyroidectomy are readmitted to the hospital within the first 1 month following surgery. And okay, sorry, but it is not moving. Here it is moving, not. नहीं इधर मूव हो रहा है, उधर मूव नहीं, इधर इधर भी आ रहा है,
স্ক্রিনে চেঞ্জ হচ্ছে না
পয়েন্টারটা কোনটা এটা,
স্ক্রিনে চেঞ্জ হচ্ছে না স্ক্রিনে
So, till it is being corrected, we can talk a little bit regarding the epidemiology. So basically, so 15 to 20-fold increase in the hospitalization rates after 1 year of parathyroidism because of hungry bone syndrome. So we have time. We'll wait. Yes. Now it is moving. So before going into the pathophysiology of hungry bone syndrome, so this picture is extremely important. It shows the process of normal bone remodeling in physiology. So bone resorption mediated by osteoclast is coupled with bone formation by osteoblast, and they go hand in hand so that the bone mass maintained in adult individuals. In PHPT, there is excess of PTH for a long duration. PTH stimulates both bone formation as well as bone resorption. But when it is elevated for a prolonged duration of time, the tilt is towards the excessive bone resorption by upregulation of rank ligand and suppression of osteoprotogenin. So this tilt the scale towards the osteoclast mediated bone resorption and further osteoporosis. So prolonged and sustained elevation of serum PTH level increased stimulation of osteoclast number and activity, sudden fall in PTH following parathyroidectomy, turn off this osteoclastic activity, while the osteoblastic bone formation continues. So in this resorption site, which has already been created before surgery by the excess of PTH by osteoclast-mediated bone resorption, after surgery, there is mineralization or net calcium influx in the bone from the blood, so resulting in hypocalcemia, which may be severe and sometimes may be prolonged, resulting in hungry bone syndrome. It may or may not be associated with hypophosphatemia and hypomagnesemia as well. In particular, in the secondary hyperparathyroidism in ESRD cases, where the phosphate level is already high, it may decrease, the phosphate level may decrease, or magnesium level may decrease, but it may not be low. After all, we are dealing with a patient with CKD stage 5D. Now predictors, can we predict? Yes, there are some predictors. The most important is alkaline phosphatase and PTH level. For PHPT, it is observed or noted that the alkaline phosphatase and PTH value more than twofold than the upper limit of normal. And for the secondary hyperparathyroidism, if alkaline phosphatase is more than 3 times of the upper limit of the normal and PTH more than 1000 picogram per ml predispose the patient to post-op hungry bone syndrome. Further, pre-existing extensive skeletal disease in the form of OFCs, fast history of fracture, periosteal erosion, all may predispose the patient for post-parathyroidectomy hungry bone syndrome. Clinical course, usually a transient drop in calcium lasting for 2 to 4 days following surgery is universal. And this indicates temporary hypoparathyroidism, which is being corrected spontaneously. However, in hungry bone syndrome, there is rapid fall of serum calcium to less than 8.4 milligram per DL, and that nadir in the post-op day 2 to 4. Often severe hypocalcemia start within the first 18 hours post-surgery, and patients remain hypocalcemic for more than 4 days at least, and it may persist for months or even years. So patient may present with features of hypocalcemia, tingling, carpospedal spasm, positive Vostek Trosu sign. Sometimes patient may have generalized seizure, even congestive cardiac failure, hypocalcemia related. So this is a graphical representation what happens in hungry bone syndrome post-parathyroidectomy in PHPT patients. So you can see that the drop in calcium is most rapid within the first 24 hours. And then the nadir value maintained at least for more than 4 days in hungry bone syndrome. Serum phosphate and magnesium may also drop post-op, but again, end-stage renal disease patient with secondary hyperpara may still have normal or high normal phosphate and magnesium level due to impaired renal function. Alkaline phosphatase may show rising trend post-operatively, and the raised alkaline phosphatase may persist for months. Still, the increased osteoblastic activity persists. Early after parathyroidectomy, normal or high PTH is essential diagnostic criteria because it differentiates this entity from hypoparathyroidism. So in this pictorial diagram, in the lower panel, you can see preoperative calcium and PTH level in PHPT and renal hyperparathyroidism patient. In PHPT, pre-op calcium and PTH obviously is in the high quarter. And for renal hyperparathyroidism, calcium may be low, normal, or elevated, depending on it is secondary or tertiary hyperparathyroidism, and PTH is elevated simultaneously. Following surgery, either patient have remission with normalized calcium and PTH, or patient may have persistent hyperparathyroidism in case of failed surgery with high calcium and high PTH, or if the patient develop hypocalcemia, your differential would be hypoparathyroidism and hungry bone syndrome. In hypopara, the PTH should be low, and hungry bone syndrome, it should be normal or elevated, but obviously it is less than that what PTH level prior to surgery. So preoperative PTH should decrease, but it may remain in the higher level or higher zone or just above the upper limit of normal even after surgery. Now treatment need to be aggressive because serious complication may happen due to severe hypocalcemia. With aggressive supplementation of divalent minerals like calcium, phosphate, and magnesium may be required. Frequent monitoring of total serum calcium level in the initial first week, particularly the initial first 2 to 3 days, is warranted. Sometimes calcium level need to be monitored 2 to 4 times per day in severe cases. For symptomatic hypocalcemia, serum ionized calcium level is preferable rather than total serum calcium level because in CKD stage 5 ESRD patients, your total serum calcium may be spurious. Oral administration of elemental calcium up to 4 to 12 gram per day may be required, and calcitriol supplementation up to 2 to 4 microgram per day may be warranted in the post-operative period. Intravenous infusion of calcium is required if there is any evidence of neuromuscular irritability or prolonged QTC, or if the patient have any seizure activity or laryngospasm. Now, in this study, they have evaluated calcium requirement after parathyroidectomy in patients with refractory secondary hyperparathyroidism. 42 patients with chronic kidney disease stage 5D who went successfully subtotal parathyroidectomy were reviewed. Transient hypocalcemia was observed in about 80% of individuals. The median daily calcium dose, that is elemental calcium dose requirement needed to prevent hypocalcemia was 3.2 gram per week per day in the first week and 2.4 gram per day in 6th week. In this study, the authors evaluated role of loading calcitriol to control hypocalcemia after parathyroidectomy in CKD patients. They observed that reduced requirement of intravenous calcium administration in patients with secondary hyperparathyroidism were started initially on high dose of calcitriol, that is 2.25 to 4 microgram per day of calcitriol, compared to relatively low dose of calcitriol ranging from 0.75 to 1.5 microgram per day. Magnesium supplementation are prescribed based on serum level. Phosphate binders may be stopped if serum phosphorus concentration decline in secondary hyperparathyroidism. Phosphate replacement in those with serum phosphate concentration less than 1 milligram per dl may be warranted because of concern of cardiac failure, respiratory failure, or neuromuscular weakness. Caution must be exercised as oral and intravenous phosphate administration may precipitate or chelate the blood calcium and further worsen hypocalcemia. So there should be a very high threshold before starting for phosphate supplementation, oral or IV. Previous studies use high calcium dialysate containing calcium of 1.5 to 1.75 millimole per liter in treating hungry bone syndrome in patients with secondary hyperparathyroidism after subtotal or total parathyroidectomy. For the long-term management, if the hungry bone syndrome persists for months, so we don't have any data on that. We require data on this regard, but usually we treat this patient with oral high dose of elemental calcium along with calcitriol. How to prevent? Yes, the main pathophysiology is a pre-op sustained very high level of PTH, and immediately after surgery, there is sudden drop in PTH level. So before surgery, the PTH was very high, so there are resorption site, widely distributed resorption site, and ultimately after surgery, there is a calcium influx in those resorption sites, resulting in the net calcium influx into the bone. So you have to prevent that. So best way to treat hungry bone syndrome or prevent hungry bone syndrome precisely in secondary hyperparathyroidism to not allow the PTH to rise much before surgery. So to treat that high secondary hyperparathyroidism or severe hyperparathyroidism, you have to give the standard forms of therapy, including calcium, calcitriol, phosphate binder, vitamin D supplementation to prevent severe elevation of PTH prior to surgery. So normalization of 25-hydroxyvitamin D and 125-dihydroxyvitamin D level prior to surgery is important. Role of bisphosphonate. Bisphosphonate actually inhibit osteoclasts. So because the pathophysiology is such in this condition that there is increased pre-op osteoclastic activity. So if you can suppress the increased osteoclast activity, so there will be less resorption sites. So after surgery, there will be less calcium influx into the bone. So less hungry bone syndrome. So that was the rationale of considering bisphosphonating hungry bone syndrome. So in this study, Andrew Davenport, what they did, way back in 2007, they administered pramidronate to see whether it prevents hungry bone syndrome or not. So they chose 37 end-stage renal disease patients on hemodialysis undergoing 4-gland parathyroidectomy. Everyone received standard medical treatment with alpha-calcidol and calcium supplementation. 27 of these patients received an IV infusion of pramidronate during the last hour of hemodialysis 2 days prior to surgery, either with a 30 milligram of pramidronate or 45 milligram of pramidronate, depending on the weight of the patient. Those who received the infusion had a lesser drop in mean total serum calcium level at day 1 and day 7, and mean length of hospital stay was shorter in those who received pre-op pramidronate. At 3 months post-op, there was no difference in the requirement for alpha-calcidol or elemental calcium prescription. So pre-op pramidronate in combination with high dose of oral alpha-calcidol and calcium supplementation can prevent symptomatic post-op hungry bone syndrome and reduce hospital stay from 9.2 days to 5.7 mean days, which was statistically significant. However, in the longer term, pramidronate may potentially delay bone remodeling. That was the concern. So now in this retrospective study, they have evaluated that the bisphosphonate pretreatment, whether it can attenuate the hungry bone syndrome incidence and prevalence. So they reviewed the record of 23 patients with PHPT who underwent parathyroidectomy. These patients were divided into 2 groups showing hungry bone syndrome. 9 patients was showing hungry bone syndrome and 14 patients did not experience hungry bone syndrome. None of the 9 patients with hungry bone syndrome had received bisphosphonate pretreatment. Of the 14 patients without hungry bone syndrome, 6 had received bisphosphonate pretreatment. But the difference from those who did not develop hungry bone syndrome was significant. So in this study, they concluded that the administration of bisphosphonate in primary hyperpara as well can prevent the occurrence of hungry bone syndrome after parathyroidectomy. So in this meta-analysis of only 2 studies actually, there is very limited study in this aspect of bone mineral density. So basically in this meta-analysis, they have observed that the use of preoperative bisphosphonate in patients with PHPT was associated with 88% reduction in the risk of developing post-op hungry bone syndrome, as opposed to patients who did not offer bisphosphonate. But what about the concern that the bisphosphonate may reduce the bone accrual post-operatively after parathyroidectomy in PHPT or SSPG? So in this review of medical record, the retrospective study, only 6 patients were included, and they observed that the accrual of bone mineral contents was not hampered by bisphosphonate pretreatment. 1 year after surgery, the mean gain in bone mineral density was at lumbar spine 14%, femoral leg 86%, and radius 22%. And they concluded the preoperative use of bisphosphonate seems to attenuate bone hunger without preventing a significant increase in bone mass in the follow-up parathyroidectomy. But you have to keep in mind, this is of only 6 patients' data. So further studies in this aspect is required. Now, role of vitamin D supplements in prevention of hungry bone syndrome. My previous speaker was talking about that, the role of vitamin D in preventing HBS after successful parathyroidectomy for primary hyperparathyroidism. This study was conducted way back in 2021, and this was a prospective randomized open-label study consisting of 102 patients. All these patients had actually vitamin D deficiency prior to surgery. So group 1 consisted of 52 patients who did not receive pre-op vitamin D supplementation. Group 2 consisting of 50 patients who received cholecalciferol supplementation with a target to maintain vitamin D level more than 20 nanogram per ml in group 2A, that consists of 25 patients, and targeting vitamin D level more than 30 nanogram per ml, that is group 2B, consisting of 25 patients. So actually there is 3 groups. 52 patients who did not receive any supplementation with vitamin D supplementation, group 2A who received vitamin D supplementation with a target to achieve a pre of vitamin D level of more than 20, and group 2B, vitamin D supplementation with a target of vitamin D level preoperatively more than 30. Patient with hungry bone syndrome had significantly lower vitamin D 25-hydroxy D level at baseline. So 25-hydroxy D is associated with hungry bone syndrome, but whether treatment with vitamin D can prevent hungry bone syndrome or not, and all these patients, you have to keep in mind that received vitamin D supplementation within 2 weeks of surgery, so within 2 weeks prior to surgery. So what they have observed, though numerically, the proportion of hungry bone syndrome in group 1, that is who did not receive vitamin D supplementation preoperatively, is higher than the other 2 groups, but it did not reach the level of statistical significance, and the authors concluded that preoperative vitamin D supplements has no preventive role on post-operative incidence of hungry bone syndrome among patients with PHPT and coexisting vitamin D deficiency. So again, we lack the evidence to support use of vitamin D, or strong evidence is lacking in this regard as well. So now Indian context, we are all talking about India, though hungry bone syndrome rates ranging from 24 to 87%, definitely higher than the Western counterpart. Reason is very obvious. We don't have routine biochemical screening of calcium here, so we detect primary hyperparathyroidism late. So that parasite tumor we found is larger in volume than Western counterpart. The calcium is higher, the alkaline phosphatase, PTH, everything is higher. So more resorption of bone preoperatively and more risk of hungry bone syndrome. Now, data from PGI. So what we have done, so Akanksha conducted her thesis on this. Actually, she is here only. So she studies 45 patients. So 23 patients received placebo prior to surgery, and 22 patients received Zol prior to surgery. There is no difference in the incidence of hungry bone syndrome. Further, she also demonstrated that the risk of decreased bone accrual was not there. So pre-op Zol did not reduce the mineral accrual by the bone in the post-op period up to 1 year. So this is the evidence we have till now. So to conclude, hungry bone syndrome, though reported first in primary hyperparathyroidism, it was more common in secondary hyperparathyroidism. Hypocalcemia with or without hypomagnesemia and hypophosphatemia is a characteristic feature. PTH is not suppressed. It is important to differentiate them from the post-op hypoparathyroidism. Marked raised alkaline phosphatase PTH and extensive bone involvement preoperatively can predict development of hungry bone syndrome post-operatively. It needs to be treated aggressively to prevent serious complications. Sometimes the complication may be life-threatening, and bisphosphonate may be useful in preventions. But however, studies shows conflicting results. Vitamin D deficiency is associated with increased risk of hungry bone syndrome, but intervention that vitamin D supplementation prevent hungry bone syndrome is still controversial. We need more studies, and still it is not routinely recommended. Thank you.
Thank you, Dr. Soham. Please be seated, and we will start with the discussion part. So the house is open for the questions. Any question from the house? Yeah.
Good presentation, Sudhir. I just was wondering this high prevalence in our part of the country about this hungry bone syndrome that you showed was very high, 24 to 87%. Is it because our intake of calcium is low, chronically low intake of calcium, and when you operate, it worsens the levels of calcium? Is that true?
So actually,
and maybe the high prevalence of primary hyperthyroidism also is as a result of chronic stimulation of the PTH glands.
Actually, anything which will increase the PTH level preoperatively
which predispose the individual to hungry bone syndrome. So low calcium intake definitely has a role to play, but I don't know whether it has been systematically studied or not. Most important is, in our cases, I am not talking about setting like Medanta or Premier Institute where routine calcium screening done and all those things done, but I am talking about the major bulk of India where routine calcium screening is usually not done. So PHPT diagnosis is usually delayed. So high PTH level, very high PTH level persisting for many years prior to diagnosis also predispose this patient to hungry bone syndrome.
Why I'm saying this is, when we conducted supplementation studies in adults, initially, after supplementation, the levels of vitamin D did, of course, reach to 30 to 40 nanograms per ml. But the secondary hypothyroidism persisted, though the PTH levels came down, say, from 120 to, say, 100 or 90, but they persisted. So I went back to those subjects, and I came to know that they had never taken milk or milk products as such. Most adults in our country don't, the intake of calcium is very, very low. So the secondary hypothyroidism persists. So that could be a reason for certainly fall of calcium when they are operated for parahypothyroidism.
Yes, sir. We also observe the same thing after correction of secondary hyperparathyroidism. That is vitamin D deficiency correction. PTH may persist for a prolonged period to an elevated level. That we also have seen in our routine clinical practice. Yes, sir.
Yes, so thank you for a nice review of a very important topic. One issue, of course, could be calcium, but could also just be chronic D deficiency. We have plenty of patients with chronic D deficiency who, exactly as Dr. Marva was saying, despite correction of vitamin D level, their PTH does not go down to normal range. It remains still higher than normal. But having followed these patients up for years, after a few years, 2 years, 3 years, 4 years, suddenly one visit, then it drops if they continue their vitamin D. So obviously it is resetting of the parathyroid gland responding to chronic D deficiency where I'm trying to compile these patients. But quite clearly, one important thing is that if you're treating vitamin D deficiency with secondary hyperparathyroidism and treating with vitamin D, you may correct the vitamin D and everything else clinically, etc., will improve, but the PTH can remain high for a long time, so that shouldn't cause any distress in treating or in a diagnosis. It can remain mildly high. It won't remain very high, but it can remain mildly high. So it's a bit difficult, though, to reconcile that treating D deficiency before parathyroidectomy is a dictum we've all been following for decades. It's a little difficult to reconcile that patients with vitamin D deficiency and PHPT, they undergo parathyroidectomy and their risk of hungry bone is the same as who are sufficient. That is very unlikely.
Actually,
that's been a
traditional teaching. Sir, as you have already told, the PTH does not immediately come down in secondary hyperparathyroidism with vitamin D deficiency. And all these studies, the vitamin D is corrected for 1 month or weeks like that. So, and I have shown that only 1 or 2 studies have reviewed these things. So we require more studies before coming to conclusion.
Because intuitively and clinically, that's how it has been. I'm sorry, I'm talking of 40 years ago when I was a resident with Professor Ahuja, and when patients used to come for parathyroidectomy, he says, "Kuch vitamin D de do." We couldn't measure vitamin D, by the way, at that time. They were patients with severe bone disease. Almost all were with severe bone disease at that time. And give some vitamin D, otherwise you'll have to stay in the ward for next 3-4 days because of the severe hypocalcemia. But anyway, so it's good to know that, that there is. The other thing which is also worth emphasizing is that a lot of you are in private environments, and a lot of you would be having calcium screening in your hospitals as part of health checks. So to be very honest, the hungry bone syndrome that we are seeing is like once or twice a year with maybe 40 parathyroidectomies a year. So, so I'm just saying that this is simply because of nutritional differences. Yes. Early diagnosis to some extent and nutritional differences. because patients have better calcium intakes and almost all are vitamin D replenished for some time before they go for surgery. So it's quite interesting how there is such a...
So basically, sir, this is the difference, the socio-economic status you are catering and we are catering.
Absolutely, absolutely. Very interesting.
One thing I failed to understand the exact mechanism, two mechanisms. One is that why HBS happen. You just said that with the suppression of osteoclast, osteoblasts continue to work. That means there is an uncoupled bone formation happening, which is called the modeling directed bone formation. Now you are taking out the stimulus for both formation and resorption here. So only the resorption component is down, but the formation, even that stimulation is out. Why it is continuing? So that mechanism is unclear to me. And the second is that again, is bisphosphonate pre-treatment is already your osteoclast is suppressed. Is bisphosphonate in this case suppressing osteoblast? But that is very unlikely. Because if it is a modeling directed bone formation happening, bisphosphonate is working in the remodeling. It stops the remodeling cycle. It does not affect osteoblast at all. So how bisphosphonate is able to correct it, a pre-treatment is able to correct it. These two mechanisms I couldn't understand.
So first of all these studies have not shown that bisphosphonate is effective. There is controversy regarding that also. So I'm not going to tilt to any side and remain open. And second one is, it is predominantly osteoclastogenesis which is being prevented. It was predominantly osteoclastic activity before surgery. This is a very high PTH for prolonged time. And you are stopping that, the predominant osteoclastic activity. So bone resorption sites are there. And there is net calcium influx. That is the hypothesis they have made.
Correct. A few clinical pulse, because I can see a lot of PGs and DM students are there. So if you are replacing vitamin D, there is always a hesitation that in primary hyperpara, already the calcium is high. So putting them on vitamin D replacement, what is your regimen and how do you justify?
So I think Dr. Mittal is a better person to comment about that, but what I understand about that, if there is calcium level is less than 12, in one of the study we have conducted, calcium level less than 12, there is no concern. Because ultimately PHPT may also have secondary hyperpara component due to vitamin D deficiency, so ultimately PTH should decrease. If there is 12, more than 12, I will be little concerned. So some people advocate in those scenarios also vitamin D deficiency should be corrected because it might prevent hungry bone syndrome. So some people still advocate, but I will have concern if the calcium level is very high, 13, 14, then I will be concerned.
And again, there is a concern of weekly vitamin D. It will take a lot of time to normalize the vitamin D. So the patient obviously do not want to wait for 2 months for a PHPT surgery. So how do you convince them?
I think...
No, I think he said it very clearly that you give active vitamin D, that is 125 hydroxy D, which acts immediately to raise the calcium. But same, the danger is when it is very, very high and you give active vitamin D 125 calcitriol. That's what you said. Because if you're going to immediately operate, then you have to give something which will immediately act.
Correct.
So that's the reason you start off with active vitamin D, but after surgery is done, you get them back to the normal vitamin D supplement, cholecalciferol.
So the only point, the question is about how to correct D deficiency safely in patients who are planning to undergo PHT or lined up for PHPT, surgery. So I think using cholecalciferol is not a problem. You may not use high, if you're going to use, maybe use little cautiously, but using cholecalciferol in patients who are D deficient and have primary hyperpara has not been shown to produce significant hypercalcemia, something we've always been scared of, but it's never happened actually. So no study has shown that. So a very good approach would be to use active vitamin D if there is an immediate correction required. Otherwise, just go with cholecalciferol and go for the surgery. So I don't think you should worry too much about hypercalcemia with cholecalciferol. And I also don't think you can try to give very high doses of cholecalciferol to correct immediately. Not a good idea. Not a good idea.
Correct. So we had another talk about the osteomorphs. That is basically a new topic. Dr. Shamshuddha has done a very beautiful job in discussing that. Just to re-emphasize the fact that how this concept of osteomorph came into the clinical practice, and what do you believe that what is going to the fate of osteomorphs, whether it's going for apoptosis or it come back as osteoclast, how these things are regulated?
I think the definition or the genesis of osteomorphs only came in 2021. Before that, there was no terminology in the literature to describe a new cell type of osteomorphs. So what these authors, basically two big author groups from Institute of Garvan and one from China is working on that. So they have shown that osteoclast does not just die as apoptosis after their job of bone resorption is finished. They do divide into active cells by fission, known as the daughter cells or osteomorphs. So what happens, what we conventionally believed, osteoclast has a limited time of action, let's say 4 to 6 weeks. After that, they die. But what has fundamentally changed over the last decade is that one, osteoclasts are not short-lived. They can live up to 6 months, not only in the bone microenvironment, but from a site which is distant through movement through blood vessels. Second is, these osteoclasts may not end up as apoptosis merely. They can go on to progress to divide into osteomorphs. These osteomorphs are a pool of precursor cells. Now, these osteomorphs are not innocent bystanders. What happens is that in due time or in conditions, these osteomorphs refuse to form again a mature osteoclast. So these osteoclasts may again perform its activity of osteoclastogenesis. So these are all basic stuff. As clinicians, how it's going to relate to a clinical science is when you give denosumab, you have a very potent agent which increases BMD, prevents fracture. But the only concern when a dose is missed or subsequently patient is not on denosumab, what you see is rapid rise in the bone turnover markers, especially CTX, that may translate into enhanced fracture risk. Well reported vertebral fracture risk increases when suddenly your denosumab is stopped and your patient is not put on another antiresorptic, let's say like a bisphosphonate. Now, previously, there was no mechanistic insight why this is happening. The answer may be when you give denosumab, your osteoclastogenesis is blocked. You may have a pool of precursor osteoclasts which remain in the blood, let's say for 3 years when you continue denosumab. The day you stopped it, the 6 monthly dose is missed, no other drug is given. These pool again may be forming a osteoclast, but how it was that nobody knew. Now these osteomorphs may be those pool of cells which remain dormant for a period of 3 years. After the therapy was unwarranted withdrawn, they again refused to form a mature osteoclast that augments osteoclastogenesis and perpetuates bone loss. So we have now a mechanistic insight of how the denosumab induced rapid turnover is affected at subcellular level. And osteomorphs are distinct genetic variant from osteoclasts. Their genetic profile is different. So targeted strategies in future may be devised which would target these particular subtypes that may culminate in better treatment of osteoporosis.
So, please.
Now, just to understand, because this is news to me, so very, very well explained. But does that mean that we never end up with the osteoclastosis? It just carries on after even the death of osteoclast. You have these precursors which again take up that role. Does that mean that osteoclasts carry on? And secondly, the fractures occur immediately actually. Whether these what is that new cell? Osteomorphs become or reconvert themselves into osteoclasts by fusion and then create so much of osteoclastosis or resorption that they lead to fracture. It's difficult to really kind of comprehend.
Sir, whatever studies I have quoted, these are basically from murine models that has yet to be replicated in human studies. So that is one of the major drawbacks as of now. But the thing is, osteomorphs, in those McDonald et al., the pioneer study which have shown that existence of this class, they have shown there is a cycle which is ongoing, osteoclast to osteomorph recycling. Now what determines that? Whether your osteoclast is going to stay neutral, whether your osteoclast is going to stay apoptotic, or your osteoclast is going to form osteomorphs, that is determined by another group. They have shown mitophagy, another cellular phenomenon which drives which pool will go where. But these many answers are still gray, remain unanswered as of now.
Actually, denosumab is not merely keeping the osteoclast in check. It is killing osteoclast. Because without rank ligand, osteoclast will not be formed at all. And existing osteoclast would be dying.
But sir, one fundamental difference is this is a kind of reversible kind of thing which is not seen with Jolendronet, which is kind of a more irreversible form. That's why rebound fractures are very uncommon if you miss a Jolendronet dose in contrast to denosumab dose.
Right.
Possibly denosumab has also an inhibitory effect of reformation of osteoclast from osteomorphs, and that's why the pool of osteomorphs are very high. And once you miss the dose of denosumab, all the osteomorphs are again becoming osteoclast, and there is a rapid bone loss. So that is the concept of here. And this phenomenon is not seen with bisphosphonate. So
well, bisphosphonate hangs around in the bone. Because
it's a bone cement type of
it remains in the bone.
Exactly.
So even if we withdraw, the mechanism is different there.
Mittal, sir.
I think this is really interesting. Very curious to know about the regulation. What factors regulate the changing of osteoclast to osteomorph or osteomorph. Is anything studied in murine models?
Yes, it has been studied very elegantly. I will just snapshot of the thing. When you have a soluble rank ligand in your blood, it drives osteoclastogenesis. More of osteoclast, mature osteoclast is formed.
Right.
It performs its function of resorption. Now, at a certain point of time, when the job is finished, they may die a proportion of apoptosis,
Correct.
but certain subsets would go divide and form osteomorphs.
Understood.
These osteomorphs have two fate. They may again refuse to form osteoclast. These authors have given osteoprotogerin, which is a decoy receptor for rank ligand. When they introduced osteoprotogerin, this fusion was also blocked.
Okay.
So that this
At least
is what
one regulator is
yes, sir.
more or less, yes.
It is a natural thing and it is a different humanized model.
Exactly. And that is why possibly after stopping denosumab, the reverse is happening and we are having rapid bone loss.
I think it remains to be proven, but the concept is very fascinating. Yes.
Well, it was a Nature paper, I remember. There was a lot of hue and cry, but for some reason it has not taken up, it has not been followed up with many other groups on this one. That is what I have.
So regarding this osteomorphs, whatever studies has been done, that has been done in the murine model. So how you think we can apply in the humans this?
They have translated it like we have other markers. Let's say after bone resorption starts, you have given denosumab, you want to have a window before the CTX rises. So what they have suggested is you can use other markers like soluble rank ligand as a marker, therapeutic marker to monitor because soluble rank ligand and type B, isoform of TRAP, these rises much earlier even before CTX rises. So perhaps that has a translational value. We may use these markers to monitor when the bone turnover shoots up.
And is there any drugs which is being targeted on the osteomorph, which is in under development?
Because the cell is not well characterized, not much is known about the cell itself, so targeted.
So what do you think, we are targeting any drug on the osteomorph, what would be the future implication? Whatever the mechanism we have understood today, so if any drug we are developing targeting the osteomorph, what will be the future implication?
Maybe like a patient rapid turnover state in which if you target osteomorph, block it, that rapid turnover may not be seen when you withdraw the drug. That could be very niche area where the drug may be repurposed.
Thank you.
Coming back to, sir, your case, Hungry bone syndrome, we see a lot of Hungry bone syndrome even in Graves surgery. Let's say Graves with large goiter or nodule. Thereafter thyroidectomy also we can see Hungry bone syndrome. But that time it's sometimes difficult to differentiate with the hypopara. You already mentioned the PTH value high and low. So my question to you is that what is the PTH cutoff that you take to differentiate between hypopara and Hungry bone syndrome? And what other way you differentiate?
Yes. So basically, as I have shown on that pictorial diagram, PTH should be non-suppressed in Hungry bone syndrome.
Use your mic, please.
PTH should be non-suppressed in Hungry bone syndrome. It can be normal or even elevated, albeit definitely below the preoperative PTH level, but it should be non-suppressed. If it is suppressed with a hypocalcemia, it is hypopara. It may be transient or it is permanent. And your second question is, what are the other parameters we can monitor? Yes, we can monitor with phosphate level. We can very well monitor with the phosphate level in thyroidectomy patients, because the problem with ESRD, CKD, ESRD, secondary hyperpara is patient already has CKD stage 5B, where phosphate level may not be low, it may be normal or even high normal in hungry bone syndrome. But that is not the problem in total thyroidectomy patient after Graves' disease. And here phosphate is an important parameters. Rising alkaline phosphatase level, you can also monitor with those things.
So, Dr. Soham, what do you think like anti-FGF23 therapy in hungry bone syndrome?
FGF23 therapy?
Anti-FGF3 antibodies in hungry bone syndrome.
Because FGF23 has an inhibitory effect on the PTH. Yeah. So you think, so anything which will reduce the pre-op PTH level will reduce the resorption sites and will is expected to reduce the extent of hungry bone syndrome. But you have to keep in mind, FGF20 not only have action on the PTH, but also have action on 1-alpha hydroxylase. It also inhibit 1-alpha hydroxylase and decrease your calcitriol level. So maintaining an optimum calcitriol level is an important factor preventing hungry bone syndrome. So that will be hampered by FGF23. So the effect will be interesting. Still no one has studies. So important point to be considered.
Sir, you also mentioned about hypomagnesemia in hungry bone syndrome. What is the mechanism of that?
So basically, the minerals, divalent mineral will enter in the bone. The calcium, phosphate, magnesium there will be influx in the bone as the bone is hungry, and there will be fill up of the resorption space, and osteoid will be mineralized by this way. But magnesium has a problem with hypocalcemia, because hypomagnesemia will per se will reduce the PTH level, and it will also cause PTH resistance. So against precipitating further hypocalcemia. So you have to correct those things.
So, Dr. Soham, you have mentioned like the data regarding the preoperative use of bisphosphonate in hungry bone syndrome. So there were like conflicting results were there. So may I know from the house like what you like in your institution, most of you are following the preoperative use of bisphosphonate in hungry bone syndrome? Mittal sir, please.
We are not using it. We just optimize with the vitamin D and as much as we can, depending on, most of our patients are not in a tearing hurry for surgery. They're usually not very severely symptomatic or anything, so we give them low dose vitamin D, correct it, and then go for the surgery.
We are not also using it to prevent hungry bone syndrome. Wherever we are using denosumab or bisphosphonate preoperatively, it is because to reduce the severity of the hypercalcemia and making the patient fit for surgery. It is not intended to be for hungry bone syndrome, but it may be a bystander effect.
Correct. So I think we had a very wonderful session and a very good interaction between the speakers and the audience. We conclude the session here. Thank you. Thank you. Over to the organizers.
Moving on to the next session, where do we stand in 2025 is the name of the session. To chair this session, I would like to call upon stage Dr. Hamid Ashraf and Dr. Jayantu Chakraborty sir on stage, please. And also I have an announcement to make. There's a meeting scheduled in the Kuch Bihar meeting room for the IGM Reviewer Orientation program from 3:15 to 4:15 p.m. So those who are interested can attend that meeting in the Kuch Bihar meeting room. Thank you.
next session is where we stand at 2025. So there are three topics with the three stalwarts of the endocrinology India. The first is the diabetic osteopathy. We know much about it. Then the second topic is tumor-induced osteomalacia. We also know enough about it. But the third topic, what is the optimum level of vitamin B12? We don't know anything. And if you contradict, then if you know anything, that we are quite confused. So, Professor Mittal. B12, sorry.
Thank you. Thank you very much. Happy to be part of this rather interesting session in this smaller gathering than the main hall. A lot of interaction in the previous session is very encouraging. My talk today is on diabetic osteopathy. And basically, there are many aspects to it, so it's almost impossible to cover the whole thing. So instead of going too deep into the pathophysiology, I'm going to talk about clinical approach to management of osteoporosis in a person with diabetes, right? So that's part of the team at Max Healthcare Delhi, which is where I work. We have 8 consultants and several DNB students, 6 DNB students, diabetes fellows. So it's a large group. So interestingly, an association between diabetes and reduced bone mass was first described by somebody who described everything in endocrinology, Fuller Albright and Riefenstein. Imagine the corridors of Brigham and Women's Hospital. They must have been crossing each other. And they observed that there is a low bone density in people with, this was type 1 diabetes basically, okay? Then it went into hibernation. No one chased that. And then in 1981, there was a paper in CTI saying osteopenia in juvenile diabetes. Again, we're talking of type 1. And then in 1991, someone had the courage to call it diabetic bone disease. Now, most of the time, these are all referring to type 1 diabetes. Today, we're going to talk about type 2 diabetes, not of type 1. And the reason is that even when we were students, or even till much later actually, it was said that insulin deficiency, insulin is a growth factor. You get deficient bone growth, and type 1 diabetes patients have osteopenia or greater risk of fractures if they live long enough. In type 2 diabetes, the bone density is high. That was a one-line opening sentence. Oh, type 2 diabetes, nothing to do with osteoporosis because the bone density is higher, right? So let's look at the reality there. Now, when they started doing studies on fracture risk and not bone density, fracture risk in people with diabetes, and there are plenty of studies, and this is an old meta-analysis, there are new ones, they all range in somewhat the same zone. But the important point here is that if you look at type 2, forget the type 1, there's no doubt, type 2 clearly between 1.5 to 2 times greater risk of fracture. Some studies have shown up to 3 times also, but definitely above 1.5 times. So the risk of fracture, hip fracture being sort of a good gold standard to use because there can be no confusion about hip fracture. So it's more than 1.5 times that of the non-diabetic population. So that's more or less established by dozens of studies now. But it's important again to see that if the bone density is not severely affected, why do diabetics have higher fracture risk? And this is again very important, and our understanding in this area has increased or improved considerably over the last decade, that bone turnover, sort of bone density is just one factor that determines our fracture risk. One very important factor is fall risk, which is clearly higher in people with diabetes. Quality of bone is different in people with diabetes. Bone turnover, so all those factors are there. There are other things, including direct glycation impact and other things. But the fact is that it is not just bone density. Bone density may not be low in comparison to age-matched peers, but fracture risk may be high because of extraskeletal factors that increase the risk. So that's important to remember. So when you're treating someone with osteoporotic fractures and trying to prevent future fractures, important that you don't just look at the bone density and say that is the
That is the only way. It's a little bit like diabetes. You don't just treat the HbA1c. You have to look at everything together, right? Now, this was a study where Nikhil and I were involved, and Parjeet was the first author. This is nothing, just to show that in the same INDIAB study, where we joined in with Dr. Mohan on this, we found that there was just self-reported fractures. That's a large epidemiological study, no other data, just fracture history reported by the patient in a proforma. And we found that there is a difference in fracture risk. No diabetes, diabetes, pre-diabetes. Clearly, people with diabetes had greater self-reported fractures in this, and the OR was about 1.3. So some increase in fracture, self-reported fractures in a large population-based study. But there was no other information in this. There was nothing else, only just self-reported fracture. So what could be the factors predicting fracture? Very interestingly, again, I've chosen one, but there are several studies. Quite clearly, as the A1C goes up, the fracture risk goes up. Numerous studies have shown that. Now, that could be these people are overall more poorly controlled, they have more comorbidities, they have longer standing diabetes. This was just A1C correlation. So poorly controlled diabetes, like will give more retinopathy, more nephropathy, more other things, will also increase the risk of fracture more. A well-controlled diabetic doesn't have the same risk of fracture as someone with poor control over the years. Now, so therefore, when we look at what is actually happening to the bone, and that's the part that I have omitted to keep the talk to 20 minutes, and just summarized in one, this is a bit of oversimplification. But insulin and IGF deficiency definitely inhibit osteoblast-mediated bone formation. No confusion about that. And the second is that accumulation of advanced glycosylated end products, interleukin-6, TNF, they promote proliferation of osteoclasts, right? So on the one hand, you are reducing bone formation if there is insulin deficiency, and in type 2 diabetes, where that is not so much the case sometimes, then the second part, that is stimulation of osteoclastic activity. And there are lots of studies on bone quality and some very, very interesting work from PGI Chandigarh in this area in collaboration with their basic science partners, but we are not going into that just now. Now, this is a good CT image of a diabetic bone, and the only reason I'm showing this right side is this is the person with diabetes and vertebral fracture. The idea is to just illustrate this one point here, that it is said that the cortical porosity increases in diabetes. And there is actually a word called trabeculization of the cortical bone. So hard bone becomes more spongy-like. That's a characteristic feature of bone changes in diabetes. Just to remember for postgraduates, if there anyone there, this is one point that you need to remember always, that this is the fundamental change in people with diabetes. So then the clinical dilemma is, how should we predict fracture risk and how should we treat it? Now, various studies have shown various risk factors. Of course, type 2 diabetes for more than 5 years, some studies say 10 years. So early type 2 diabetes is not that much of a risk, but certainly more than 10 years, definitely, possibly more than 5 years. Poor glycemic control, already said, more than 9% A1C consistently. Those who have comorbidities, coexisting complications, already have retinopathy, already have neuropathy. Neuropathy is very important for diabetic, for osteoporotic fractures because risk of falling is much higher. Simple cataracts, so neuromuscular coordination, eye vision, all those things are important. And there are some studies that have also shown, well, one is consistent among the drugs. Thiazolidine diones are not good for the bone, no confusion. I'm not going to spend time on that you all know, that pioglitazone may increase the risk of at least long bone fractures, but overall osteoporotic fractures. Sulfonylureas and insulin is largely because of the hypoglycemia they may produce, or insulin may be used in people who are already sick and have multiple comorbidities. It's difficult to distinguish. They are not directly bad for the bone. Now, how do we use bone mineral density? And I already said that bone density is not so low in people with diabetes as compared to those without diabetes. But the important part is the relationship of bone density to fracture remains intact. But the fractures happen at a slightly higher bone density. So even within people with diabetes, as the bone density declines, fracture risk goes up. No confusion about that. Except that the threshold is different. Threshold for fracture might be a little different in people with diabetes. Remarkable study here, which showed that people with, this is a 10-year hip fracture risk. You can just look at this. This is people without diabetes, this is people with diabetes. For the same, this is a T-score, okay? This is minus 2.5 and this is minus 1. So for the same T-score, the purple bar is higher everywhere. For the same T-score, people with diabetes have greater fracture risk than people without diabetes at every T-score. So it's the threshold that changes, but the relationship will remain intact. The other thing is FRAX. FRAX, of course, you know, is a fracture predictive tool used very commonly now. There are some question marks on Indian FRAX, but it doesn't matter. Whatever is being used, overall, FRAX underestimates risk in type 2 diabetes. That's well established. So if you're using FRAX, even that underestimates the risk. So there's a challenge. Bone density underestimates the risk. FRAX also underestimates the risk. So there is a bit of a question mark there again. Lower limb fractures, which are commonest in diabetics, are not well predicted by FRAX. But anyway, so therefore, and there are many gaps in FRAX. I don't have the time to explain the problems with FRAX, right? So there are lots of things. How many people have used FRAX here in the hall? Right, great. So there are problems. You know, previous fracture, when was it? When that makes a big difference. How many were there? Somebody had 3 fractures, somebody had 1 fracture in the past. Glucocorticoids, yes, no, what, yes, no. I mean, you know, how long, what dose, all those things. So this was a simple way, obviously a good way to start. But therefore, FRAX Plus was developed. FRAX Plus is presently available only on payment. It's not available free. So we are trying to convince IOF to allow it, or Sheffield to allow it free, but or maybe society can buy and just give it to all, something like that. So there, all these things are added. Diabetes is added for the first time. Duration of diabetes is also added. Dose of steroids, you know, how long they've been taken, all that. So this will probably improve that. So this is one of the review papers / position statements we did with the IF. I'm part of the Diabetes and Bone Working Group for the International Osteoporosis Foundation. And sort of we keep coming out with statements in areas which are confusing. So osteoporosis drugs' impact on bone turnover is same as in non-diabetics. Baseline bone turnover is confusing in diabetics, right? But response to drugs is the same. So basically, many things were looked at, but ultimately, HbA1c was the only predictor of fracture risk. The relationship was only with poor control. But the response of the use of biochemical markers to predict response or in treatment as we do is intact in diabetes. That's not a problem. Then what else can we do to predict trabecular bone score? And there's good work again from Vellore this time in this area. This was one of the best papers 10 years ago from a Chinese group, Korean group, trabecular bone score as an indicator. And you look at this and just not spending time, low TBS correlates with prevalent vertebral fractures. So bone density, you have to alter the threshold. Bone turnover markers, baseline, no, but response is good. Trabecular FRAX, you know, again, is a bit of a challenge, but FRAX Plus is better. And trabecular bone score might be adding. So again, we wrote a review on this. And what we wrote was that both trabecular and cortical parameters measured by HRQCT, which is again being done now at Chandigarh very effectively, is lower. So it's not just the bone density by DXA, which is lower, the usual DEXA bone density, but even if you do it by HRQCT, you find that it's lower. But lumbar spine TBS has been reported to be lower consistently. The discordance between bone microstructure and degraded TBS is probably the effect of central obesity. Again, one line here, always we've thought of obesity is a protector against osteoporotic fracture, but not true. Central obesity is an independent risk factor of osteoporotic fracture. So central obesity is what alters the TBS and increases fracture risk, and future may say see use of TBS combined with BMD and FRAX tools to predict fracture risk better in people with diabetes. Now, instead of going into all the things, I just thought I'll put in 2 slides or 3 slides on this because this is the topic of the season, this is the flavor of the season. GLP-1 RAs and fracture risk. You all know I told you pioglitazone increases risk and the others are more or less neutral. What about GLP-1 RA? A lot of questions, no? GLP-1 RA, bone and muscle, you know, all those. We're not talking of muscle today, but A very interesting study from Dr. Badada's group, just published like, I think last week or maybe 2 weeks ago, looking at effect of oral semaglutide on volumetric BMD and bone microarchitecture in obese patients with type 2 diabetes. And they actually, forget the details, read the last line. Oral semaglutide improves vertebral BMD despite a reduction in body weight. With DEXA, the problem is when the reduction in body weight will alter the DEXA interpretation to some extent. With HRQCT, that won't happen so much. So there was no decline. In fact, there was improvement in in bone structure despite loss in body weight. So I think that's important for us to understand this fear of these drugs affecting the bone adversely. And then we looked at a very large, or the largest meta-analysis so far, and they found that overall fracture risk, 23% reduction in the group that was on GLP-1 RA. In this, of course, the main group was liraglutide. This is just an analysis of 26,000 and 21,000, 47, 48,000 patients. Okay, so this is one of those large meta-analysis, and you find that there seemed to be a reduction, at least with liraglutide, in fracture risk. And it only happened when treatment duration was more than 1.5 years. Obviously, in bone, you don't expect necessarily, unless it's a very dramatic thing, you would normally expect it will take time. That's what was the result of this study, which matches the study that Dr. Badada's group did, and also another study, which has also come on semaglutide and improvement in bone density. Now, there may be liraglutide, we'll leave that. Their mechanisms are being worked out, may suppress osteoclast formation and promote bone formation through different pathways. It's still speculation. And Nebedia is here, and we wrote a review in the Journal of Endocrinology about role of GLP in osteosarcopenia. And there again, when you look at all the studies which are looking at all the models where muscle and bone have been studied, there are no negative impacts of the drug themselves. This is important. So people, when they talk of muscle loss in patients on GLP-1, are talking of muscle loss as a part of weight loss. But whether the drug itself is affecting the muscle or bone adversely, that's not been shown at all. So we need to be confident about this part of it, that it's the same thing that would happen after bariatric surgery, but maybe not as bad as after bariatric surgery. Same thing that will happen if you go on a very low calorie diet. When you lose weight, you lose fat, you lose some muscles, so 20-30% can be muscle. So that is important, but it's not that the drug is toxic to the muscle or bone. I think that's very important. There could be many, clinical outcomes are all mixed. So mechanistic studies and preclinical data we wrote suggest that GLP-1 RA are beneficial for bone and muscle, but clinical outcomes are all mixed because of the central obesity, so many other things. But now more and more clinical data to suggest that volumetric BMD is actually improved with the use of at least semaglutide. So what about treatments? In one line, all treatments work the same way as they do in people without diabetes. I won't waste your time on that. But what is interesting towards the end is denosumab and the incidence of type 2 diabetes among adults with osteoporosis. Now this is very interesting, going the other way. So 4,300 new users of denosumab were matched with 21,000 of those on oral bisphosphonate. And incidence rates of type 2 diabetes was lower in people on denosumab. So, yeah, just 1 minute. So clearly denosumab seemed to reduce the risk of development of diabetes in this study. It's just one study, but this is what it shows. So, and definitely as compared to oral bisphosphonate, showing the same data here, that is bisphosphonates, diabetes risk. This is denosumab, the yellow line, denosumab diabetes risk. So it seems to go down. It could be related to the rank ligand. I don't have time to discuss that, but it can, rank ligand inhibition with denosumab can ameliorate subacute inflammation, and rank ligand also has a role in beta cell proliferation, so replication. So there also there could be something interesting there, which time will tell us. And the last is how should we then do it in our clinic? I think it's very important that as endocrinologists, all of us treat large numbers of people with diabetes, very large numbers. Whatever else you might do, you are treating people with diabetes for sure. And I think it's a good idea. This is the IOF recommendation. There was a bit of we had a lot of discussion in this, but anyway. So the thing is that if patient has a fracture, there's no discussion. Let's go to the right. If patient doesn't have a fracture, right? Then basically you should do a bone density, ideally with TBS if possible, but if not, at least a bone density. This recommendation says in all over 50, men and women. So that seems a bit much, and you treat at a T-score of -2. So the recommendation right now is not changed. All those over 50 with diabetes should be screened by a bone density, and if you find a bone density which is -2 or lower, you should treat it. So what we are following in our clinic, this is almost impossible to implement, but for almost 2 years now, we are screening all our patients above 60 who come to us with diabetes by using a bone density. So 60 is a cutoff. That's just arbitrary clinical. I'm just sharing what we do. I don't have any recommendation to say why 60, why not 55. I don't have any data. Just common sense that, it's impossible. All our diabetics over 50 is a large number. So over 60, we are screening with bone density. And even if you do that and use -2.5 as a cutoff, still you'll end up treating a lot of patients. Not using -2, not using 50. Still you'll end up with a lot of patients. So these are we forget these are already discussed, these points. All drugs work. So this was a small study done where an audit was done by APCO, led by Manju Chandran. I was one of the lead authors, one of the authors of the study, and it shows that we did an audit of use of osteoporosis evaluation in people with diabetes. What are people doing across Asia? Now, unfortunately, this is a bias sample. We had 100% results because everyone was screened because that policy was in place at that time. But this was the only place. Overall, the 31% patients underwent assessment in this 1,000. Just getting data that what is your policy for screening, right? And how many of your last 20 patients, how many underwent bone density? And this is not data, but just saying that, just to emphasize the point, of the first 250, this is a slide that is almost 2 years old. Of the first 250 patients, 130 had T-score of -2.5 or less. So roughly, and the percentage is similar, roughly half the patients we screened required treatment. So it actually adds to the complexity of treating diabetes. You're already looking at blood glucose, you're looking at their CGM sometimes, you're looking at hypertension, you're looking at lipids, you're now looking at fatty liver, you're also looking at, there's so many things you're looking at. And to add to that, you add this, so then the other require further testing, bone turnover markers, and they require treatment, and in their follow-up, they require looking at that. Thank you very much. Thank you.
Thank you so much, sir, for such a nice and elegant presentation. There are a lot of confusion. At least your presentation has made some difference how to work up these patients with diabetic osteopathy and how to work up them and when to treat and how to treat. And I think there will be a lot of questions in the mind of the audience. Definitely we'll take all those questions after this is over. Our next speaker is Dr. Sanjay Saran, and we all know him. Sir is Associate Professor at the Department of Endocrinology, one of the largest department at SMS Medical College, Jaipur. And he was organizing secretary of ESICON 2022, and there are a lot of honors, and he has also 47 publications and many book chapters. Welcome, sir. The stage is all yours.
Yeah, first of all, I'm thankful for the organizing team for inviting me here on such a big, this academic platform. So, I'm very thankful for the organizing team for inviting me here on this academic platform. We know this is the biggest, you can say, the academic activity of our Indian endocrinology, that is Endocrine Society of India. So this is a very rare thing that they have given me this topic, that's the ultra rare disease, that is tumor-induced osteomalacia. So let's start without delaying. So we know tumor-induced osteomalacia, it's a paraneoplastic syndrome which is mainly because of the phosphaturia that causes hypophosphatemia, and also because of the overproduction of the FGF23. So it is also known as phosphaturic mesenchymal this tumor syndrome. So mainly caused by the mesenchymal tumors, which can be there anywhere in the body, mainly on the extremities, particularly lower extremities can be there. Usually they are found on the musculoskeletal part of the body, not on the viscerals. It's very rare on the viscerals. So on the cranium also we can get such kind of the tumors. So biochemical features of TIO are again hypophosphatemia along with phosphaturia, then overproduction of the over high level of this FGF23. So this is mainly the biochemical hallmarks. So if we are going through this pathophysiology of this tumor, so here we can see FGF23 overproduction is there, that causes phosphaturia. So again the phosphate level will be low in the body, so that causes mainly the symptoms of the this tumor. So later on, if we are removing the tumor, obviously we get some good prognosis is there. So going towards the this epidemiology, so we do not have the much study on this. First study is from the this Japan, so they are showing prevalence is not so high. It is just like the X-linked hypophosphatemic disorders. Hypophosphatemia indicates in children or in adults, it's a hypophosphatemic disorder, that is X-linked. According to that only, it is that same this prevalence is there. Other study from the Denmark, they are also showing it is very rare tumor, so it can be there like this 0.1 in per 1 lakh of the population, or 0.43 in the adult population of the this whole country, 0.4. So it is very rare tumor. Now here the prevalence, other estimated prevalence in some other study, it is not there, only male to female ratio is there. Somewhere they are showing that the 0.4, this 40% are female, somewhere they are showing 55% are female. So we don't have the adequate data to this level, this epidemiology is complete. So now this is the pathophysiology of this tumor. So first overproduction of the FGF23 that leads to this decrease in the alpha 1 alpha hydroxylase activity, that causes decreased amount of the this 125 dihydroxy cholecalciferol. Then also it increases the 24 alpha hydroxylase activity, that causes the increase in the 25 this alpha vitamin D. So particularly active vitamin D is decreased, FGO23 is increased, and hypophosphatemia is there. So this is the pathophysiology behind this tumor, that decreases the phosphate reabsorption, particularly from the this proximal tubules of the kidney, and also decreases the phosphorus absorption from the intestine. This acts particularly on these various channels which are the sodium, this phosphate and the sodium phosphate channels particularly. So now come to again what is the molecular mechanism behind it. So molecular mechanism behind it, that this F1 FGR F1 fusion gene is there. So one is this one, other one is this the F1 FGF1 fusion gene. So these fusion gene causes sustained activity of the FGFR1 receptor. So it causes increased production of the FGF23. So that leads to this all activity. In many of the patients, we do not get this FGF1 fusion gene or FGF1 and FGR fusion gene, it is not there. In those patients, the clotho is there. So clotho is sometimes bound to this receptor FGF1. So that can also leads to this the pathophysiology of the increased overproduction of the FGF23 here. So now come how this tumor responsible for all the mechanisms. So many times we do not see even the FGF overproduction is not there. At that time, many other metabolites are there. We can say these are extracellular phosphoglycoprotein is there, soluble Fitzgerald related factor 4 is there, even FGF7 is also produced from these mesenchymal tumors. So many times these factors denote this causes the hypophosphaturia, but mainly this is FGF7 that can cause the hypophosphaturia, hypophosphatemia and phosphaturia in such kind of syndrome. So yeah, so again this is the same thing I have described here. Just these are the various sodium phosphorus channel, that is 2A and 2C. These are affected at the proximal tubules of the kidney, where the reabsorption of phosphate doesn't occur. So now the clinical presentation, we know this mainly skeletal or non-skeletal. So in the skeletal presentation that is non-specific, particularly bone pain is there. So we know misdiagnosis can be up to more than 90% of the patients if first time the patient is going to the doctor. So even in some study they have shown that initially it was misdiagnosed as 95% of the patients. So when the tumor located somewhere else like nasal sinus or like that, that we have some nasal congestion or some other the symptoms. Otherwise, the symptoms mainly is the bone pain, then muscle weakness is there, then later on the patient can bound to wheelchair, sometimes the kyphoscoliosis or some hip fracture also there. So these are the very skeletal symptoms. So again, the misdiagnosis we have already explained that this was the study from the China. Here the 144 cases were studied. Then again, they have shown that 95% time, first time they have misdiagnosed. Then 245 patient here, again they have misdiagnosed the patients. So it's a very rare disease. So here, so again the other clinical features like we can see the bone pain, then difficulty in walking, pathological fracture, height loss and muscle weakness. So height loss is, we can say it's a very sensitive because it's not seen in many more other commonly in other patients. So that should raise the possibility here. And other thing is that mainly these symptoms occur in the adult population. Before 18 years, it's very rare. Although it is almost, it's rarest the disorder, but still in the children's it is very rare. So again here misdiagnosed condition, I'm not going in detail like intervertebral disc herniation, spondyloarthritis, then osteoporosis, then femoral neck necrosis, even bone metastasis also can be misdiagnosed with this disorder. So now come to the non-skeletal manifestation. They are like weakness is there or some patient may present with severe disability in difficulty in walking and sometimes wheelchair ridden. That is all because of hypophosphatemia that leads to decrease in the ATP and ADP inside the cells. So that causes the severe weakness. And there can be then later on with the treatment related that maybe secondary or tertiary hypoparathyroidism also can be there. So these are various common features. Then come to the skeletal, these manifestations, how we can diagnose with some X-ray, because many of the patients, whenever they are coming to us for such kind of condition like musculoskeletal condition, we used to go for the X-ray. So here on the X-ray, we can get the osteomalacia and Luger's zone. Pseudo fractures are also there. We know the pseudo fractures, we are not getting on the area of stress. Particularly, we are getting area of non-stress on the bone, which are traversed by the particularly blood vessels, arteries, mainly arteries. So these are the various areas of Luger's zone like ischopubic area, iliac wing, then tibia, radius, fibula, and this lateral scapula. These are different kind of areas where we can get usually pseudo fracture. Here in this beautiful diagram, we can get the pseudo fracture here on this tibia also, then even on this fibula also, and also here on the scapula. So now come to the bone density. We know bone density is also severely reduced in case of tumor-induced osteomalacia. So we can confuse it with the osteoporosis also, as I have already shown here. So now come to distinctive laboratory features. So these are the hallmark of this tumor-induced osteomalacia: hypophosphatemia, phosphate level less than 2.5 milligram per deciliter, because it is usually in the adult male, it is around 2.5 to 4.5. So lesser than this, it can raise the possibility of some hypophosphatemic disorder. Then come to the tubular maximum phosphate reabsorption per glomerular filtration rate. That is very diagnostic of this syndrome. So value again, it is just around the phosphate value in the blood, 2.5 to 4.5. So again, the renal phosphate wasting that caused the high levels of FGF23. That again, if the obviously bone turnover is high because of the hypophosphatemia, so alkaline phosphatase level will also be raised in such kind of condition. Now these are the metabolomics. I am not going into details because we do not have some robust data on this metabolomics still. So now come to the tumor localization. So the most commonly how we can localize the tumor, particularly it is seen in the lower extremity maximum, head and neck 24%, then torso 9.4%, upper extremity is 6.9%. So tumor can present anywhere in the body. So it is not like that some part is exclusively involved. So it can present anywhere in the body. So first to diagnose the tumor, we need the functional imaging. So functional imaging technique, we have some tumor is having some somatostatin receptors, particularly type 2. So such kind of receptor can be used with some functional imaging like this. We can use this technetium hydrazonic cotinamide, that one octreotide scan, then mainly the gallium dotatate PET CT that is having sensitivity at over 100% and specificity is very high, 90% with accurate localizing the tumor. So this one mainly we are using, otherwise FDG PET also we can use in such kind of condition, that is also seen, but it is very difficult to differentiate between the metastasis and malignancy with this tumor-induced osteomalacia with FDG PET. So many the functional imaging are there. Mainly gallium dotatate is this having high sensitivity and specificity. Technetium scan also can be used, indium scan can also be used, but we have the gallium dotatate better. Then come to the anatomical this imaging. So how to see this anatomy of the tumor. So before going to towards the surgery, we need some anatomical image. So here we can see the contrast enhanced MRI or CCT. These are the both anatomical imaging. So with the MRI, we know nowadays we are having 7 Tesla MRI, so that is better than the 3 Tesla MRI. So define better this tumor. So how the surgeon can access the tumor. Now come to the venous sampling. Somewhere we cannot define the tumor. It is very unusual. Sometimes we cannot diagnose where the tumor is there. So at that time, or sometimes multiple tumors are also there. So at that time, selective venous sampling we can do. So we can see the level of this FGF23 here. So here in this study, they have diagnosed this intact FGF23 level at the various sites. So that can also be done, but it is very rarely it is required. So again, FGF23, we need some intact FGF23, because the C-terminal and N-terminal, if you are cleaving, then the activity is not there. So at that time, here in this particular TIO, we need the intact FGF23 level. So these are various differential diagnoses here, like nutritional phosphate deficiency, vitamin D deficiency, malabsorption syndrome, rheumatological, neurological, and other like Fanconi syndrome. So we need to diagnose this tumor with such kind of condition. They are also not so common. They are also very rare conditions. So from these conditions, so this is the diagnostic algorithm here. Hypophosphatemia presenting symptoms, then clinical presentation. If it is related to TIO, then we go through this biochemical parameters like calcium, creatinine, vitamin D, PTS, and 24-hour urinary creatinine and this calcium. Then accordingly, if you are seeing the low level of this FGF3 or high level of FGF3 are there, at that time we see the tumor can be there. We go for this functional imaging. Now here we can see here that if we are getting the low level of FGF this 23, at that time it is non-FGF23 related disorder. Particularly, it may not be TIO, maybe something else, or even I have just shown previously that FGF7 can also behave like FGF23. So that can also be there in very rarest of rare cases. Or if the FGF23 related disorder there, then we can consider some other differential diagnosis. Then rule out the diagnosis like McConnell-White syndrome and other like hypophosphatemic this disorder in the adults. And then go for the functional imaging like gallium dotatate scan or this FDG PET scan. Then perform the anatomical study, anatomical imaging, then perform if it is not required, if it is required, then go for the selective venous sampling. So this is the approach towards the imaging study. Then come to this treatment. So in the treatment part, we need the tumor is there. If the tumor is diagnosed, then we need the surgery. So we know the surgery, if done with the adequate margin, then the disease is most likely it is cured with the surgery. So sometimes lesions may not be identified. At that time, we need some medical therapy, like conventional therapy or some specific therapy, or lesion if identified and it is resectable, then with the wide margin resection is this treatment of choice. If resection is not feasible, medical therapy can be there, then ablative therapy can also be done in such kind of these conditions. So here, so now the outcome of surgery, we know surgery, it depends on the site of the tumor, so where the tumor exists particularly. So sometimes the worst outcome can be there, particularly in female sex, tumor in the bone, then spinal tumor, malignant tumor, then lower this post-operative, pre-operative phosphorus level, then higher post-operative FGF23 level. So sometimes during surgery, intraoperative FGF23 levels are also done. So we don't have the big trials on that. Again, now come to the post-operative recovery. So after resecting the tumor, if surgery is good, surgery outcome depends on the surgeon's experience particularly, and also the tumor characteristics also. So within few days, we can get the normal level of this FGF23, normal level of phosphorus, but this osteomalacia, these things require some long years or some months or years. So come to the conventional treatment if medical treatment is required. So conventional treatment is this calcitriol that can be given the dose of 0.5 to 1.5 microgram per day, or sometimes it is given along with phosphorus. So phosphorus dose again it is around 2 to 3 gram per day. So if calcitriol is not available, then we can use alpha calcidiol because of many of the hospitals nowadays, alpha calcidiol is freely available. So dose is just double to calcitriol. So still we are not getting some good result with alpha calcidiol even after giving the higher doses. So that is a conventional treatment. With conventional treatment, we can get some this adverse effect like nephrolithiasis, nephrocalcinosis, impaired kidney function, then secondary or tertiary this hyperparathyroidism. That can also be there. So now come to the cinacalcet. So this is a very beautiful agent. This is using in many where in the hyperparathyroidism. So here also we can use this agent. We know it acts particularly this is calcium sensing receptor modulator. So here they are saying that calcium sensing receptor can also sense the phosphorus also. So if phosphorus is low, then they are increasing the PTH level. So again, sorry, they are decreasing the PTH level. So again, so it is the pathophysiology behind this using of this cinacalcet level. So the result low PTS was associated with an apparently a weakened phosphaturic effect of FGF23. Then it doesn't directly annihilate the tumor tissue. Sometimes the tumor tissue is grown with the use of cinacalcet in some studies they have shown. Now come to the somatostatin analog. There are also mixed results are there. Only case study are there. Somewhere in one study they have used the tumor. This is cured. Other study they have shown that 2 patients nothing happened. 4 patients nothing happened. So we do not have the data with octreotide. So other novel therapy like here FGF23 antibodies. So borsumab, this burosumab we can use. So it is a fully humanized monoclonal antibody against the FGF23 approved for the treatment of X-linked hypophosphatemia disorders. So it is efficaciously normalize the phosphorus level and also ameliorate the bone deformity and relieve the symptoms of X-linked this hypophosphatemia disorder. So it is approved in the US for the treatment of tumor-induced osteomalacia. Even in the Europe also it is approved for the treatment of tumor-induced osteomalacia in adult population only, more than 18 years in the US and more than 17 years in the European countries. Here in India also we are expecting it would be improved very soon. So now here in the treatment this burosumab they have 2 trials we have here with the burosumab here. So with the dose of around 0.3 to 0.7 milligram they have used and they have got some beautiful results in the both of the trials. These are the phase 2 trials. Based on these phase 2 trials it is approved in the US and European market. So here then come to here to other therapies like FGF inhibitors. So still they are in developing phase. FGF inhibitor we have only the animal studies. We don't have the human studies with these molecules. Now come to here toxicity. I'm not going into details. So other treatment like ablative therapy, we can ablate the many times small lesions are there. That time we can ablate with the heat ablation can be there with microwave or radio frequency, and some alcohol ablation, chemical ablation, or cryoablation can be there, or maybe ablation with peptide receptor radionucleotide therapy. That also again the somatostatin receptor this base therapy. So these are various other. Now mechanism of action of different potential agent. I'm not going into details now. Over. Thank you. Thank you very much.
Thank you for such an illustrious presentation. There will be so many questions, very difficult to treat, very difficult to diagnose, and very difficult to suspect, as sir has already shown in different slides. Now, we will have the last session of it.
our third speaker is none but Dr. Marwa, Raman Marwa. So he will speak about the optimum level of vitamin D, most controversial subject, I think so.
Good evening, ladies and gentlemen, and thank you, speakers. And I must thank the organizers for having me here. What I'm going to talk to you is what is the optimal serum 25-hydroxy D levels, a critical evaluation. I am at a loss as much as you are, but I'm just trying to go through as to how do we try and define what is normal or optimal 25-hydroxy D. So what is optimal 25-hydroxy D for normal bone or global health remains a bone of contention. The controversy can be very clearly reflected in the diversity of the recommendations regarding vitamin D intakes. Different scientific bodies recommend different intakes. If you take Pediatric Endocrine Society, they define deficiency as less than 15 nanograms, insufficiency as less than 20 nanograms. However, if you take US Endocrine Society deficiency, they define deficiency as less than 20 nanograms per ml and insufficiency as between 20 and 30. Institute of Medicine defines deficiency as less than 12 nanograms, whereas between 12 and 20, it is called insufficiency, and more than 30 or more than 20 is sufficiency. So these cutoffs have been based on certain parameters which we are going to take. So what are the different ways to define optimal 25-hydroxy? Should we have population-based normative data of serum 25 to define what is normal? Or can evolution tell us how much vitamin D do our bodies need for maintaining normal bone and global health? Should it be based on the possible inflection point at which PTH levels start to rise with falling levels of serum 25-hydroxy? Or should serum optimal levels be based on calcium homeostasis? I think I'm not getting the full picture in this. And the other way is to define as to what is that level which would prevent future fractions or decrease preventions, or some of them have based optimal level on the basis of BMD. So coming to the population-based serum, can we really use them? Well, the investigators did realize that the population-based normative data cannot be used because of differences in the genetic, ethnic, environmental, cultural differences, location, and several other factors in different populations. Well, if you take the historical background, the human ancestors in Africa had plenty of exposure to UVB rays, and thus they produce fairly large amount of vitamin D in their skin. And if you take children and adults who are living in similar surroundings, like in Mosoi and Herdezel tribes in South Africa and Gambia, the levels are between 30 and 45 nanograms per ml. So some of the investigators feel that these levels are considered desirable serum 25-hydroxy levels for skeletal and extraskeletal health. However, others believe that these serum levels may reflect the maximum levels that evolution allowed in the presence of excess UVB radiation. So this is probably that this is a cutoff for toxic serum 25-hydroxy levels and not normal 25-hydroxy levels. So coming to PTH as a marker of vitamin D status, This has been extensively studied as a marker of vitamin D status since parathyroid gland is the key tissue responsible for calcium homeostasis. Now, the definition of optimal 25-hydroxy has been tried on the basis of two inflection points. The first inflection point is when the serum 25-hydroxy level, where the PTH levels plateau. That means the levels of 25-hydroxy where there is no more rise, the PTH levels plateau. And the other one is the serum levels where there is a sudden steep rise in PTH levels. So the serum levels where the cutoff level where there is a sudden steep rise in the PTH, that is to define what is vitamin D deficiency. And where the serum PTH starts rising is what we should consider as serum 25-hydroxy deficiency. Insufficiency. So these different inflection points for different age groups are there. If you take adults, it has been very well established that there is an inverse correlation. That has been well established, and it is not linear. It is a curvilinear curve which shows the relationship. Thomas et al. Observed that the PTH values increase when the serum 25-hydroxy concentrations fall below 15 nanograms per ml, suggesting that that point is likely to be, the inflection point is likely to be 15 nanograms. That means that is the cutoff below which the PTH starts rising. Hollick et al. Showed that the rise in the PTH occurs when the concentration of serum 25-hydroxy falls below 29.8 or 30 nanograms per ml. A recent study here from Calcutta itself by Mukhopadhyay et al. Revealed two reflection points, that is a cutoff of 16 nanograms per ml suggesting deficiency and a cutoff level of 32 nanograms per ml suggesting insufficiency. So thus the estimates of inflection points from various studies range from 15 nanograms by Thomas et al. To almost about 44 nanograms by Haney et al., which was kind of published in Journal of Steroids. And recently, Kroll et al. Did confirm inverse correlation, and they had a huge data, but they did not discuss about the inflection point between 25 and the PTH. So if you see in adults, this is a relationship. If you see here, now this is at 20 nanograms, PTH starts to rise. And it is at 10 that it starts suddenly accelerating, going up. So this is the first inflection point, this is the second. So you can define deficiency at this level, 10 to 12, or at 20. Coming to inflection points in children, we in early studies, myself and Nikhil, we had very clearly showed that the PTH starts plateauing at the level of 20 nanograms of serum 25-hydroxy. But the steep rise was noted when it was less than 10 nanograms. And more recently, there is a study in children and adolescents with overweight and obesity who also revealed two inflection points. One was that PTH mean plateaued when the concentration reached more than 20, and the acceleration was when it reached less than 10. However, this inflection point was shown only in the girls and was not seen in the boys. And this is a study where we showed that if you can see this, at 20 it starts rising slowly, and then at 10, less than 10, there's a steep rise which you can see. And this is the second study about obesity which I was showing you. If you see this curvilinear curve here, at 10, there is a sudden acceleration of PTH, whereas it starts plateauing below that, and at 20 it plateaus. This is in girls. But in boys, there is no inflection point seen. Why is it so? One doesn't understand, but they did not show any inflection point. So what about inflection points in early infancy? There are limited studies that have identified this inflection point at even lower serum levels of 25-hydroxy, that is less than 10 nanograms. Yadav et al. Recently have shown even lower than 6.83 nanogram was the cutoff which he showed in infants where there was a certain rise in the PTH level, as against the earlier literature which had taken 8.64 as the cutoff. So different age groups, we see different inflection points as far as PTH is concerned. And this is the last study which I was mentioning about infancy. Look at 6 points or 8, almost about 7 nanograms, there is sudden acceleration, and then you start seeing the plateau here. So now coming to calcium, what is that optimal serum 25 based on calcium absorption and serum levels of 125-hydroxy? Well, 25-hydroxy, as you all know, is a precursor for 125-hydroxy for calcium absorption, because it is 125-hydroxy which absorbs calcium. And the renal production of 125 is perfectly normal when the substrate concentration of 25-hydroxy-D exceeds 15 nanogram in the absence of any chronic kidney disease. That means in normal person, if you have serum 25-hydroxy more than 15 nanograms, there is adequate production of 125. Several other studies have also shown that increasing serum levels beyond 15 nanograms by supplementation did not further increase the active vitamin D, that is 125. Heaney et al. Reported no change in 125 in subject with the mean values of actually more than 30. So most studies have shown that if you have more than 15 nanograms, adequate 125 is being formed for adequate calcium absorption. Most pharmacokinetic studies concluded that serum levels of 32 nanograms were needed to optimize calcium absorption. However, these studies actually had a lot of limitations because these calcium absorption studies were not done by isotopic studies. But the clinical vitamin D deficiency for the risk of rickets and osteomalacia occurs at low concentration of 25-hydroxy below 40 nanomoles or below 16 nanograms. This was shown by an Australian study in about 319 patients by Need et al. Calcium absorption, if you take by isotope techniques along with 125-hydroxy and turnover markers when evaluated showed that 125-hydroxy and calcium absorption became low when the serum 25-hydroxy concentration went below 20 nanomoles or below 8 nanograms. So if your serum vitamin D or 25-hydroxy is below 8, that's the time when 125 also gets affected, lower synthesis of that and lower calcium absorption. So giving the overall weightage to the whole study, I think all the studies combined, what they have said is that the calcium absorption is good enough. If you take the meta-analysis, calcium studies are good enough between 8 and 15 nanograms or between 12 and 20 nanograms, some of the studies. So as far as calcium absorption is concerned, after 8 to 10 nanograms 25-hydroxy, it achieves maximum calcium absorption. What about the histomorphometric studies? Can we have some idea of what is normal 25 through histomorphic studies? Well, through increased, you know that there is an increased osteoid surface and osteoid thickness. These are the hallmarks of rickets and osteomalacia. But this is not a proof of vitamin D deficiency because calcium and phosphate deficiency or even increased bone turnover can bring about these histological abnormalities. But there was a very interesting study which was done in German group that the increased osteosulfide, is generally a finding in the bone biopsies with hyperparathyroidism, that is secondary hyperparathyroidism. So the recent study in these Germans who had died when they were brought to the hospital, their blood serum 25-hydroxy was evaluated and histomorphometric was done. And so what they showed is that all those who died who had more than 30 nanograms per ml of 25-hydroxy, there was no evidence of increased osteoid surface or osteoid volume or thickening. So they had no evidence of either osteomalacia in those. But those who were between 20 nanograms and 30 nanograms, 20% of those cases did show some changes of osteomalacia, meaning thereby that can we, on the basis of this, define that if you have 30 nanograms or more as the cutoff, that your bone histomorphometry will be normal. So that is one way of also estimating. Coming to bone mineral densities, enhanced data analysis and longitudinal aging study has very clearly showed that BMD did decrease when the serum 25-hydroxy fell below 20 nanograms. But BMD does not improve with vitamin D supplementation once the baseline levels of 25 are more than 20. So through scientific evidence supports combined use of vitamin D and calcium supplementation in prevention of fractures, but unfortunately, no definite conclusion of vitamin D levels are there for fracture prevention. So I therefore conclude that based on the RCT studies available in literature, taking into account calcium absorption, serum PTH levels, serum 125-hydroxy, histomorphometric study, fracture prevention, no definite consensus till date has been reached on the optimal levels of serum 25-hydroxy level for skeletal and extraskeletal health. This is probably due to the fact that relevant relationships have not been studied in totality and the ideal indicators for vitamin D assessment are still lacking. So these differences in the threshold for various surrogate points vary due to variation in the age, sex, race, body composition, pubertal status, calcium, phosphate intake, baseline vitamin D levels are all there. However, based on available RCTs, most research societies consider serum 25-hydroxy of 20 nanogram per ml as a safe cutoff point for defining vitamin D insufficiency for sound bone health. Thank you very much.
Now the paper, article, sorry. Now the lecture is open for question and answer session.
My question is to Dr. Mittal. Naturally, GLP-1 is the hot cake. But are we convinced GLP-1 protects bone? The data from preclinical trial does suggest a possible benefit. The study you quoted, some small scale secondary analysis from liraglutide trial, no dedicated trial with GLP-1 with regard to the bone outcomes. The meta-analysis you quoted is an exploratory incidental analysis pulled together, meta-analyzed. Grade of evidence would be D perhaps. To my knowledge, there are only one studies done with GLP-1, which is a double-blind randomized controlled trial against placebo in people with high fracture risk, with semaglutide 1 milligram once weekly, sponsored by Novo Nordisk, published in Lancet eClinical Medicine last year, without any benefit. Another trial is currently ongoing, recruiting, which is directly comparing tirzepatide to liraglutide called Tilly bone trial, which is going on from the Athens. So we don't have any evidence at the moment.
So I think the major thing we have to understand is when we look at fracture risk, we are looking at a constellation of reasons why people get fracture. And one very important reason in that is that if people lose some muscle mass for whatever reason, the risk of falling might increase and their fracture risk will increase. As far as the bone quality per se and the effect of GLP-1 on bone quality, at the moment it is safe to say that there is no evidence that they are directly damaging to the bone. That is all that can be concluded on the basis of studies, because dedicated studies are very few, one or two hardly, and that too, but there are many in the pipeline. The problem is in sifting out bone quality effects from fracture effects, because the fractures might be increasing in some studies which may be unrelated to bone quality. Having said that, I think it's fairly safe for us to say that GLP-1 drugs at the moment, the ones that are in use, do not have any adverse impact on muscle or bone by their direct actions. That is the best we can say.
But theoretically, sir, there is a concern. For example, once we are using GLP-1, we do lose lean muscle mass. If we lose lean muscle mass, not because of the reduction in lean muscle mass and because of the fall, if you lose lean muscle mass, the bone architecture will be lessened. And therefore, we are not concentrating on a mono GLP-1 agonist, double, triple, quadruple, adding for say, a myelin agonist or a calcitonin agonist to protect bone from the lean muscle mass loss induced bone loss. So GLP-1 is a double-edged sword.
Yeah, you are absolutely right. But the thing is that similar to the fact that there is no conclusive evidence that these drugs are beneficial for bone, there isn't any conclusive evidence that these drugs are harmful for the bone and muscle. So the important point here is you have to compare with the group. So when you compare with bariatric surgery group, or there are no comparisons that I have seen with just low calorie diets, but I have seen comparisons with bariatric surgery. And certainly patients who are on GLP-1s do not do worse than those on bariatric surgery with regard to bone health. So the important clinical message for us at the moment is that when you're using these drugs, you need efforts to preserve bone and muscle, but that is not specific for the drug. That is simply because you're going to lose significant muscle. You're going to possibly, have greater risk of falls, or as you say, between the muscle-bone connection, obviously. So that's all. So the message here is, it's been well known that when you have rapid weight loss, speed of weight loss also matters in this. Rapid weight loss and substantial weight loss, there will be some impact on muscle and bone. However, the important point is that GLP-1 drugs, at least based on the data available so far, till we have more dedicated studies, do not seem to specifically harm the muscle and bone.
Agreed.
That's all that we can conclude. I don't think we can say that they are, I just showed the clinical data and whatever meta-analysis is available of 44,000, whatever, just to emphasize the fact that there is a growing concern amongst colleagues and patients that these drugs are going to cause osteoporosis, they're going to cause damage my muscle. So at the moment, there is no evidence to say that.
There are some reports also that GLP-1, that by decreasing, by improving MSLD or NFLD, it increases the CYP2R1. That is the 25 hydroxylase that increase the vitamin D level. That may have indirect effect on this diabetic osteopathy.
So those are indirect evidence that has to be translated into.
There is no RCT.
I have a question for Dr. Mittal. Number one is that regarding diabetes-induced osteoporosis, in terms of its diagnosis, osteoporosis diagnosis, or the bone health diagnosis, because BMD, DEXA kind of data are the limitations of diagnosis. Here the problem is the quality because of all these hyperglycemia and secondary metabolite causing alteration in the bone quality. Now, there is no good quality marker. What is the status of age and its connection to diabetes-induced bone loss?
So age has obviously a very important role. I mean, age will be part of any algorithm that you use to predict risk of fracture. So are you talking of age as in age?
AG, AG,
Advanced
AG, AG.
Yeah, sorry, I thought.
The advanced glycation end products, sorry. Yeah,
Yes, of
advanced.
course. Because certainly they can impact bone quality, and the reason why people with diabetes seem to fracture at relatively preserved bone densities is because of the change in bone quality. So DEXA, as we are realizing, not just in the case of diabetes, but in so many other places, is sometimes a very poor reflection of the actual, the actual bone health. But at the moment, for clinical purposes, the simplest way is to change the threshold a little bit. But undoubtedly, when we have better clinical markers of bone quality, they will help us a lot in choosing whom to treat and whom not to treat.
And what about calcitonin status in GLP-1 patients? Because there are reports that calcitonin is induced by GLP-1 agonist.
Well, statistically significant rises are not common unless you have an underlying condition. But yes, the tendency is to increase the calcitonin. I don't think that is playing a role, at least as of now here. As I said, the field of GLP-1 and bone and muscle is confusing because ultimately we want to look at the fracture risk. Nothing else really matters. Okay. Now, when you look at fracture risk, you have to compare with someone who's lost an equivalent amount of weight by other measures. Because when you lose weight rapidly, you are increasing your fracture risk in some way. So that's the question too. So it is a bit of a nuance here. When someone asks you, what are these drugs doing for muscle and bone? Are they going to increase my fracture risk? Well, you have to exercise regularly. You have to take adequate protein. Make sure you are following the guidelines. Then you will not increase your fracture risk, or probably not increase your fracture risk. But you have to reassure people also that at the moment there is no evidence that these drugs are directly harming your muscle and bone.
My question is to Dr. Mittal. So you said that we should be screening all patients above 60, diabetic patients. So we will land up with a huge number if the cutoff is -2. And if we do, and again you said denosumab is better in diabetics maybe, or it prevents development of diabetes. So it has to be better in diabetics also. So if you start it, how long do you suppose to continue it?
So I think that's a great question. The recommendation actually is 50 years and -2. What I am following right now, this is again just being practical, is 60 years and 2.5. And at 60 years, you're completely justified, diabetes or no diabetes, in screening people over 60. And you're completely justified, you have to calculate their facts, etc. But in screening most people above 60 who come with a T-score of below -2.5. In that, we are consistently finding half of our people with diabetes above the age of 60 are actually falling in the below -2.5 zone. I am not using denosumab as first choice for them. That is just an interesting bit of information that I shared. But yes, you will need to treat them like you treat other people with osteoporosis who are over 60 and who are, who have a low bone density.
And we continue it lifelong, that means?
Well, osteoporosis treatment
Yes.
is like any other chronic disease, often lifelong. You may have to juggle medications, you may have to give a break in between, but ultimately it is because with age, and this, now I'm talking of age as in age, umr, ayu, as with age, there is an increasing risk. The risk of fractures will only increase as time passes. So therefore, if you're treating someone at 50, let's say 60, with medication to treat osteoporosis, it's very likely the person will need more intensive treatment when they're 75.
Yeah, sure.
So I think it is going to be very long term.
And one small question. In type 1 diabetes, when would you start screening for osteoporosis?
I think
at the age, the same age, or earlier, because their bones are more fragile?
Yeah, I mean, I don't think there are any guidelines to that. There's not enough numbers that have been looked at, but obviously you have to be alert to the fact that they are. So if you have now that type 1, people with type 1 diabetes are living much longer than they used to, I suppose it's absolutely fair to at least screen them at 50 if you have a 50-year-old type 1 diabetic.
Just to continue that further, the other blockbuster molecule are SGLT2 inhibitors. And there was some data with canagliflozin where it increased the risk of fractures, maybe due to postural hypotension. So is the jury still out on SGLT2 inhibitors and the risk of fractures?
I think all recent studies have not shown any increase in risk of fracture with SGLT2. But however, I'll say the same thing again, that if one is with them also, not to the same extent as GLP-1, you will lose some muscle, etc. So therefore, one has to be careful, especially in the elderly. But so supposing you're starting a 75, 80-year-old man on SGLT2 for the first time, maybe mild amount of dehydration, some little postural hypotension, passing urine at night, maybe the risk of falling. So you have to be cautious. But I don't think we can say that they are dangerous for the bone, SGLT2 inhibitors.
I think last question from Dr. Sanjan.
Yeah. So question to Marwa, sir. Sir, actually we are seeing a lot of patients. I think it will be all will agree. Patients with a vitamin D level of between 15 to 20 or 25, and having a very variable PTH level. So they come with a PTH level of 130, comes with a PTH level of 70, maybe 110 or maybe 150. So we are at a very difficult state. So shall we, the calcium levels, all things are normal. So shall we are dealing with a normocalcemic hyperpara or a secondary hyperpara due to vitamin D deficiency? So how to deal with such cases?
First of all, normal calcium levels give you no indication. Even if you take low calcium intake, it will come out of your bone and maintain your serum calcium. So serum calcium levels have no meaning.
Yes.
Every individual has a different cutoff of 25-hydroxy. What we talk is of generalization in epidemiological studies. Your cutoff 15 may have normal PTH, mine may not have. Mine may have 70 or 60. So for me, it will be secondary. So that's why you have these variations in the various studies that coming off. So PTH is far more important to consider for vitamin D deficiency than the 25-hydroxy D levels. As long as your PTH levels are within the lower one-third range of the kit, that is between 10 and 30, I think you should play safe even if your vitamin D levels are 10, 11, 12, whatever it may be. Have I answered that question?
Yes, yes.
It is sometimes, as you would agree, very difficult to distinguish what is normocalcemic hyperparathyroidism from persistent secondary hyperparathyroidism we're talking about. You'll have to just follow them up. There is no sort of definitive test at that point. And before I end, I think all of you are invited to the ISBMR meeting in Mysore in October. In addition to other things, I'll be taking a full discussion on just GLP-1 and bone. So everyone is welcome to discuss in detail.
One question to you. What is the duration of time that the bone quality showed improvement in PGI study with GLP-1? Because, see, that is more important because if the bone density remains the same, so what is that duration of the drug dosage that would cause?
So in general, one of the large analysis suggested 1.5 years. I don't remember in PGI study how much exactly was the follow-up.
Yeah, because bone density doesn't show improvement immediately. So maybe the quality.
So this is going to be only, I think the changes you will find will be only based on volumetric BMD if you're looking at humans. I don't think DEXA scan will really lead us anywhere.
Okay. I think we can conclude because we are already running late. And thank you everyone for your patient listening and being here. Thank you.
So coming to the last session of the day, clinicians' perspectives. And to chair this session, I would like to call upon stage Dr. Rajiv Kasliwal, sir, and Dr. Avdesh Kumar Singh, sir.
So I know we are at the fag end of the day, and you can assume the voice of the speaker getting slowed down as we started day from very beginning. Nonetheless, it's my proud privilege to invite Professor Nikhil Tandon. He doesn't need any introduction. Can I have his slides, please? But just for the sake of, saying, he is the professor and the head of the Department of Endocrinology, All India Institute of Medical Science, New Delhi. And one more announcement that because he has got a flight early, so we will take Q&A immediately after his presentation and then followed by the next two presentations. So Dr. Tandon, the floor is yours.
Thank you, Avdesh, and thank you to the organizers for having me across in this meeting. I'm a big note taker, and I've taken lots of notes in the last 2 days, so I'm feeling enriched by my presence. So this is going to be a practical, sort of clinician's pragmatic approach. I'll not do science. I will do practical politics in the management, which I think is what we face on a day-to-day basis. This is interesting. My font was different when I submitted it, so clearly things happened at the time of going from one system to the other, but that's all right. Okay, let me just get back to this 1 second. So I will talk to you primarily on this basis. After a brief introduction, talk to you about the causes, single case vignette, a little bit about the physiology of levothyroxine absorption, which is relevant because it relates to some of the reasons of refractory hypothyroidism, not necessarily failure of compliance, approach to a suspected case of thyroxine non-compliance, and possible solutions. And then I'll wind up at that point in time. So really, this is the commonest cause for people having, non-normal TSH levels despite being on reasonable doses of thyroxine, because they just have different issues about intake of thyroxine rather than anything more complicated. And if the TSH is elevated and the T4 is slightly on the higher side, it usually means that the person has been non-compliant and suddenly remembered and started taking a lot of medication to try and make up for it rather than anything more sinister. The emphasis always needs to be on the compliance with therapy, and I think that's the message we have to communicate to the people at the time of initiation of therapy. It is difficult. Remember, if a 20-year-old comes and you're telling them for the next 60 years, every single day of your life, you have to take a medicine in the morning, fasting with a gap between the time you take the medicine and the meal. It isn't an easy job to do, and therefore it needs some degree of reinforcement and motivation. Right? So there are three terms which I use, which I think we need to be a little clear about. Compliance is a passive term, right? It's the participation of the treated person. Adherence it also reflects the conformity of the prescribed thyroxine, conformity of the patient to the thyroxine regimen, and persistence is the issue which really actually creates a problem, which is the fact that you have to take it in a sustained fashion over an extensive period of time. As I said, the usual reasons for non-compliance are a daily intake, the fasting schedule, the need to wait so that the stomach is empty, and lastly, as one grows older, some of us in the audience like me are, multiple comorbidities, you end up taking multiple medication. The younger person who does that is a pregnant woman because they're always given calcium, they're always given iron. And so those add to the issues related to absorption of thyroxine, which we must flag and address. So this is a case vignette of a 24-year-old female, primary hypothyroid, 5 years, on treatment with 150 mics of thyroxine, which is actually enough for somebody who's totally thyroidectomized, right? She wasn't thyroidectomized. Her weight was 54 kgs, so we're in the vicinity of 3 mics per kg, which is a very large amount. TSH was in the 60s. T4 was low normal, and swore with a hand on her heart that she is compliant. So I will take you through how we normally approach individuals like this with a little bit of a theoretical background. So as I said, the concept of refractory hypothyroidism is a biochemical evidence of hypothyroidism, and the TSH levels persist high even after 6 weeks of an increase in dose, and or there's a presence of clinical evidence of hypothyroidism and unresolved hypothyroid systems, despite reaching a dose of 1.9 or 2 mics per kg, right? So that's a pretty big dose for a 60-year-old. It means about 125 microgram. If you go beyond that, you need to start thinking as to what happens. Strangely, it is not uncommon. 15, 20, 25% of people actually go through these periods when we would define them as refractory. Now, as we all know, levothyroxine is, after ingestion, undergoes a phase of dissolution, which is important because you need a suitable physiological gastric pH. Since we love proton pump inhibitors in this country, and if it was left to people's choices, they would put them in their tap water. Everybody's taking gas ki dawai, so it's a problem. Your gastric acid is never optimal in this country. Most of us are sitting around at acids which are at gastric pHs which are not right. After the dissolution, the T4 is absorbed in the jejunum and the upper ileum. So any problem in the stomach, any problem in the jejunum, any problem in the upper ileum will actually interfere with the absorption of thyroxine. And this is something which we really need to remember. There's also a fairly significant inter-individual variability in the efficiency of GI absorption, which could be also contributing to the fairly wide range of levothyroxine doses which we end up prescribing at similar stages of hypothyroidism. The main processes, I said, affecting the absorption is gastric juice, pH, the viscosity, the type of excipients and structure, which are fairly common in our country with the different preparations, and of course, storage. Now, it isn't a difficult drug to store. It's supposed to be stored at room temperature, but in our country, in some of the room temperature can be really, really high. And the second thing is it has to be away from light and moisture. So as long as you take care of these things, you should be fine in terms of quality of the product. As I mentioned, amongst the list of causes of refractory hypothyroidism, the most important will remain poor adherence or non-compliance. The other problem which has started emerging, I don't want to I don't want to be inflammatory on this, but a lot of non-branded thyroxine preparations are now available with inconsistent bioavailability. And therefore, whenever you, either by design or by default, change from one brand to another, you can actually end up in getting difficulty. So you must remember that sticking to the same brand is a very important part of treatment. I mentioned maldigestion because of PPIs. I mentioned malabsorption because of H. pylori and other factors which are present in the intestinal lumen. Sometimes, of course, there is a genuine need for increase in levothyroxine because there's a change in body weight, or you've been started on medication which will change the metabolism of thyroxine, or in pregnancy, in which as part and parcel from the 7th week onwards for the next 10 weeks or so, there is about a 10% or 8% increase in the requirement week on week. So you often end up with a 50% increase in dose of thyroxine requirement by the time you're in the mid-second trimester. Different levothyroxine preparations, not surprisingly, actually are a very important cause. In a survey of about 18,000 prescribers, there were 200 adverse events, but the important thing is not that. The important thing is that 90% of them actually said we had changed brand, and a large proportion of them actually, the pharmacy changed the brand without instructions to do so. So please always, and I always ask the patient to bring their bottle of thyroxine, because a lot of my patients are not literate in English, so I will actually verify what product they're taking so that I'm 100% sure that they are consistently taking whatever we prescribe. If they're well controlled on a particular brand, I'm very happy for them to continue with that brand. I have no fixation about a particular brand. I have a fixation about continuity of the brand. In terms of diet and drug, this is again actually a study in which about 900 people were evaluated. Issues remained about shortage of time between thyroxine ingestion and the intake of the meal, and also sometimes this, oh, I forgot, and taking the thyroxine after the meals. The other two things I specifically mentioned were calcium and iron supplements, which are mandatory during pregnancy, and I make it a point to actually tell patients that you're taking the thyroxine in the morning, you take the calcium midday or later, and you take your iron in the evening, or whichever order, but clearly specify that there has to be at least a 4-hour gap between ingestion of thyroxine and these other supplements. Otherwise, you will have interference with the absorption and create issues because of that. I've already referred to our antacids, but it's not just PPI. It could be antacids, it could be sucralfates, it could be actual increase in thyroxine binding proteins, which can happen if somebody goes on an oral contraceptive pill. It could be on medication which metabolizes thyroxine. So a lot of anti-epileptics, some of the antipsychotics, and in current era, 2 sets of agents, tyrosine kinase inhibitors and antiretroviral drugs are common agents which are used by oncology and actually end up impacting thyroxine metabolism and the need for higher amount of thyroxine intake. I've referred to the GI causes, and I'm not going to go into detail about that, just for me to clarify that issues like celiac disease, like lactase intolerance, like small intestinal bacterial overgrowth may be responsible for thyroxine malabsorption without being clinically overt. So it's not good enough to ask for, are you having these problems? You may have to end up investigating them with breath tests if you are convinced that compliance is good. So clinically non-overt gastrointestinal disease can be responsible for thyroxine malabsorption. So how do you approach a patient? You confirm the diagnosis. I said markedly elevated TSH levels. You obviously, in rare circumstances, you might see if the assays have changed, and you need to know your platform which is being used. You need to know what are the usual interfering substances in that TSH. So again, since we perform most of our thyroid function tests in-house, we have a reasonable sense of what the assay does. And if we have confusion, we shift to another platform for cross-verification. But otherwise, this sometimes can become or contribute to as a conundrum. I referred, now what do I do for the compliance part? Because that is usually the most important thing. Check the medication bottle, see that it's the right one, check for the record and compare it. So, when did you buy this bottle? When did you start it? Now, if they're saying I started this bottle 4 months ago and it has 100 tablets and they were supposed to take 1 tablet a day, clearly they're not eating enough, right? So these are small things. You don't have to be judgmental. You have to ask them in a non-judgmental, non-adversarial fashion, but it's important to find this out. You must ask about the timing. You must ask about the gap with the food. And you must ask about a medication. So I have a standard sort of little script, which, nowadays people consult you on WhatsApp more than they do it otherwise. So if they say, this is my this is my TSH report, what do I do with my dose? I say, if you can say that you're taking the medicine on a regular basis, that the gap is at least 45 minutes, that you're not on calcium, iron, or PPI, increase the dose in that circumstance. So I give them these 5 preconditions before. If they come across, of course, I will do more to check about the intake frequency and reliability. This I've mentioned, and therefore all the agents which interfere need to be taken into account for this conversation, and only then will you do more complex evaluation for GI malabsorption, which comes much, much later. Because as I said, the proportion who are having uncontrolled disease because of poor compliance or adherence are much more likely than people having a problem with GI malabsorption. There is, however, a test we do, not frequently, for ensuring that the thyroxine is being absorbed. It's like a direct observation. So you actually will take a baseline value of free T4 and TSH, primarily free T4, give them, and this depends on which algorithm you follow, either 10 mics per kg, which is approximately 600 micrograms of levothyroxine, or in some authors have prescribed as much as 1,000 micrograms, so it is, but usually we get with 600 mics of thyroxine. We measure free thyroxine levels before and then every hour for 4 hours, right? And essentially what you're trying to see is if you're putting the tablet in, is it entering into the blood? If it's entering into the blood, then there cannot be an absorptive issue. And that's a reasonable way. It's a crude way, but it's a reasonable way of checking. And there are different ways of looking at that. One of the things which we use commonly is if the rise in free T4 at any point in time during the 3 to 4 hours of follow-up is less than 0.4 nanograms per deciliter, you put the tablet, which that person was eating at home, then clearly there are issues related to malabsorption. And that's when you will need to look at the malabsorptive sort of sequence of investigations. There are different tests. I said one is a delta free T4, one is a delta total T4, and then there is a free T4 increase rate in which you have peak free T4 minus baseline free T4 divided by baseline free T4. And then the last one is a complicated formula, and I won't even go into it because we do not use that on our basis. This is from a paper, but I'll come back and show you the data from the particular patient. So there are people who've actually done a 2-hour rapid absorption test also, in which the same principle of a free T4 minus so baseline and peak, or total T4 difference between baseline and peak are seen, and people say that in 80% of patients, even a 2-hour test is sufficient. If you do find out and you do convince the person that they have not been taking their medications, this is what I do. If you confront them with the evidence, I mean, they have no choice but to accept. Till you do this test, you are still suggesting it to them, but you can't be emphatic. Once you've done the test, you have to show them that when we put the tablet inside the mouth, it goes into the bloodstream. So clearly, you're not putting it into your mouth because you use the tablets which you use at home. Now, my simplest solution is I tell them to keep a week's supply in a separate bottle. So let's say they're taking 100 micrograms a day. I just say, take an empty bottle, put 7 tablets aside on the Sunday. The first tablet will go in on the Monday, the second on a Tuesday, the third on a Wednesday, and so on. By the time you come to Sunday, there should be 1 tablet left. If perchance 2 tablets are left, it means you've missed it at some point of the week. Take both, you're done, you've taken 7 tablets for the week. And it happens. And they often come back and say it looks, because it's very difficult to make out from a full bottle as to whether you missed something or not. Whereas if you put 7 tablets aside, or whatever number is needed in the week, you can actually make it out without any difficulty. Of course, there are people who recommended doing a weekly dosing under observation. The only concern sometimes with once weekly dosing is that you may get a high level of free T4 in the initial period. Though overall, over a period of time, the TSH actually seems to settle. I'm not a big fan of a under observation weekly dosing. I prefer setting aside my tablets for that particular purpose. Right. So in our particular case, it was the woman who had 3 mics per kg, claiming compliance. She looked like she'd actually read the prescription properly. Gap of 1 to 2 hours with breakfast, using the same brand of tablet for the last 2 years, not on any interfering medication. So she checked all the boxes. She wasn't doing anything wrong. We did the levothyroxine absorption test, and actually this is clearer than what it was. You can see at baseline her FT4 was 0.8. We gave 550 mics of her tablet, right? Because if you take your tablets from somewhere else, she'll say that my tablet is off. You ask the patient to bring their own bottle. You take the tablets from there and you feed her with that. And as you can see, within an hour, it jumped to 1.8 and it peaked out. So it's clearly much higher than a difference of 0.4 nanograms per deciliter. And when we confronted her with the results, she then accepted poor adherence, right? So sometimes having the data to support your case is of use. So let me just sort of end this by saying compliance is actually a fairly common issue. We sometimes end up increasing the dose inadvertently. Patient at another point in time suddenly becomes compliant, and from somebody who's hovering at 20 suddenly becomes at a suppressed TSH. So don't be in an urgency to increase the dose without verifying for a fact that you're not dealing with compliance issues. You must educate your patient about the timing of the ingestion of levothyroxine. Always tell them that in case a new medicine has been started, keep us informed. The test for levothyroxine absorption actually is very, very useful because it helps us confirm or refute the compliance issues. And if there is a concern about malabsorption, it then directs you to doing tests for malabsorption at that point in time. Levothyroxine malabsorption can sometimes be the only manifestation in GI disease. So as I said, you need not have significant GI symptoms. It can still be there. So looking at tests like the breath test and the urease test would still be required, but obviously that is being done by other people. I must also confess that even after extensive workup, the cause may not be identifiable in about 10% of cases, and then we have to look at this at another day. So if you miss a pill and you remember missing a pill, take 2 the next day, or as I normally tell people, ensure a weekly delivery of the dose by setting aside the week's supply and ensure that you have all of them in place. Before I end, I think I need to acknowledge 2 people. One is sitting in the audience, who was in the department as a senior resident, and one who is sitting in Delhi, who is currently a senior resident, who helped me with the slides. But thank you so much, and as Avdesh mentioned, I will crave your indulgence in the event that I need to answer any questions. I would request you to ask them now, because I need to jump off soon.
Thank you very much, sir. Big round of applause. Please come. So, it's open for discussion. Any questions, query, please come to the mic, please.
Sir.
There is one question.
Sir.
Please, after
Sir.
that. Yeah.
Hello, sir. So, suppose the patient is not accepting to do the levothyroxine absorption test. And, if the requirement is high, can we do one more thing like dividing doses? Sir, I've in my small practice, I saw that if I divide the dose, the requirement comes down. Maybe because of saturation.
Divided multiple times in a day?
Two times a day, morning and 3 hours after dinner.
So I've never done that. You've done it and you found it successful, so there's nothing I can I can't respond to that. My instinct says if somebody is missing it, even when they're expecting to take it once a day, they're sort of equally, if not more likely, to end up missing even otherwise. But, as I said, you've done it, you found it works for your patients. There's nothing I can say about that.
Okay, sir.
Yes, please.
So it has been said that the PPI intake interfere with the absorption, but very commonly we see the patient used to take gas ka dawai and as well as levothyroxine, but somehow maintains their euthyroidism. So how much it affects?
No, that's a very fair point, right? But we also end up telling them, take your thyroxine first, take the antacids or whatever later on. The question only arises if you find a funny TSH on a dose which was previously causing a normal TSH, right? In those circumstances, see, a lot of PPI use is actually instinctive, patient-driven, and not prescribed by a physician. So if there is no genuine reason for continue, it's well worth trying to discontinue. If it is required, it's required, then you'll have to up-titrate medication. I mean, obviously, if the person has a disease which requires a PPI, you can't tell them to stop it, but you need to know what they are on even before you can take a decision.
Or in other words, Animesh, this would be likely that if the patient is taking co-prescription of PPI with, say, levothyroxine, currently dose requirement is, say, 100 microgram. Had the patient stopped taking PPI, the dose requirement would have come down to 75 or 50. That's why we are not able to distinguish whether presence of PPI is changing the bioavailability of the thyroxine. So we can't say that you continue with the PPI with the levothyroxine because your thyroid function is normal. You could have reduced the dose, given that if you have stopped the PPI, not concomitantly with the levothyroxine, you can take PPI 1 hour after the levothyroxine.
That is, as sir is saying, usually I tell that also, but sometimes
we got your point.
Most of the people do not stop. Even we stop advising stopping.
This is exactly what I was saying, that if you inform your patient that had you not taken the PPI, your dose requirement would have been even lower. Yes, please.
So I want to ask about a lot of patients now they have on semaglutide plus thyroxine. How do we manage those doses? How do we take it? Which you take first, sir? Which you take first or which you thyroxine take first?
The kings of semaglutide answer. But there's a prescription now. There's a clear recommendation for that.
Of course. So when we are talking about semaglutide, we are talking about oral semaglutide.
Exactly.
Nothing to do with the injectable semaglutide.
Exactly, sir. Exactly.
So the rule of game is that once you have taken oral semaglutide, that should be the first thing should be taken in empty stomach.
Sir.
So if you are a patient receiving levothyroxine and you are diabetic, you are supposed to take oral semaglutide. First you take oral semaglutide, wait for 30 minutes. Now you take levothyroxine, wait for 45 minutes and then you go ahead.
Done, sir.
Other way, alternatively, you can take it after 3 hours after the dinner. So there is a both way to go at the levothyroxine. Of course.
Sir. But the recommendation is, as Dr. Amresh
Yeah.
said, first semaglutide, wait, then thyroxine, wait, then the meal.
I said alternatively, if your patient cannot wait for 30 minutes of oral sema, then 45 minutes of levothyroxine, then another option alternative is to take, at the night time, preferably 3 hours after your dinner.
Thank you so much, sir. Is there any role of tannin or caffeine in the absorption of the levothyroxine?
They can interfere. Both of them can
So
interfere. So,
is-
if somebody is taking their thyroxine with coffee or tea, it
Yeah.
may actually create
So
a
what
problem.
should be the gap ideally?
So actually, I keep life very simple. If you start telling patients too many things, just say nothing else goes into your mouth for the next 30 to 45 minutes. Then they cannot ask you, can I drink tea, can I drink coffee, can I drink water? Just say nothing else goes into your mouth for
Okay.
30 to 45.
And sir, the medication which you have mentioned, which cause interference in the absorption of the levothyroxine, so other than any other drug, suppose the patient is also suffering from the diabetes as well as the hypothyroidism, and patient is taking the drug for the hypothyroidism in the morning as well as for the diabetes. So is there any interference between any other OHA or and the...
So that's not been reported. That's not been reported in that list, because they will either interfere by binding or by interfere by causing a change in metabolism. So neither of those two actually come into play.
Okay, thank you, sir.
Sir, one more question, sir. Sir, this is different. Sometimes patient is compliant and he has gone to higher dose, say 400 microgram or 600 microgram. Sir, then we think the possibility of malabsorption. Then we are doing the test like TTG. Do you think some rationale is there? What I'm talking?
This is what Dr. Tandon showed you. When you suspect that there is a malabsorption problem, so you go for a levothyroxine absorption test. You give the 6 tablets of 600 microgram, or other people says 1000 microgram. Different procedure had been discussed. Once you ruled out that
Then
this is
only.
it, then only.
Because
Otherwise not.
Compliance is much more likely to be a problem. Rule it out, because that's directly under your control as a physician. The moment you then go into a malabsorptive, inevitably you will have to go for another specialist consultation. So finish what you have to do under your control.
Sir, one more thing I want to add, sir. Like as you told you, oral semaglutide, you take in half an hour. After that, you have to take some water, and then you have to take levothyroxine.
Water is all right.
Water, and then you have to take sir, the levothyroxine, and then you have to wait.
Of course,
for
you will
30
take oral
for 30
semaglutide with the 120 ml of water. That I assume that you know about
but
that.
sometimes, sir, you cannot take direct. Sir, I
Right,
don't.
I forgot your point. And the last question, please.
Yeah, if the simultaneously if the patient is taking oral bisphosphonate, then what should be the sequence?
Oral?
Bisphosphonate.
Oral bisphosphonate, two things again. Oral, so I don't know, and I don't think there's a recommendation clearly. I don't know.
Now, what
Somebody
should be the
does-
sequence, sir? Ideally.
Just 1 minute. Number one. Number two, also remember that oral bisphosphonate is likely to be once a week, right? As opposed to a daily. And then again, I would retain. So why are we concerned about the oral bisphosphonate and anything by mouth? Because they're very poorly absorbable medication. So if you have any food items, they're much more likely to have a problem. So you can, as far as I can, but I'll wait for other people to respond. I don't think the sequence will matter out here, as long as, just like we did for semaglutide, the gaps are maintained. Because it doesn't really make a difference. Bisphosphonates will not cause change in gastric pH acutely. And thyroxine, if taken first, you can follow it up with bisphosphonate and then wait and then go ahead.
Thank you very much. So big round of applause for Dr. Tandon. Thank you very much, sir. So it's my pleasure to invite my co-chair to introduce next speaker, please.
So good evening, everyone. So we will go to the other end of the spectrum. So till now we were struggling with increased TSS. Now we are going to know about how to deal with persistently low TSS. So our the next speaker is Dr. Subramaniam KV. He's professor and head Department of Endocrinology, Andhra Medical College, Visakhapatnam. Over to you, sir. Thank you.
Very good afternoon, and respected chairpersons and my dear friends. Let me thank the organizers for giving me this opportunity. And the same topic very nicely discussed by Professor Nikhil. And I thought non-compliance means the patient not taking the drug. Here the thing is different entirely. So the drug is not effectively entering to the body is also a non-compliance. But for my talk, I think that would not make much difference. As far as thionamides are concerned, it is very important that they are drugs. Whereas thyroxine is not a drug, it is a supplement, and we are replacing. So a drug which will be there in the body, it has some actions and some repercussions. So as far as side effects are concerned, also what it does in the body. So before going to discuss this particular thionamides, what is actually where we use these thionamides? It is in the Graves' disease, which is an autoimmune disorder, and it is a diffuse toxic goiter producing the increase in the thyroxine production. And of course, this is what we see, the usual follicular cells, and you see in the Graves' disease a lot of lymphocytic infiltrate, and you see all these changes. And when you see the lymphocytic infiltrate, it's mostly the increase in the CD3 plus T cells and also the T helper 17 cells. And there is at the same time the balancing cells, the T helper regulatory cells, lymphocytes are reduced. So this balance is very important, and why it is important, I'm going to discuss in a few slides. And of course, this may lead to increased production of the autoantibodies, including our TSH receptor antibodies. And the site of production of these antibodies is one is from the lymphocytic infiltrate within the thyroid cells, thyroid itself, and also outside from the thyroid gland also. This has been known because you can see that there is a beautiful study which is from autoimmunity, where they showed that this transplantation of this particular thyroid tissue from the Graves patient to when you see those mice in the T cells and B cells deficient, that means combined severe autoimmune deficiency mice, and they observed that though the mice are deficient in these lymphocytes, but still they observed that there is increase in the autoantibodies. That means thyroid has some T lymphocytes which have the capacity to produce autoantibodies. And of course, how do you know that the thyroid antibody is being produced outside the thyroid gland also? Because we know that after surgery, even full thyroidectomy also, still these TRAB antibodies are persisting. So this is what our thyroid stimulating immunoglobulin, it binds to the TSH receptor, and of course we know the downstream actions, and that's how it produces more of thyroxine. Then the treatment is mainly medical, what we practice. Of course, we have the permanent treatments also, both radioablation as well as surgical treatment. And coming to the thionamides, we have methimazole, carbimazole, and propyl thiouracil, and of course they inhibit the thyroid hormone synthesis, and where they interfere with the organification of the iodides as well as the conversion to or coupling of the tyrosines, iodotyrosines also. So PDU is another thionamide which has with the conversion, it also interferes with the conversion of T4 to T3 if it is given a very high doses. After all, the objective of our treatment is achieving a biochemical euthyroidism and elevating the symptoms. But the main action of these thionamides as far as Graves is concerned, they interfere with the autoimmune process which I have mentioned here in the thyroid gland and may achieve some amount of relapse or remission. That is what is important. Apart from reducing the thyroid hormone synthesis. You can see this graph where you can see that after medication the thyroid antibodies have come down drastically, and that could be maintained when you maintain the treatment continuously. So this point has been made, and this is a beautiful study by Maria et al. That when they looked at the children with Graves' disease, they've seen that the amount of CD3 plus T cells and the T regulatory cells, the levels of CD3 plus T cells are much more, and the amount of T regulatory cells are very low. And when they showed the co-culture of these both, they can show that these particular T regulatory cells could not inhibit the production of the or increment in the CD3 plus T cells. That means the capacity of the T regulatory cells have gone down. But after treatment with methimazole, yes, there is a reversal of the changes, and the proliferatory activity of the CD3 plus T cells have gone down, and the T regulatory cells have increased. That means there is a beautiful reversal of the activity which is going on this particular thyroid gland and reversal of the Graves' disease also. And when you look at the another study from the same group, they looked at the T helper 17 cells and T regulatory cells. This is in the adolescents. The previous one is in the children. And there they showed that with, again, both the concentrations of T helper 17 lymphocytes have come down after treatment with methimazole. And they said that probably both the cells are important in the Graves' disease, and methimazole has reduced the percentage of this particular T helper cells, the T17, and increased the amount of regulatory cells. So this says that it's very important not only reducing the thyroid hormone synthesis, it is important that they alter the autoimmunity within the thyroid gland. That's how they induce the remission in the Graves' disease. So this remission part is very important, and that is important as far as knowing the non-compliance. So regarding the non-compliance, you see the prevalence is not exactly not known. That's the point. So I went through so many studies, nobody mentioned about the prevalence, but one study showed that probably it may be between the 20 to 50% of patients struggle with adherence to these drugs. And most of our practice, I think, 10% of the patients will have some type of non-compliance when they are using the drug for more than 1 to 1.5 years. That's what we see. I said, what is exactly non-compliance? So one is the skipping the doses. It is the most common. After 3 tablets we write, or 2 tablets we write in a day. Sometimes they may say 1 tablet in a week or 2 tablets in a week. That is the first thing what they do. And taking the incorrect doses. You might be writing a 30 milligrams in a day. They might be taking only 20 milligrams, or they may be taking only 10 milligrams. Or sometimes they think that, okay, the disease has come down, they may stop the drug, and prematurely they may stop the medication. And sometimes they think, by the advice of the neighbor, think that continuously using the drug may produce some side effects or some damage to the body. That's why they wanted to give a drug holiday, once, for example, once in a month or once in a week. And of course, what will happen if this particular non-compliance or not taking the drug comes into effect? First thing is uncontrolled hyperthyroidism. The patient again may become having palpitations, anxiety, loss of weight, and again all the tremors and heat intolerance may come back. And more important is there is increased risk of thyroid storm, and of course the relapse rates, which are much more important, may come back. That's what is important when the patient is stopping the drug. And also there is a small chance of patients developing multinodularity. That's what the gland, instead of the soft diffuse gland, it may become a multinodular goiter, and you know that multinodular goiter is more resistant to the medical treatment. And thus, this may lead to the reduced quality of life. Again, the patient going into that particular anxious states and all those things, especially females. And of course, the cost of the healthcare goes up when the patient stops. Again, every test the patient may repeat, or patient may go to some other healthcare professional where again they repeat the test, and naturally the cost will go up. So what are the various factors contributing to this particular non-compliance? One is patient related, the other one is medication related, the other one is a provider related. So all these things are related, and of course, first patient related is first thing, lack of understanding of the disease. This is what is important. So once we see this, we have little time to explain to the patient. So naturally the patient thinks that he can use the drug and just the disease may disappear. And second most important, what we think is the patient usually know the symptoms of Graves, where the patient will have anxiety, the patient will have tiredness, and probably they may not understand what he is saying exactly. So they may think that doctor has taken the prescription and we can use it and stop them. And of course then forgetfulness and missing, this is very common. Even in our diabetic medications also, most of the patients forget it. And sometimes it may so happen that after 1 month or 2 months they perceive good improvement and they think that doctor has written for a long period of time, we can stop the drug. And of course, the fear of side effects. See, any drug which is taken into the abdomen and the stomach, they will induce some amount of gastric side effects. And also we know that the rash is the most common side effect, and patient may get worried about it. They look into the Google, and after seeing that they may think that this drug produces this particular complication and may stop it. And apart from it, the financial constraints, you know that the previous thyroxine is very cheap when compared to our thionamides, this methimazole, which is almost costing around approximately 500 to 1,000 rupees in a month. And of course, psychological factors, which I discussed already, and the beliefs and attitudes that the drug should not be taken so that their health will be destroyed, damaged. That is another point which is important. So coming to the medication, yes, This problem with the medication is most of the patients are on 30 to 40 milligrams of carbimazole or 30 milligrams of methimazole on the starting point. So naturally they are on 2 to 3 tablets in a day. Naturally when somebody is taking 2 to 3 tablets, they wanted to, sometimes they may forget the lunch dose because they don't have time. Or duration of the therapy, that's once important because once the patient is on medical treatment, usually the treatment goes for more than 12 months to 18 months and sometimes it may be for 5 or 6 years. And that is the one which may be the reason for non-compliance and the side effect profile. First thing is the rash is the most common. Most of the patients, approximately 20% of the patients will have some rash on the body after taking this. Most of the things is usually controlled by our anti-allergic drugs. But yes, at that moment the patient can look into the Google and may be worried. I have a patient where she refused everything, starting from the anti-thienamides, saying radioablation and surgery she is worried. So it took more than 2 months to persuade her to take thienamides. Because she looked into the matter and everything, somebody says that there is a granulocytosis and she may die of that particular complication, nobody will take it. So then of course, number of tablets I already mentioned about it and the cost of medication already mentioned about it. Then of course, the important thing is from our part, where the time of the consultant is less, we write the drug, may not explain about the disease, may not explain about the number of tablets and the duration. So patient may understand that when they finish the drugs, probably they can stop it. Of course, poor communication is another one. And of course, lack of multidisciplinary process. We mean that the staff outside, whether the nurse or the educator or the receptionist, they should be also educated and should be trying to tell the patient the various nuisances of this particular Graves' disease. I know that most of our staff are equipped with talking about the diabetes and those things, not regarding our thyroid and Graves and all those things. And the other problem what we observe is that, see, most of the people think the thyroid is same. Some of the MBBS also I've seen patients after taking abnormal thyroid report, a TSH less than 0.01, they write thyroxine. So they believe that, okay, there is a thyroid disease and there is a thyroid medication. So they write thyroxine as usual because the treatment comes from so many, starting from MBBS and others. I have seen the MBBS prescriptions doing it. So that is a problem. So patient believes that thyroid is same and doctor has somewhat, because he wrote a costly medications, because the costly doctor, he wrote the costly medication, we can shift over to the cheap medication like thyroxine also. They may think that's another reason. Probably there may be some non-compliance. So what are the strategies to improve this thienamide adherence? When you look at the strategies, most important is the comprehensive patient education at the initial consultation. But let me tell you, I understand most of patients in the first consultation, they do understand less than 10% of what I tell them. That's the problem what I observe. Because they're in a hurry, I am in a hurry, and they're sometimes, initially first time they're somewhat anxious, probably not absorbing what I'm saying into their brain. So that's a problem. So we have to dedicate sufficient time, especially we are talking about a Graves' disease patient where that, you know, how their brain is working. So it is very difficult and that's we have to wait. Then the language is most important. I see patients from Orissa, West Bengal, Tamil Nadu, and it is a very, very difficult thing. Sometimes I myself doubt what I am speaking, whether clearly understandable to the patient or not. So that is important, and we have to ask them to engage in an interactive discussion where they ask questions and all these things we have to engage. And I think we have to dismantle or disengage them from the knowledge acquired from the social media and the Google. That is much more important because once you do it, probably they may listen to what we are saying properly. And whatever we say, probably we have to provide in a very written instructions. This is very important. They may go home, open it and may read. But mind you, most 90% of my patients don't open my file. They will religiously go home, keep it in the bureau, almara, and only follow the instructions told by the medical shop person. And next time when they wanted to purchase also, they have sent the medicines, the strips only, not my prescription. So that's what's surprising to me. But of course, I think these things gradually change when we educate our patients regarding what to be done. And when they have some concerns regarding side effects, it is very much important. But I don't know what you do when I should tell them about granulocytosis and all those things. I'm very much worried that if somewhat I tell them that after using this drug, you will get arthralgias, you will get jaundice, and you will get granulocytosis, sore throat, then I think nobody would prefer to use these drugs. But yes, It is important, and we have to support them and tell them about these complications, and we have to give, because recently we are observing, throughout my DM course, I have seen only one case of granulocytis developing after usage of this carbimazole. At that time, methimazole was not available. But now, in the last 5 years, we have seen about around 4 to 5 cases of granulocytosis, and by God's grace, we could recover them. One case we have lost. So, what is important as far as pill organizers and dosage reminders, I don't believe them, but because a person who can keep all those things can as well remember and take them, right? So, purchasing full prescribed lot, this is another difficult thing what I observe. Because see, most of the patients think that they will purchase a bottle, then they purchase afterwards. Afterwards, a point which is very difficult to understand, they may not continue most of the times. Of course, financial factors always matters with us. We don't have an insurance for most of our patients. Even those patients who have insurance, they don't have coverage for the OPD-based services. That's why I think here is a point, and I think government should help them as far as this is concerned. And follow-up is most important, and follow-up call from the receptionist would make a difference whether they are taking the tablet or not. And of course, regarding the medication adherence, as Professor Nikhil mentioned, we can ask them to bring the bottle and see how many tablets they have used or not. And of course, lab testing goes on, that we all know. And if still, if they are not sure what to do, while the goal is thiamide success, if persistently and repeatedly they are having a documentation of failure to use these thiamides, which have an approximately 1 to 5% of my patients, repeatedly they stop the drug whenever they come to me, stop for about 15 days and come to me. I don't know what, see, I repeat the test also, the test will be wrong because we don't have the proper report. So this is what we observe, and if the patient expresses, say that, sir, I cannot use them because of financial constraints or the education problems, or they are come from a faraway place, then probably we have to tell them that, okay, there are permanent ways of treatment like radio ablation and as well as surgery, and of course explaining the full results of these complications and all those things. And with this, my dear friends, I conclude saying that thiamide compliance in Graves' disease represents a significant clinical challenge with profound implications for patients' comfort. As endocrinologists, our role extends beyond simply prescribing a medication. Patient education, communication with the patient empathetically, active listening, and proactive approach are important in identifying addressing the patient barriers. So these strategies should be implemented comprehensively to empower both the patients as well as the patient attendants, so that proper take is taken care of in taking the drugs. But still the patient cannot follow these doses guidelines and then not compliant, then probably we have to follow the radioactive iodine ablation or surgery are the only mainstay of therapy. And with this, I thank you all for patient hearing.
Last talk of the day. For that, I will invite Dr. Arun Menon. So he is going to speak on about the uses of TSH trap antibodies in daily clinical practice. Dr. Arun Menon is currently working as a consultant endocrinologist in Dubai. He was previously working with Department of Endocrinology, Amrita Institute, Kochi, and he has been organizing secretary for various ITSCon 23, 24, and so on. So now it's over to you, Dr. Menon. Thank you.
Thank you. Thanks for the introduction. Okay, so first of all, thanks to the organizers for giving me this opportunity. I think this is quite a relevant topic in terms of the clinical practice we do in terms of hyperthyroidism, because more and more this is a test that we are using quite a lot. Depending on where you practice, the TRAB antibody or the TSH receptor antibody is something we do more or less compared to where you practice. So we will try and focus on what the benefits of this is, where we are in terms of the understanding of this antibody, and how our practice might change in the years to come. So what I'll try and do is, what is TSH receptor antibody? Why is it an important test in terms of diagnosis? But the unique thing about this antibody is that it is just not for diagnosis, it is also for monitoring and also for prognostication. So we will look at that aspect. We will look at what are the challenges that we are facing in terms of this antibody, the TRAB antibody estimations. And we will look at what the applications are in thyroidology in future as well as beyond thyroidology. So I'll hopefully touch upon all those aspects. So it is very specific and very sensitive in terms of diagnosing autoimmune Graves' disease. We know that, and that is one of the scenarios where we very clearly use it. And what do they do? These are antibodies that specifically target TSH receptors. They lead on to excess production of thyroid hormone. So fairly straightforward. Now, the good thing is that over the last decade or perhaps in the last 2 decades, there has been significant refinement in terms of the lab testing of this one. There is still a long way to go. Even the 3rd generation tests we are using are still not without problems. I will mention that in the following slides. So in a way, TRAB testing serves multiple purposes. So one is in diagnosing it, okay, in confirming Graves' disease, in assessing disease activity, which means if it is a very severe or very high level, it is a very severe GD. So in terms of assessing severity, it is a very useful test. In terms of predicting relapse, this is where a lot of us have been using it in the last 10 years or so. So especially when it comes to the time of stopping treatment, if the antibodies are still very much raised, then most often they will relapse. And then I'll come to those points later. So, and guiding treatment decisions. Should we continue in terms of antithyroid drugs? Should we be looking at other options of treatment, treatment of thyroid eye disease? In many other areas, we have this antibody that is playing a role. And a very important aspect is assessing the fetal risk in pregnancy-associated thyrotoxicosis. So these are the important areas where we will look at TRAB one by one. So if you look at the antibodies, there are actually 2 types of antibodies, the TRAB antibodies. One is the stimulating TRAB antibody, or the one we call as TSI, so thyroid stimulating immunoglobulin. That is actually the more commoner one. There is also an inhibitory type, which is on this end you can see. That's the one that would cause TSH binding and cause hypothyroidism. So it causes autoimmune thyroiditis. That is less common. You present with a goiter, but we do see, isn't it? We all see cases where they present with Graves, or in fact, they would present initially with autoimmune hypothyroidism and then they shift to Graves. It's not very common, but we have all seen cases of that sort. So clearly, that is shifting of antibodies. So that can happen. So the effects in thyroid, because of the stimulating antibodies, cause a goiter and produce thyrotoxicosis. The effect on orbital cells cause thyroid eye disease. The effect on the skin causes thyroid dermopathy or acropathy and all those things. So where is it really useful? Does every patient need? Is one question that always come up. Perhaps everybody doesn't need this, because if you have a patient who has, for diagnosis I'm talking about, okay, for diagnosis, not all patients need it. If they have thyroid eye disease, it is pretty clear that it is Graves' disease and it is not a toxic nodular goiter or thyroiditis. So to make a diagnosis per se, perhaps 100% of patients don't need this test. However, the value comes in other aspects. So one of them is when you have atypical presentations of hyperthyroidism without the classical features. So there, you're not sure whether it's a toxic nodular goiter, whether it's a thyroiditis. That's a very common situation where we face. We are not sure in the beginning whether it's thyroiditis or Graves. And that is one situation where if this is raised, especially significantly raised, we are very, very clear that we are dealing with Graves. And that is important in terms of how long we are going to treat, how we are going to treat. The second is that subset of patients who have euthyroid ophthalmopathy. So they have thyroid eye disease, you look at their thyroid function, and that is normal. And this situation, if you do this antibody and it's raised, then we clearly know that we are dealing with autoimmune disease of Graves. And the third very, very important aspect is pregnancy. And pregnancy and thyrotoxicosis is not very uncommon. And in those situations where you can't do the gold standard test, still the gold standard test is supposed to be the nuclear imaging, the technetium scan. So when you can't do that, it's contraindicated in pregnancy. And in pregnancy, this definitely is a very, very useful test, and we should be doing it. So this is just a table to compare the two tests, the thyroid scintigraphy and the trap testing. I wouldn't want you to go through all these things, but what I'm trying to show here is the gold standard in most countries, except perhaps in Western countries, is still the nuclear imaging. That is because of the lack of availability of trap testing in many places. However, where it is really, really useful is where the safety side of things. So in pregnancy, clearly you can't use scintigraphy, as I said, so definitely you need to use. The cost could be an issue because trap testing, if you have set up in a good lab, will come out much cheaper because it's a blood test, whereas you know the logistics involved in getting a patient to a nuclear scanning, getting the test done and all that. So that is another aspect. And the availability. Availability, as again the nuclear scans in cities, it might be easily available, but when you go into other places, it may not be. What is the cutoff that's used? Again, this is not very straightforward and simple, because depending on which assay you use, the cutoffs are slightly different, and it could range anything from 1.5 to 2. So if you have a value which is more than 2 international units per liter, then you're fairly convinced that this is positive. So I'm choosing my words very carefully here, because we do end up with a lot of test levels which are somewhere in between 1.5 and 2.5, and you're neither here nor there. So that can happen because the assays are still not fully refined, and there might be a lot of labs which are using the older generation assays which are not that accurate. So the typical cutoff, as I said, is it's supposed to be 1.75. A better test actually is the TSI, which is called a stimulation index, but that is not easily available in most places. So if you look at, if you order in most cities in India, or in fact for that matter, many parts of the world, what you would get as a TBIA test is the TBIA itself, not the TSI, the thyroid stimulating immunoglobulin, which is a much more accurate test. So that is one of the issues that we still have. Now, if you look at what happens to these antibodies over time, I think this is a very important slide, because this is why testing initially and then following it up, although the guidelines are still very unclear as to how you should follow it up, this kind of tells you how what is the clinical timeline of the antibodies. So if the antibody is significantly raised, you know that it's Graves' disease. But then if it starts to decline significantly, very quickly, once you start your treatment, then those patients usually remit very quickly and then stay remitted. Again, it's most, we don't have still good evidence to say that this is very accurate. This is where the issue is. This is why still the guidelines are not very clear cut as to when you should do, when you should repeat and all that. So at diagnosis, yes, if it is available, definitely you should do it. Definitely you should have a number. If at 3 to 6 months you can do one, and if you find that it's significantly declining, then you know that you're heading in the right track. With antithyroid drug itself, you might be able to sort it out. At 12 to 18 months, when you're planning to stop treatment in most of your patients on antithyroid drugs, if you find that these levels have become negative, then great. Most of these patients will remain in remission. Whereas if it is raised the other way around, they are going to relapse. And I think that is where the catch is. So the prognostication is the other aspect when it comes to it, isn't it? So if your initial titers are very high, most of these people who have very high initial titers have got a very severe disease, and there it is a very useful test. And the rapid decline side of things, I did say, once you start treatment, that is also a useful one. And negative at the end of treatment is also useful. So these three are very useful points. Very high titers in the beginning, rapid decline, and becoming negative. These three can help us titrate the treatment of these patients. I will quickly run through the lab tests. I think this is probably too much for our discussion today, but it is important for us to know that what is really making us unsure about TRAB still is the fact that the lab tests can be highly variable. Okay? There is still not good standardization across manufacturers. There are so many kits available, but the standardization is not very good. The reference ranges established again, it's not for the local population. It is for Western population or whichever population that they have done the studies on. And then dealing with interference factor. Again, there is no clarity in terms of, especially, it's a time when everybody uses biotin because everybody has hair loss. And the heterophil antibodies is a problem. So all these interferences and how they affect, again, there is no clarity around this. So currently we are in the third generation assays. So the first generation and then second and third. So third generations are much, much better and we have much better results, but we are still getting a lot of kind of borderline results in and around 2. And if you are unsure, clinically as well as with these levels, you might sometimes have to repeat it at a later time to make a decision. So it depends on your patient as well as the availability of the test and all that. See, these are the kind of kits that are available. So many of them. But what is clear here is most of these kits are TBII kits. So that is what is available across the board in most of our towns and cities. So the limitations I have said, one of the problems is 5 to 10% of GD patients might be seronegative. Okay, so that is an issue. So just because it is negative, don't think that it is not GD. Can't be 100% sure, although you have a reasonable amount of confidence. Of course, your clinical, as I said earlier, you start off with a clinical assessment, and if you have thyroid eye disease, none of these things would matter, but still it helps in terms of our treatment in the long term. And optimal testing frequency is still undefined. We don't know how that is, how we should do it, and interpretation variability is also there. Now, another important area where it is useful, I'm sorry the slides have just, I think it's probably the projection, the slides have, the font has changed, I think, so it's just projecting out. But one of the major situations where TRAB is very useful is in pregnancy and neonatal monitoring. So in pregnancy thyrotoxicosis or GD, if the TRAB is more than 3 times, then these children or these fetus will need intensive fetal surveillance. And that would involve regular ultrasounds, fetal thyroid assessment, heart rate assessment, and all that. So that is very important. Whereas if the TRAB is less than 3 times in the mother, then usually these pregnancies will go without much problem for the kids. So that it is very useful as a test there. And if it is those with very high levels of TRAB, mother with high levels of TRAB, then the clinical monitoring of these children is very important even after they are born. So there could be even a delayed onset of hyperthyroidism. So it's important that these children are monitored. So practically very, very useful test in pregnancy and in follow-up of these children. If symptomatic, many of these children might even need treatment. Fortunately, it's a very rare condition and we don't have to deal with this day in, day out. But it can be quite tricky to deal these children with antithyroid drugs, neonates is very, very tricky. The other very useful scenario is thyroid eye disease. Okay, and obviously I told you that the antibodies play a major part in the pathogenesis of thyroid eye disease by attaching to the orbitoblasts. And what has been shown again is that if you have, there are two uses here. One is in atypical cases of thyroid eye disease, where either they're presenting with unilateral proptosis, or if they have other diagnosis that you're thinking of, doing this test would be very, very useful. It is very useful for risk stratification of disease progression. So those who have very high levels, their thyroid eye disease is going to, so if you're, say, treating them with steroids, or in fact, there are now quite good evidence that those who are treated with triptotamab is one of the drugs that has been very much in the news now for thyroid eye disease. TRAB can be used as a monitoring tool for these patients on these medications. So very useful in terms of monitoring treatment. The TRAB levels could help you in those scenarios. And again, to differentiate, as I said, from things like orbital pseudotumor, lymphoma, etc., if this is positive, then you are inclining towards thyroid eye disease due to Graves. How has global practice patterns changed in terms of TRAP testing? This is currently where we are. So if you look at ATA, they would say this is a first-line test. The European Thyroid Association still goes for nuclear scanning, and they would recommend this for as selective use. So Europeans are always slower to change. Asian countries, it's really the cost that would dictate. So if you look at some of the bigger hospitals, cities, definitely a TRAP would be what they would do. So it will be very aligned to the US kind of this thing, whereas others would be doing more of the other scans. A few novel applications before I stop, where it would be useful. And what people are thinking of is that this could definitely be a test that can be used to decide on how long to treat with antithyroid drugs. So 12 to 18 months we say as a rule, but is that right, or should we be looking at this and deciding, is one of the aspects. The other thing is in terms of thyroid eye disease. I've already told in terms of medication use and how we would use that. And in terms of umbilical cord, I think that has gone off. This, I think, again, sorry that the slides are not clear here. So in terms of umbilical cord estimation, we could decide whether these children or these neonates would develop neonatal thyrotoxicosis. So TRAB levels in the umbilical cord could be tested. So that is another one. What about non-thyroid autoimmune disease? You could use this as a predictor in type 1 diabetes and autoimmune polyglandular syndrome. If they are raised, then they are at higher chance of autoimmune thyroid disease. Even in chronic urticaria and atopic diseases, it has been shown that if they are TRAP positive, they have much worse disease and have hypothyroidism kind of symptoms. So TRAP seems to have some relevance with this skin disease as well. Add to that is this current situation we are dealing quite a lot, the immune checkpoint inhibitors. We are seeing more and more patients who are using the immune checkpoint inhibitors for malignancies. There are a big group of them who develop hypothyroidism, but there is also a smaller group who develop autoimmune thyroid disease. So, and the TRAP could help us in that. I'll just stop within a minute. And another very interesting aspect is there has been studies that have shown that differentiated thyroid cancer with elevated TRAP can have a poorer prognosis. So there could even be a role in malignancy. In DTC, this could be a prognostic factor. So I'd conclude by saying that it looks as if the TRAP testing during our 10, 15, 20 years back when we were coming out of training and all that, it was not very, very much used. But it looks as if we are expanding with the understanding of this antibodies and the improvement in techniques in lab testing, it looks as if we will use this more and more in terms of not only diagnosis, but following up these patients, prognosticating, and then treating them and deciding on their treatment. So I'll stop there and take any questions. Thank you.
So please come to the mic, Ashish there. So before I throw this to the floor, I have got two quick questions to both the speakers. So Dr. Subramaniam, we have got levothyroxine absorption test for non-compliance to levothyroxine. We had something to look at it. What are the measures to find out the non-compliance to thionamide? We don't have thionamide absorption test analogous to levothyroxine test. So how to suspect in clinically?
Sir, as far as the difference between levothyroxine and thionamide is that levothyroxine, as far as absorption is concerned, there are so many factors concerned. Whereas thionamides are relatively better absorbed and interference with other drugs is minimal. That's why we don't have this problem. But as far as how do we know is the one, whether any test is there, and as far as I know, there is no test to do this. But definitely a patient's history along with the reports what we see, the FT4 and TSH will definitely give a clue to the usage of these drugs. Patient might be stopped about around 5 days back, then FT4 will go up and TSH still in the same value as before. That's what we see. And I think that's what we can see as far as absorption characteristics are concerned when compared to thionamides.
Yes. Dr. Subramaniam, thank you very much. So my next question to Dr. Arun, isn't it intriguing that two disease, hypothyroidism, anti-TPO positive, hyperthyroidism, Graves' disease, TRAB positive, the TPO's value has got nothing to do with prognosis anywhere, severity, trends changing with the drugs. TPO severity remains as it is. Regardless of the TPO value, you treat hypothyroidism as it is. In contrast, when you are looking at the TRAB, it changes with the anti-thyroid therapy. Why? Number two, is there any difference that between thionamide means carbimazole or PTU, the TRAB level changes or one is superior to each other? So you have two parts of the question to you.
I think the answer to the first question I don't have. What is a wonderful question. I mean, I have always thought of this. And in fact, even in Graves, you see quite a lot of patients who have significant positive TPO levels, isn't it? TPO and TG levels. And you see one patient who has got TPO which is raised and the other one who has got TG is raised. You can never predict which one is going to be raised. And that happens in Graves as well. So you would just then write it off as, oh, it's all a part of the autoimmune process. But I don't have an answer to that question. Why is it that when it comes to hypothyroidism caused by...
I will answer you that.
Okay,
of course, I have asked the questions.
So,
It's my duty to answer that.
Wonderful, that's great. The second part, let me then answer. So that was, sorry, what was your second part of the question?
Between the two drugs.
Yes.
So,
yes.
carbimazole
So
and
I think Subramanianji did mention about the immuno modulatory action of both of these agents to an extent. I don't think there is any difference between these agents in terms of its action, but they do, as it's not only just reducing the the thyroid hormone levels, they certainly have, and you did show some studies as well in your presentation of how they affect the T lymphocytes and the thing. So as far as I know, again, there is no difference between the agents in terms of immunosuppressive effect or immunity effects on the immunity, but PTU is supposed to have a better effect on it, isn't it?
Yeah,
Are
so
there any
that's,
studies on that?
Yeah, so that's theoretical. So, yeah, you want to say something?
As far as effect over the autoimmunity, there are no studies which have differentiated between thionamides, methimazole and PTU. But because of the side effects of PTU, especially liver failure, people have almost stopped or reduced the uses of PTU except in the first trimester of the pregnancy. You know the reasons. So that's why all the studies now going on as far as the lymphocyte infiltrate and the TRAB antibodies are with only methimazole. They are not even with carbimazole also, sir.
Yeah, so on theoretically, PTU is a more immunomodulator than CMJ. So on paper, theoretically, propylthiouracil would reduce TRAB, should have been reducing TRAB larger than carbimazole. But there is only one study done that compared the TRAB level between carbimazole and PTU and find carbimazole to be little superior. Perhaps this suggests that, you know, reduction in TRAB level is dependent upon how rapidly you change the thyroid status. And this is the explanation as to why TRAB changes while anti-TPO doesn't change. So the simple answer is that anti-TPO means it's an immunity marker of damage. Once the damage has been done, no medicine is going to change that severity. But for TRAB, it depends upon how quickly you recover the thyroid function. And therefore, once you treat thyroid disease, Graves' disease, the TRAB level comes down. So regardless of the therapy of, you know, Graves' disease, TRAB levels comes down, but not the anti-TPO.
Sir, as far as the anti-TPO is concerned, is a marker, sir.
Right,
It is not influenced by that lymphocyte infiltrate, whereas TPO is the cause and effect.
Correct.
Where the lymphocyte infiltrate will produce more amount of T TRAB, whereas the anti-TPO is not so.
True.
It is from the whole of the body by the beta cells.
Right.
B cells. So entirely the whole mechanism there is the B cells, it is T cells. T cells is the cause and effect.
Right.
That's why influencing this TRAB would influence the disease relapse and remission.
Correct.
Whereas this will not affect because already B cells are already what you call memorized and they are producing anti-TPO.
Right.
That's why their production will not change with whatever you do in the treatment.
Correct. This is what exactly I said.
Sir, thank you, sorry. I'm repeating the same.
Please. Yeah.
In some situation, particularly the elderly patients, without any telltale sign of, the Graves' disease. The patient may land up into silent thyroid storm without any premonitory symptoms. This is a sort of apathetic thyrotoxicosis. If we don't have any high index of suspicion, the diagnosis is sadly missed, and down the line, patient merges into silent coma and death. So these patients should be tested for TSH receptor antibody because they frequently present with cardiac symptoms like atrial fibrillation, cardiac failure. So no sort of the Graves' disease eye sign or tremor or hyperkinetic circulation, etc. This is one area where TSH receptor antibody testing is very, very crucial so that we do not lose the patient, number one. Secondly, in pregnancy, sometimes the hypermesis gravidarum or gestational thyrotoxicosis poses a knotty problem, nagging problem. Of course, it is a self-resolving issue, but still the problem is a nagging and sort of nightmare for the physician endocrinologist initially. In that perspective, TSH receptor antibody will give us a clue that it is not going
to differentiate between gestational thyrotoxicosis versus
think it's a
Graves'
point
disease. We
I
got your
probably
point,
didn't
sir.
highlight. And again, the last one, as Abdesh was trying to point
That
out,
is absolutely true, sir. Yeah.
anti-TPO antibody, some entity is there, the hacetoxicosis. Initially, they have only high sort of antibody, anti-TPO. And down the line, they do develop high TSH receptor antibody. And there the Hashimoto's thyroiditis merges into hacetoxicosis. So these are the sort of...
So usually in Hashimoto's, it's the transient rise in TRAP is possible. It does happen.
I have a simple question.
But,
To ensure compliance in a case of hypothyroidism, can you give 20 milligram once a day instead of dividing the doses?
So that is there, sir. When especially you are using carbimazole, we use 20 milligrams at a time. But more than 20 milligrams is not advised as far as carbimazole is concerned. Whereas methimazole, they advise not more than 20 milligrams. But most of the times, our availability of the tablet is 10 milligrams only. So we use it 1 BD. But I don't know whether we can give 3 tablets of 10 milligrams at a time. I think I don't have any.
So there is a head-to-head study that compared once daily dose of Numarcazole versus twice daily dose of Numarcazole versus 3 doses of Numarcazole. And this study find 3 dose has got no meaning. So either you can use once daily. So say if you are giving 20 milligram, as Dr. Subramaniam said, 2 tablets at bedtime. If you need further increment the dose, then you add 1 tablet after breakfast or 2 tablets after breakfast. But there is no data that suggests giving a 10 TDS, which is very common, by the physician. Is not at all.
40 milligrams, whether we can give it same one time, so we don't know, sir. No data is available.
There is just slight addition to what Dr. Aiki Singh has said, that there is some data that especially when the patient is frankly thyrotoxic in the initial part, theoretically and some small studies have shown that divided doses because of the increased turnover of the drug, there is some theoretical benefit of dividing the dose. Otherwise, once it's stable, it doesn't matter you divide it or don't divide it. It's in fact to ensure the compliance, it's better to give once a day kind of a dosage.
Correct. Yeah, so last from the floor.
Okay, one is that we had about 104 cases of Graves' disease, and that time TRAP was not available, and we did anti-TPO antibody. 56% of Graves' disease did have positive anti-TPO. Number 2 is that why these changes are occurring is basically because of the double pathology going on within the thyroid. There is a portion which shows lymphocytic infiltrate, picture of Hashimoto's. At the same time, the other side is showing picture of Graves' disease. And how I came to know was that when we started Graves' disease, all those who had gone into remission after a year or some 8 months, we did FNAC. I didn't tell the cytopathologist what was the condition. the previous report and this. And most of them, in fact, all of them, those who went into remission, turned out to be frank Hashimoto's thyroiditis. So basically, it's a double pathology like he was mentioning that could be the reason for these changing of TRAB, whether that process is more or not. This is just an experience that I was wanting to share.
Thank you, sir.
Just one last question, sir. Maybe it's useful for everyone. So it's to Dr. Menon. Sir, at what level, after completion of 18 months or so of thianomides, at what level of TRAB actually we decides to stop? Because now there is a concept of giving long-term antithyroid drugs. So at what level of TRAB you want to stop the drug? Is it just normalization, or will you add something to that?
I think there is no clarity on this. It is normalization that has been said. There is again no clear cutoff that has been given. So, and even in those who are negative, if you stop it, there is still a small chance that it can recur. So that is there. Because once you stop, maybe this immunomodulatory effect goes off, and maybe these people will recur. But the other way around, if it is raised, that is where it is really useful. So there is no point really in stopping the medicine at that point.
And it should not be, because the moment you start the treatment, it will stop going down.
Yeah.
So at some point of time, when the thyroid function becomes euthyroid, you are bound to get a TRAB level to nearly normal. That should not declare us to stop the drug because TRAB has come to normal. Because it's a drug dose dependent reduction in the TRAB. So we can't stop the drug based on the TRAB.
So it means that it doesn't have a role in when to decide or when to stop the drug. I will add, there is some recent data again published in JCMs where the chances of recurrence with a normal TRAB, which was supposed to be one of the marker that we use to decide to stop the drug, at least the chances of relapse are less. Almost 60% actually relapsed with the normal TRABs. However, they try to do statistical analysis, and what they have found out that that level of 0.9, that is where the long-term remission rate is more than 85%. So they specifically mentioned rather than waiting for normalization, you continue the drug, low-dose drug, and wait the TRAB to go down below 0.9. 0.9 is the cutoff they have recommended,
I think
with
other
85% of
points,
long-term remission.
Other clinical points which are important is the thyroid size. If somebody has reduction in the thyroid size, the relapse rate is very good. And the other one is the rapidity with which the PT4 gets normalized. For example, it gets normalized within 5 days or 6 days, PT4 I'm telling. Then the chances of relapse is, remission is very good when compared to FT4, which is going slowly down over a 1 month or so. So this is another study which showed this point also. Please, sir.
I will take the last comment, please. NT-TPO?
No, sir, no role,
Not at
sir.
all. No, answer is no.
It's only for diagnosis.
So NT-TPO's importance remains a stick to the pregnancy. In a non-pregnant state, based on the NT-TPO, we don't do anything. But somebody has got NT-TPO positivity in pregnancy, then we have got a certain threshold of TSH by defining subclinical hypothyroidism, whether to go for treatment or not. So the NT-TPO's importance stuck to the pregnancy only, otherwise no value. So right, so right.
Sir, it's a long way, sir. So Hashimoto's thyroiditis, it can be initially, as sir suggested, it can be toxicosis, then euthyroid, then hypothyroidism. Very less chances of again becoming toxic because of fibrosis and almost becoming less. Whereas Graves, most of the time, sir, once we start treatment, according to the grade score, we have the chances, and only 60% only remit. Remaining patients still they will be euthyroid on treatment only. Once we stop the treatment, patient will have relapse. Burnt out Graves, yes, sir. Burnt out Graves is the one what we are talking about, sir. When we start treatment, on its own after some time, the autoimmune process completely reverses, or the TRAB antibodies which are stimulatory will become a blocking antibody, sir. So that is another possibility, sir.
So thank you very much. Give a big round of applause to all the speakers that generated so many questions. Organizer is hinting me to close the session. So thank you very much, both the speakers. Thank you very much. And thank you all the delegates for active participation. Okay, you are the organizer, yeah.
Last question, as you have said, do you measure stimulating and blocking traps? Do you have access to measure?
No, we have trap only. Mostly we expect it to be stimulated.
Yes.
We assume that it is stimulating, we don't know. We don't know.
Human body is the best test.
Right.
If it is
Clinical, still listening.
stimulating, it's
Absolutely.